post-operatively. Very important is the tricot and the wound, the tricot-assisted vitrectomy if there is a vitreous in the anterior chamber, leaving the patient, and ultimately 618 and N10. Detailed post-operative examination anterior and posterior chamber in every traumatic cataract, planning backup of devices, intraocular lenses, strategies and techniques, respecting the traumatized tissue and reviving the tissue to rehabilitate as much as possible, and multiple stage procedures if a single procedure is not possible, and special management of control of infection and inflammation. And above all, God is there to help. Thank you very much for your patient presence.
Thank you very much, sir. So please come in the center, sir. I'll request all the chairpersons to please come in the center to confer this oration award. I'll request our treasurer, Dr. Pratul Tyagi, to please put a turban, our traditional turban. I'll request Dr. Sandeep Vijay to please put a shawl, a secretary of ROS. I'll read out the oration plaque. Rajasthan Ophthalmological Society is honored to bestow Dr. R.G. Sharma Memorial Oration 2022 on Dr. Partha Biswas in recognition of his exemplary innovations in the field of ophthalmology. We also acknowledge his outstanding contribution in ophthalmology as researcher, innovator, and a great teacher. Roscon 2022, Kota, 44th Annual Conference of Rajasthan Ophthalmological Society, signed by President, Secretary, and Chairman Scientific. I'll request President Dr. Kanjolia sir and Dr. R.K. Sharma sir to please give away this oration plaque. So please, aye. Thank you so much, sir. So Dr. Partha had a very long Europe travel plan just few days back, and he did a lot of adjustment to be here and to give away this oration award. We are really honored and thankful to you, sir. Thank you so much. That's all. Thank you, sir. So now I think we'll have a break of 15-20 minutes for lunch. And after that, we'll start the live surgery session. I'll request all of you to please come quickly. And we'll be having so one more plaque. Yes, yes, yes. ये भी दे दो बेटा. Sir. हाँ नहीं ठीक है. हाँ. Pleasure to have photo with you.
आरुण कम से कम फोटो के लिए आ जा. कम से कम फोटो के लिए आ जा. I think I'm welcoming you to Utah. Arun, फोटो हो गया.
रोलिका
One,
Check, hello. DC,
hello. Hello, 1, 2, 1, 1, DC.
hello DC.
Hello, test 1, 2, DC.
Rupesh,
Hello, echo हो रहा है? Hello, test.
hello
Hello,
DC.
DC.
Hello,
DC. DC.
hello,
Hello.
hello DC.
हेलो हेलो
Check on. Hello. Hello.
हेलो डीसी।
आवाज आ रही है मेरी?
हाँ तेरी तुम्हारी तो आ ही रही है, हमारी ऑडियो चेक करो यार।
हाँ, आ रही है, आ रही है, आ रही है।
कम करो कम करो।
1 2 3 4
हाँ बोलो।
मेरी
हेलो
आवाज कम करूं?
1 2 3 4 डीसी
एक मिनट
हाँ
डीसी,
जी।
इससे बात
मेरा
करो।
ऑडियो आ रहा है?
जी आ रहा है। चेक चेक मैं चेक
ये
टेस्टिंग।
फेस माइक की
ये
ऑडियो क्लियर
दूसरे
है ना?
माइक बंद करो
हेलो।
ना, एक माइक से चेक करो ना। राकेश।
हेलो हेलो चेक हेलो।
हाँ डीसी, ये अतुल अतुल बात कर पोडियम से।
हेलो।
हेलो चेक। यस
हाँ
सर।
ठीक है। इंदर से बात करो, इंदर का वीडियो मिल रहा है।
अतुल,
हाँ भाई।
मेरी आवाज क्लियर है?
सर थोड़ा सा लेवल बढ़ा दो, थोड़ा दब
1
रही है
2
आवाज।
3 4 5
हाँ?
6
हेलो
1 2
बस
हाँ
हल्का सा कम।
1 2 3 4 5 6
ठीक है सर,
7 8
इतना ठीक है।
ठीक है अतुल?
फेस के पास तो माइक नहीं है ना?
नहीं नहीं,
ठीक है, एक मिनट लाइव फीड डाल देना इस पे।
माइक्रोस्कोप ऑन कर दो यार, वो चेक कर।
चेक।
चेक 1 1 चेक साउंड चेक।
ये फेस
हेलो,
माइक है, लेपल माइक है?
ये फेस माइक है।
ठीक है,
ठीक है ना?
एकदम ओके रिपोर्ट है।
ठीक है, लेपल चेक कर रहा हूँ मैं।
हम्म।
डीसी इंदर, बेटा वो चेक करना जरा, इनका माइक्रोस्कोप क्यों नहीं आ रहा, दूसरा
करो,
वाला।
आवाज कम करो उनकी, बंद मत करो।
हेलो हेलो डीसी, हेलो चेक
ठीक है
चेक।
ठीक है ठीक है इंदर।
ठीक है चलो।
हाँ, उनका ऑडियो मिल रहा है ना तुम्हें इंदर?
हाँ
ठीक।
लेकिन तेरे इसमें भी तो आना चाहिए ना, इसमें तो नहीं आ रहा, मैं मेरा बेइज्जती कर रहा हूँ, इसको आ ही नहीं रहा यार। सही तो जगह लगाया मैंने लेकिन आ नहीं रहा।
लास्ट में क्या हो गया, बार ग्रुप पे डाला जा रहा है, क्या दिक्कत हो गई यार?
ग्रुप में मत डालो ये सब चीजें।
क्या दिक्कत है? क्या दिक्कत है? ग्रुप में क्या डाल दिया? कुछ पता नहीं
आ गया।
यार।
आ गया, अभी नहीं आया था, अभी आ गया, अभी क्या आ गया।
ऑडियो ऑडियो क्या लगे सर? ऑडियो तो क्या होगा?
हाँ दोनों डाल रहा हूँ मैं।
ये कौन सा बंदा बंसी है? भाई ऑडियो में है क्या वो? क्या बोल रहा है? क्या बोलना चाह रहा है?
अभी लगा देना यार।
ऑडियो क्या हो गया भाई? क्या नहीं आ रहा ऑडियो का?
पता नहीं क्या
आंसर डाल रहे हैं ऑडियो का। हैं?
टेप भी है, कहाँ के टेप है?
माइक बंद करो ना यार। ओए माइक तेरा बंद करना।
ये आ रहा है देखिए। आवाज होगा तब तेज करियो, ठीक है?
Check, hello. Hello, check. Hello, check.
मेरी बात सुन, वहीं से सुन ले भाई, वहीं से सुन। ये हमारा टेक्शन सही है, वहां का कोई नेटवर्क का इशू पड़ रहा है, बार बार लाल पड़ रहा है। चेक करा देखिए, तो खुद और चेक करा देखिए।
Check, hello. Hello, check.
मेरा जा रहा है, ठीक है? मेरा वो दोनों चीज ओके है मेरा। सबके सब अपने वाले ग्रुप में डालो ना, उसको तो डाल दो।
Check 1, 2, check.
वहां पे दो मुझे, ओटी में दो एक बार। हेलो, डॉक्टर सुरेश पांडे। ओटी से फीड है इसमें?
हेलो
हेलो
हेलो हेलो
यस, डॉक्टर
Yes, sir.
सुरेश पांडे।
सर अभी प्रिपरेशन चल रही है, अभी बात कराता हूँ आपकी डॉक्टर सुरेश से।
नहीं, हाउ मच टाइम इज टू स्टार्ट द ओटी?
वेट सर, मैं बताता हूँ आपको। सुरेश आए?
Hello.
हेलो
इसका तो नहीं आ रहा।
हेलो।
Yes, sir. I am from here, from the Life Surgery Center, Suvi Hospital. We are just reading the entropion, and Dr. Mukesh Sharma will be operating the entropion case. Can you hear me in the hall there?
Yeah. The hall
Okay.
is ready with the transmission.
Yeah. Good afternoon. I think you can see Dr. Mukesh Sharma.
Yeah, I can see. So I welcome all the delegates after a beautiful lunch. Now we are going to start the live surgeries, and I would like to invite the panelists for this session, Dr. Saurabh Bhargav, Dr. Vaishali Vasavada, Dr. Neeraj Shah, Dr. Anil Kothari, and Dr. Mahesh Punjabi. So please be on the dais. Mukesh sir, can you hear me?
Yes, I can very well hear you. So tell us when you want us to start.
Sir, you can start.
Okay, fine. So this is a case lower lid senile entropion, spastic entropion of lower lid. We have already injected xylocaine. So you are not right now seeing the entropion, but can we switch over the view to the mobile? We have taken PIC pre-operatively. So I think you have to see it in a few seconds only. So that was the pre-operative video. You can see entropion of this particular patient right eye, and lid laxity is equal in both the eyes. So this is very important. Had there been more horizontal lid laxity in this particular eye, then we would have chosen the lateral tarsal strip, LTS, for this. Since the laxity is equal in both the eyes, so we are going for tightening of lower lid retractors, so or plication of lower lid. So this is the surgery which we shall be doing it. So with this introduction, I am starting. Give me the 4 sutures. 40 सिर्फ lid suture दे दो, skin suture दे दो, कुछ ये नहीं ना. All right. So first I want to pass stay sutures for lower lid, just to have good traction on the lower lid. After that, marker देना मुझे. I will be marking it around 4 millimeter from lash margin. Can I have another marker? So roughly around 4 millimeter from lash margin, we make the incision. मेरे को कैलिपर भी देना 4 millimeter करके. So this is the 4 millimeter, and this is at the same place which I have marked. So with graying here, you can have some idea about the millimeter scale also. So it is at the right place. Okay, so have we received the 40 और stay suture? Thread दे दो मुझे, thread suture दे दीजिए, superior rectus वाला. It's a beautiful OT operative setup is great here. I am operating on a Leica microscope. We all know that it's damn difficult to arrange live surgeries. There are too many cases, too many people inside the OT, too many machines. But in spite of that, we are able to find out the things. And I am just asking them to give me stay sutures. Nowadays, nobody uses these sutures in cataract surgeries, so it is taking some time to find out one. All right, so we have received, I think, the ethibond. So I will be passing it one in the center. Anytime if somebody wants to ask me something, I will be happy to answer that. So I will be passing 3 such sutures. इसको पकड़ लो थोड़ा सा. एक और भी चाहिएगा, सूचर और चाहिएगा एक थोड़ा. आपको दर्द तो नहीं हो रहा है? So in today's era, we only get, mostly we get lower lid entropion only. Nowadays, it is very difficult to get patients of upper lid cicatricial ectropion, which during our residency days we used to get a lot because of trachoma, but nowadays incidence of trachoma is gone down to that extent. So these are the stay sutures which we have passed. Now spatula, ointment लगवा लो. Xylocaine paracaine डालना है आई में. I am asking them to inspect. कि इसका XY नहीं चल रहा है. दे दो spatula please. I am sorry for this delay, but इसको पकड़ना पड़ेगा आपको. ये ऐसे पकड़ लीजिए. मेरे को 11 नंबर सर्जिकल नाइफ दे दो, ब्लेड. So now I will be making my incision. So it's a scratch incision on the lower lid, not too deep. I can use here cautery also, but we have got Elman cautery here, but since it is not readily available, so I will be performing my surgery with the help of normal instruments only. So this is the incision which we have made. मेरे को थोड़ा सा मोटे वाला टूथ देना. 1 2 3 4 है. और सीजर्स एक यहाँ पे स्वैप करना होगा. So I will be briefly reminding you about the anatomy of lid. This is the skin. Below the skin there is orbicularis. So right now I am cutting the orbicularis. So this is the orbicularis which I am cutting. And below orbicularis we shall be having orbital septum. Underneath the septum there is fat. And below septum and below fat there will be capsulopapillary palpebral fascia, which is the analog of levator aponeurosis in lower lid. This is also known as lower lid retractor. So I have reached on to the lower lid retractor or capsulopalpebral fascia. So I'll be just give me another one tooth. Take out one tooth. Hai na? So this is the skin. Clean karna hai. This is orbicularis. This is orbicularis. And this is thinned out orbital septum. This white degenerate orbital septum which is thinned out, and this is the fat which is found underneath the orbital septum. So I will be plicating this part which is capsulopalpebral fascia. एक बार मुझे corneal scleral और दे दीजिए. Corneal scleral सीजर देना. एक जना और आगे होना चाहिए ना आप में से. So I am just undermining little more of tissue. Clean करो. अब मेरे को एक और फोर्सेप्स है ना. So just to revise it, this is skin. Then we have got orbital septum. Oh, sorry, orbicularis. Underneath the skin there is orbicularis. Clean karo. Underneath the orbicularis there is orbital septum. This part is orbital septum. And underneath orbital septum is fat. This particular patient, since it's a senile patient, this is degenerated, but you can see some amount of degenerated fat. And this whitish thing is capsulopalpebral fascia. So I'll be simply plicating it like this, like this, and we'll have entropion correction. Before that, I am just removing some part of skin. Then I will scissor, cannot. वो दे दो जो बड़ी वाली नॉर्मल. हाँ ये दे दो. So what I am doing is I am just making a paracentral cut, and I will be removing elliptical part of skin on both the sides. So clean करना है. ऐसे pull करो इसको हाथ से. क्लीन करो. एक जना इधर होना चाहिए बेटा क्लीन करने के लिए. एक बार छोड़ो. ऐसे पकड़ो. इसको पकड़ो. आप पकड़ो. आप क्लीन करना है. गुड. अब इसको ऐसे स्ट्रेच करो.
Actually, it's very commendable. Dr. Mukesh Sharma has come in at the last minute and with new assistants and new instruments. So it's a beautiful demonstration of the plication of the lower lid retractors.
So I have removed the elliptical part of skin. So, ऐसे पकड़ो. All right. तो अब मुझको वो डेस्मा से रिट्रैक्टर है ना, लिड रिट्रैक्टर. आप स्वाब मत करो. स्वाब आपको करना है. आप ये दोनों पकड़ लो. तो ऐसे पकड़ लो. I have removed the spatula. इनको सेंटर में ऐसे इसको इस हाथ से पकड़ो. So now I will be plicating. मेरे को सूचना चाहिए. वाइकल दे दीजिए. 60 वाइकल. ये रहा दो. निडल होल्डर. So I hope things are clear there in the hall. यहाँ थोड़ा सा साफ करना.
Yes, sir. Your audio, video, everything is perfect.
Is the voice audible from here in the hall?
Yes, it's audible. Absolutely. The audio as well as the video.
or any sign of people are there in the hall? No sound, no voice.
Can
Somebody
someone
is-
from the hall speak
They're
up?
all engrossed seeing your surgery. They're all concentrating on the surgery.
All right. So I am plicating this capsulopalpable fascia. So I have passed 6-vicryl from bottom end. Roughly around 4 millimeter of tissue I will be taking. So this is around 4 millimeter. Clean karna beta. Yeah. Good. So now I will be passing needle again, and this needle ab chhod do isko, upar wale ko chhod do. I will be taking from the tarsus and orbicularis. So I have taken this bite deep, tarsus, orbicularis, and I have come out. So when I will tightening the suture, this part of capsulopalpable fascia would be plicated. So just to see the correction, I will be passing a temporary knot. Chhod do, ye bhi chhod do. So this is good. Chhod do isko. So for me, this correction is good. Lid has come out. We should not be overdoing it also, otherwise there will be ectropion. And especially for the medial suture, we should be more careful, because if we develop ectropion in medial part, then patient will have epiphora. काटना है ना यहाँ से काट दो, हाँ यहाँ से काट दो, लो पकड़ना है, एक पकड़ लो. So I'll be passing 3 such sutures, 1 in the center, 2 on either side, and then tightening it. So clean करो, needle holder को clean करो.
Dr. Mukesh,
Yeah.
how you identify this capsulopalpable fascia?
Clean करो.
Hmm.
Clean करो. Yes, sir. Actually, I wanted that somebody should ask something. So thank you for that. So when we describe anatomy of lower lid, there is a skin, then orbicularis, then there is orbital septum. This part is orbital septum thinned out. Underneath the orbital septum is fat. This is degenerated fat, and underneath fat is capsulopalpable fascia. So this is capsulopalpable fascia. There are some vessels which are there in capsulopalpable fascia. And when we ask patient to close the lid, आँख बंद करना है जोर से, then there is some tuck which is felt there. So now I will be passing 2 more such sutures in capsulopalpable fascia, 1 on lateral aspect, around 4 to 5 millimeter of capsulopalpable fascia will be plicated. So 1 bite, another bite after 5 millimeter or so, then it is taken through the orbicularis and tarsus, and I have come out here.
These are all double arm sutures, right?
These are not double arm sutures, these are single arm sutures, because we don't need to pass it twice. दूसरा और देना, एक और suture जो था. But I have not tightened them, because if I tighten one suture, I will not be getting exposure to find out capsulopalpable fascia. So first I am passing, thread को वापस. I am passing all 3 sutures, and then I will tighten them together. So I hope this point is clear. I am just passed it. Initially I have checked by passing a temporary loop, tightening a temporary loop. That was sufficient for me. Again I had released that, and now I am passing 2 more sutures on either aspect. So this is done. So I have passed all 3 sutures. Now I will be tightening them one by one. अब इसको छोड़ दो. So I have done that. ये upper lid को पकड़ो थोड़ा सा. Yes. So when patient looks up and down, there is stuck on the capsulopalpable fascia. So you काटो इसको.
Which block you have given, Dr. Mukesh?
Pardon?
Which block you have given?
Block. block, it is infiltrator block in the lower lid and also infraorbital block. So infraorbital block is given here around 1 centimeter below the infraorbital margin. There is infraorbital foramen. We inject right over the foramen because infraorbital nerves come out through that. So इसको ऐसे pull करो. So I am tightening those sutures. काट दो. Clean करो. So I am pulling out those sutures now. So the medial suture was crucial. Yeah, clean karo. There should not be overcorrection medially. Otherwise, there is ectropion of puncta and patient can have watering later on. So we should not be overdoing, especially at medial end. So this is the last.
Does it differ in the upper lid or you follow same procedure?
Sir, I did not hear you. Can you repeat the question?
Does it differ in the upper lid?
Entropion?
Yeah.
Yes, sir. For a upper lid, we need to do wedge resection. We cannot go up to the upper lid retractor, which is levator muscle. So if we do anything on the levator muscle, so there will be gross contour problems. So what we do is we remove one wedge of skin, tarsus and orbicularis. Skin orbicularis, and also we include tarsus plate, partial thickness of tarsus plate. Please can you keep quiet, please? Yeah. So that's how upper lid entropy differs from lower lid, and also we do the tarsus fracture, which is age-old technique, and I think people from senior persons, they know a lot about that, but subsequent generations, they have forgot about tarsus fracture because now we hardly see the entropion. So I'll be passing one. Now we need to the. So if we are ready with the table, they can switch over the microscope, or else we can continue talking.
Mukesh, it's a wonderful surgery, totally avascular.
Thank you, sir.
It seems the correction has already been done.
Yeah.
Patient looks very good.
Skin
how we will do a closer? Just if they shift the microscope, just tell us how the closer will be done.
Okay, sir. Closer is done by the interrupted sutures only.
Yes.
Because in elderly persons, if we do subcuticular suturing there, then there is some time bunching up of effect. So it's better to pass interrupted suture in elderly person. Had the person being young, then definitely subcuticular suturing is one option.
You will use Vicryl, same sutures?
No, sir. Generally, we prefer proline. I don't know what is available here because proline does not produce any reaction on the skin. So there are no needle marks with proline and no skin reaction. So for skin, proline is preferred, but Vicryl also good enough. So they have given me Vicryl. That's also fine because in lid area hardly there is any scarring with 6-0 Vicryl also. But when we talk of ideal, then ideal is proline.
And sir, sorry to ask a little ignorant question, but what would be the endpoint in terms of the lid margin? Would you aim for
actually,
correction or under correction?
That's very important, and that's the final deciding point. As I told you initially, we should not be overdoing it. So it's just correction. Lid lash margin should be outward, and there should not be any eversion of the puncta. Because right now we have injected xylocaine. Post-operatively, patient will have more correction than what we are seeing now, because the effect of xylocaine infiltration will go away. So there should not be any time gross eversion of eyelid. Otherwise, post-operatively will have gross overcorrection. If at all you get overcorrection, then we do suture removal early at 5 days or so. 5 to 6 days. If there is no overcorrection, adequate correction is there, then we do suture removal at 7 to 8 days. So that's the strategy which we follow for this.
Even with Vicryl, you remove the suture, Mukesh?
Yeah, yes, sir. Because if we leave Vicryl, there is some scarring. So for skin, if we are having Vicryl outside, then we should remove it. If we have used Vicryl for subcuticular region, काट दो, skin की तरह काट देना, थोड़ा सा बड़ा, थोड़ा बड़ा. Then we can leave it.
Change the mic, please.
Turn
That
करो.
was an excellent surgery and Dr. Mukesh has done so much. Was available here and the next.
May we know the second case on the other table? Details of the second case.
The next case is anti-VEGF injection to be done by Dr.
Ma'am, you are not here, not audible. Dr. Vidurchi?
Yeah, the next, am I audible now?
Yes, yes. Yeah.
The next case is anti-VEGF injection. This is in a patient who had right eye pseudophakia with subfoveal CNVM with IRF and left
इसी को दोनों में divide कर दें.
nucleus sclerosis
कर
grade 2 with
सकते हैं.
cortical cataract, and Dr. Ajay Arora will be doing this. So I'll just be showing you the OCT picture as well. ये इसको दिखा दो भैया.
So can I talk?
Yeah, yes, you can talk. This mic doesn't work inside, so I'm showing.
Yeah. So, am I audible? This is Dr.
Yes,
Ajay
sir.
Arora from the second station. So this
Yes,
is
sir.
a patient
Very
whose
audible to us.
OCT picture is being shown. Can you see the OCT picture?
Yes.
So this patient has got a subfoveal choroidal neovascular membrane. It's a fibrovascular PED, and there is intraretinal fluid in the, madam, you can show the OCT picture, I'll explain. So there is intraretinal fluid and his vision in this eye is 6/60. The other eye, he's pseudophakic in this eye and he's received 3 injections of ranibizumab earlier. The last injection was in August 2022. And we are planning to give an injection aflibercept, which is Eylea. So what our purpose of demonstrating here was to show that now this is under topical anesthesia. So I'm going to show you something which I talked to you earlier. वो device दिखाओ जरा. So one we can measure with the caliper. ये जो खुले हुए devices. ये जो दिखा दो device. So can you see my device here? Is it visible?
Microscopic view is not visible. Yes, now it is visible.
Can you see the? So this is a device. You can see here that there is a hole here and there is a platform. This hole is made in such a manner that it is angulated. So when I put in a needle, which I'll show you here, so when I put in a needle through this, you will see that now it is just hanging. I'm not even holding the needle. So I cannot, with this needle, I can neither go anteriorly nor posteriorly, which basically means that if it was a phakic eye, I can never ever damage the lens. So what this does, this has got a sawtooth on this undersurface. Saline डालो cornea पे. So when the patient is moving, it is very difficult. This patient is very cooperative. So I can do it in the upper temporal, upper nasal. We have to choose an area which is relatively avascular. So supposing I hold this in my left hand, I can fix the device here and inject. दूसरा device दिखाओ. The other alternative is a second type of device, which again can be used. We can inject it here, and you see this gap in the middle. This gap can be utilized for doing paracentesis.
Sir, could you please center the microscope more towards you?
Okay.
Please do the fine focusing also.
No, other way around, sir. Other way around.
Other way.
Little more, sir. This
Yes.
looks very good.
Okay.
It is
Little
centered now.
fine focusing.
I'll do that.
It looks very good, sir, now.
Is it visible? Can I
Yes,
go
sir.
ahead?
It's better now.
This is good.
So I'll go ahead and inject. So we fixate the globe. I know that this area is, and I have already calculated the amount of drug to be injected. We go inside, touch the eye, and we give a slight rotatory movement. So at this time, I can see the needle inside. You can see the needle inside. I'm going to gradually inject. The injection has been done.
Sir, which injection you are using?
This
Which
is
antibody?
injection aflibercept. Then I come out. I keep holding. So I keep holding for some time. Give me a bud. So we keep holding for a little while. This will ensure that there's no bleeding. There's no egress of fluid.
I hope you are using 30 gauge needle.
It's a 30 gauge needle, sir.
So,
So now I come out, you see that there is no mark, there is no bleeding, there is no egress. We touch it with the betadine and the whole procedure is done. At the end of the surgery, we ensure that we put antibiotic drops. ये क्या है? हाँ? हाँ? Vigamox, okay. आप वॉश कर दीजिए. So आप ठीक हैं सर? इंजेक्शन लग गया है, कोई दिक्कत तो नहीं है. At the end of it, just show me. You must try, make sure that you have checked the intraocular pressure. So we see the pressure is fine. That you don't have to do paracentesis because invariably the intraocular pressure rises during the first 2 minutes. After that, the pressure starts dropping down. So in case the pressure is higher, with the same device, I can go in with a 30 gauge needle with the piston removed and do paracentesis. That way the patient doesn't move the eye and I'm able to do paracentesis. So this device can be used for all the injections, including intravitreal injections for endophthalmitis, which I demonstrated in the morning. We'll be doing another injection subsequently, and I'll discuss more about the device and show you how it helps you in preventing any damage to the lens as well as to the retina. Any questions, I'm happy to answer.
It's always better to ask the patient after the injection whether he can perceive light or not.
That's true. So it's very important because many ophthalmologists, you don't need a caliper here. You don't need any fixation device. You do not, the eye is fixed and you are able to inject and it's a beveled incision. So there's no leakage.
It seems to be a very useful one. Very useful.
It's a very innovative device, sir.
It's available commercially.
Yeah, it's available in Epsilon. There's a new version which is going to come out very soon, which will also have 2 ports. So one which is at 4 millimeters and one which will be at 3 millimeters, so that different patients, it can be used, whichever port you want, it can be used comfortably. Right. Thank you very much.
Thank you, sir, for the innovative demonstration.
Thank you for the nice presentation. Can you switch over for the next surgery?
The problem with Eylea is that they don't supply the needle and syringe. So somehow if some mishap happens, then they are clear of the scene. It's not our needle and our syringe. That's the main problem with Eylea.
They put the liability on the syringe and needle.
One who was charging 55,000 for injection can't spend another 5 rupees or 10 rupees on a 30 gauge needle and syringe. That's the problem, main problem. Despite my repeated reminders to them, they are still continue with the same practice.
Meanwhile, Khilnani sir, please throw light on different molecules of anti-VEGF which recently came into the market, including Eylea, this Pegamax, and newer versions of these molecules.
Well, we all started with Avastin, that is bevacizumab.
I'm Am I audible?
Yes, you are audible.
Yeah, I'm Dr. Suresh Pandey. I want to ask Dr. Ajay Arora, who has invented many devices and he has filed many patents. Can you briefly convey about your invention and about your patent?
So, sir, my first device was what is called as ANT, which is known as the Aurora Needle Trocar Canal System, which was awarded the 2015 BMJ Southeast Asia Innovation Award amongst the 7 countries of Southeast Asia, which actually can be used for all gauges, 20 gauge, 23 gauge, 25 gauge, 27 gauge. And we just need an appropriate needle and the device, it is autoclavable. Then we have this device which is called the FIG, Aurora FIG, which is a fixation and an intravitreal injection device, which I just demonstrated. Then we have other devices like a suprachoroidal injection device. We also have a special sclerotomy closure device and a device which is used for locating the peripheral brake. So many of you who are anterior segment surgeons may not be aware of it. And then there are other smaller innovations which are in the pipeline, which we'll be discussing in future. I have recently come up with an automated injection for the subretinal injections, especially TPA and taking subretinal biopsies, which again will be showing up, which can be connected to your vitrectomy machine.
Thank you very much, Dr. Ajay Arora, sir, for wonderful demonstration of the technique of intravitreal injection. And the next case will be done by Dr. Seetal. And Dr. Seetal is a cornea surgeon who is working at Ahmedabad. And Dr. Seetal is doing corneal cases, pterygium cases, cataract cases, and she has been trained from LV Prasad Eye Institute. And Dr. Seetal will be using the conjunctival autograft with fibrin glue. Thank you. If you have any question, Dr. Arora will be happy to answer. Meanwhile, the case is getting ready.
So my aim was showing this intravitreal injection is a very simple this thing, but it is one of the commonest procedure used at par with cataract surgery, and lot of ophthalmologists all over the country are already using my device. So I actually get feedback from people saying कि डॉक्टर साहब इससे तो हमारा बहुत फायदा हो गया, अब हमको कैलिपर यूज नहीं करना पड़ता, we are not afraid of causing a lens damage. So I would encourage people to be aware of the dynamics. You don't have to use my device, but you must be sure that you inject in the right direction. You make sure that there is no egress of fluid, and you take all the precautions so that we can give safe intravitreal injection to our patients.
What is the
That's
cost?
very excellent message, Dr. Ajay. You have,
Dr. Pandey sir, Dr.
Yes.
Madhu Mathur madam want to ask a question.
What is the cost of the instrument?
I got it. I don't think it's quite expensive. जो मेरा जहाँ तक idea है, it doesn't cost anything more than 1,800 or 2,000 rupees, ma'am.
Okay, thank you, sir.
That's very important aspect in India, where you are the price, it's price sensitive market. And any other question for Dr. Ajay Arora? Now we have Dr. Harshul Tak. We welcome Dr. Harshul Tak, who is the chairman scientific committee, and under his leadership, the excellent program has been framed. And congratulations, Dr. Harshul, for the wonderful ROS Roscon program you have put together. And now I will hand over mic to Dr. Harshul.
Thank you so much, Dr. Pandey.
Next case.
इंसुलिन 2 cc
Which one is the next case?
हाँ हाँ दोनों निकालना हाँ मैं दे दूँ
Can you hear me, Dr. Sandeep?
Yes, sir, we can hear you very well.
Okay, Dr. Vaishali. So next case is going to be pterygium surgery with autografting by Dr. Sheetal. And we all know Dr. Sheetal is an amazing cataract and corneal and refractive surgeon from Ahmedabad, Vaishali's own place. And she'll be demonstrating autografting in a case of pterygium with fibrin glue. So thank you so much, Dr. Ajay Arora, sir, for sparing time and demonstrating the intravitreal injection, the correct technique of it. Can we have the hall view here? So after this pterygium surgery, we are going to have 15 minutes video session from Dr. Santosh Honawar. So he'll be demonstrating ptosis surgery,
ये कहाँ रखूं?
DCR surgery there.
Oh,
Unfortunately, he is not able to do live surgery because
मेरा एक
his
gloves
instruments
और extra
couldn't
gloves
arrive from
चाहिए।
Hyderabad here.
Change
But he's going to sir.
नीचे देखिए।
Sir.
ऊपर। Yeah.
ये कौन सा है?
Change it
SICS.
because
Video is paused.
डाल दूं यहाँ पे? वो ले लेना। मुझे सिर्फ ओटी में क्या क्या लिया है दिखा देना।
Become fillers in between.
वो तो है, हाँ हाँ
डॉक्टर होनावर को निकलना है जयपुर के लिए, इसलिए वीडियो है, वहीं चलेगा। हाँ नहीं लगा दीजिए सर, इसके बाद वो शुरू करेंगे।
चलेगा, मैं कर देती हूँ।
While Dr. Sheetal is prepping up, do we have a photograph or maybe a topography or something from this pterygium patient?
Dr. Pandey, do we have a photograph of this patient? Photograph of pterygium of this patient, do we have? Do we have photograph of this patient which she is going to operate? No. Okay.
सलाइन, सलाइन इसमें सलाइन लेके उसी ने पाई।
क्या SICS? हाँ हाँ।
और ये 2 खोलना है अपने को, बाद में ग्लू के लिए 2 लगेंगे।
हाँ।
2 सीसी में भी लिया तो चलेगा, 2 सीसी में।
हाँ हाँ आप करवाओ।
2 कराई क्यों ना इंजेक्शन?
नहीं SICS होगा।
इसमें आया ही नहीं सलाइन। इसमें सलाइन नहीं आ रहा। ये है राइट?
Dr. Sheetal, what block have you used?
Just second ना। Zoom is।
हाँ कोई नहीं करके लाओ।
Am I audible? सलाइन देना।
Yeah, you're audible.
Dr. Harshul?
Yes.
After this pterygium, will we?
No,
will you go for SICS or Dr. Santosh?
No, Dr. Santosh has to leave for Jaipur. So after this, we'll have a 15 minutes video deferred live surgery kind of session.
Okay.
From Dr. Santosh Honawar there in hall.
After that, we'll see the SICS, no?
Yes, yes.
Okay, got it.
Focus.
It is decentered.
Just focus the microscope.
हाँ ठीक। कैलिपर है ना? कैलिपर।
Focus the microscope and center it.
Please center it. It is decentered.
नहीं मैं बताती हूँ। Can we start?
Yes, ma'am.
Am I audible?
Yes, you are clearly audible.
ग्लू है ना वहाँ?
But the microscopic view is not centered.
पता है कहाँ पे रखा है मैंने ग्लू के 2 हैं और ये 2 छोटे इंसुलिन सिरिंज में ग्लू लेना है और उसमें 2 कैन्युला भी है। देखो ये नहीं
Dr. Sheetal, please center your microscope.
ग्लू निकालते टाइम पे इससे निकालना थोड़े वाइट बोर्ड से और बाद में 2 कैन्युला लगा देना। कपिल को पता है ग्लू।
Dr. Harshul?
Yes, Dr. Sanjay.
Microscopic view is not centered.
Yeah, we are going to center it.
24
Okay.
हाँ उससे आ जाएगा।
Sheetal, can you center it here?
It's very hard actually, this one.
No,
This is
opposite.
not moving. Very hard. I'll just move.
Yeah.
Okay, is it centered now?
Is it centered now?
It is better, but a little low. Yes, now it is better.
Wait,
Now it's better.
Zoom down.
Zoom down.
उधर वाला है, इधर वाला है। हाँ, wait.
No, wait. Let me actually know.
ये।
अच्छा ये दोनों zoom है। This is zoom. Okay. Is it better now?
Yeah, if you still little more centration, Sheetal.
Yes,
This is very
this
good.
is best.
Okay, okay. fine.
Perfect.
चला है.
This is best.
हाँ वो ग्लू इनको साइड से यहाँ पे देना, उसमें से 2 ले, कोई भी आपने पहले दिया मुझे तो चलेगा, ठीक है. हाँ वो 1 cc इसमें ले लेना और फिर कैनुला लगा. Okay, hi, I'm Dr. Sheetal. So this is a pterygium. This pterygium looks like quite chronic. No, not crescent, tooth forceps. उसमें से देना, limbs देना. Crescent नहीं चाहिए मुझे.
So,
And,
Dr. Sheetal, what are the
okay.
signs which show you that this is a chronic?
Yeah, so I'm
like
showing. So
an
if you can see this, there's already an opacity which is formed.
Yes, yes.
So this is an opacity and this is not actually a pterygium part. So when I remove this pterygium, this opacity is going to remain.
Right.
So that is one condition, or that is the reason why we need to operate pterygiums in time, because the opacities will not reduce and there will be some kind of a flattening which will be always there. So even if we remove this pterygium, there will be a bit of topographic changes. They won't reverse completely. Can I
Right.
have a scissor? Okay, so what I generally do is I hold it over here and at the neck part of the pterygium, I cut it. A good idea to do before pterygium, because luckily this pterygium is not very vascular. It is okay, but otherwise a drop of brimonidine or adrenaline should be put. So the surgery, the bleeding is less. Then just hold this part and try to remove it as much as it can come. Don't worry about the epithelium. It generally heals. और एक टूथ फोर्सेप को तो दे देना, ठीक है, नो प्रॉब्लम. बड एंड स्पॉन्ज तैयार करो. Okay.
So Sheetal, for anesthesia, what kind of block did you use here?
I generally use peribulbar.
Okay.
I don't prefer doing surgeries like pterygium in topical, where a lot of people do it, but sometimes when you're handling conjunctiva, it is pretty painful. 15 number blade on a blade parker.
Even if it's a very small pterygium, Sheetal, you prefer giving block or?
No, the small pterygium, it may happen it faster. Unfortunately, I do not get to do small pterygiums many times. So most of the times I do the recurrent pterygium. So this is, if you do not have a diamond blur, the 50 number blade is a pretty good friend to us. What you have to remember is never keep the blade oblique. When you keep it oblique, you can cut the stroma, but if you keep it straight, perpendicular to the corneal surface, you are just removing the fiber part.
Right.
So this is how you should clean your area which is there. So you can clean it. You can see what I was telling you, the sponge dena mujhe, that there is already an opacity which we were expecting it. So now if I clean more than this, there are no pterygium part as such. I will be just removing the stroma and making this part thinner. So there's no point doing that. This opacity will always remain. So now once we take care of this part, we have to move towards the body of the pterygium. One. हाँ, this को डाल देना. I think the focus is, sorry, I am little new to this camera system.
It's very well focused for us.
Okay, fine. So what I generally do is hold the pterygium and try to remove the subepithelial fibrotic part of the pterygium. If you are not sure, or when you're doing a recurrent pterygium, always hook your medial rectus, because sometimes you can damage medial rectus. So the good part is, either for the beginners or if you're doing a recurrent or pseudo pterygium, because that is attached to the recti muscle many a times. दूसरा अगर tooth forceps को तो देखना, you should try and hold it with the muscle and then do it. So what I generally like is do it till the end to give a better cosmetic appearance also. So my grafts are generally pretty big, even if the pterygium is small, because it gives a good cosmesis later on. So this part, either you can use it to put it back, but what happens is we can never clear the subconjunctival fibrosis and this fibrosis totally, so it can recur. So what I generally do is remove the whole thing till the end and took a large conjunctiva for a better cosmesis. This is known as, this is invented by an Australian surgeon. It's called as a perfect surgery, which is basically a large pterygium excision. So now either we can cauterize this part or we just put some kind of adrenaline, measure it and move towards the conjunctival graft until that time the bleeding stops. अपने पास adrenaline है? वो स्पॉन्ज पे सोक करके दे देना. कैलिपर
Can we center it? Yeah, fine. Is centration is good there?
Yes.
So now this is around around
You have
10.
lost the video link.
Video?
The video is frozen. We have
still
lost
frame
the
में आ रहा है.
link.
Is it on?
No, wait.
No.
No, it's, could you wait, Sheetal? We don't.
Yes.
Yeah, now come
Yes.
back.
Yeah, fine.
Again, same thing happened. Video is paused. We are not. Yes. Now it is better.
Okay, so this
We are getting the video down.
Yeah, this is around 10. If you can see it, and this will be also around 10. Okay, so 10 by 10 is the graft which I needed. So now to take that graft, I need 80 vicryl या 10 ये दिया था ना मैंने, हाँ. Needle holder.
So you try to take a little bit larger graft or the same
graft,
size?
larger. No. In this, because this will, see, it will come on.
Right,
So we can
right.
just take it. नहीं, cut करने की जरूरत नहीं. Just needle holder. हाँ, cut कर दो. बराबर. Cut कर दो कहीं से. So I'm just taking a traction suture here. एक इसमें
Rotate
2 cc में या किसी में भी adrenaline लेना again.
This is the superior part, no?
With
Coming
26
inferiorly.
number needle.
Need to
Sticker या
rotate
कुछ artery
पूरा
forceps
camera.
हो तो
Cataract में problem आएगा.
इसी में रहेगी artery.
कर दो अभी, क्योंकि टेरिजम है ना. हाँ, do it. उल्टा आ रहा है ना यार. स्क्रीन पे ऐसे आना चाहिए. दिस इज सुपीरियर
Okay,
व्यू.
marker
इधर
pen.
सूचर आना चाहिए. उधर आ रहा है नीचे.
Caliper. So ours was 10. So as Dr. Harshul said, it's to be on a safer side. I'll take 11 by 11.
न्यू दे दो, न्यू.
उसमें डालिए कि देखो मेरे इसमें मार्कर पेन. कोई बात नहीं. Okay, so you don't have to take the stem cells. We don't need it. So it's here. And something around नीचे. हाँ, दे देना. उन्होंने भी वही दिए शायद. The marker pen is so good, but that's okay. I have got idea of my size. Okay.
नहीं.
चलो 10-0 adrenaline वो देना 26 needle के साथ. Adrenaline with 26 number needle.
You are not worried about superior rectus insertion?
No, not at all, because we are going to do it very, very superficially. So what I generally do is I inject, either I generally prefer injecting. मुझे दूसरा ये देना ना, ये tooth forceps अच्छा नहीं है.
Forceps.
I generally inject adrenaline in this, so it again doesn't bleed much. You can inject just a normal saline also. Now Vanas. So I hold it from one side and start my dissection. So here there are very, very less chances that one will damage superior rectus because you're above tenous also.
Dr.
Okay, so
Sheetal, what concentration of aniline do you use?
it doesn't matter, we are using it superficially, so whatever we get it, I don't dilute it. Like if we are putting it intracamerally, we dilute it. Like for surface surgeries, you don't need to dilute it.
Okay.
So you can just even use your block. Okay, so you can make it like taut like this. Keep your vanas like this, not like this, because if you keep it your vanas superiorly, you can cause a buttonhole. So keep it like upside down and start just breaking your adhesions. You actually get a conjunctival forceps also, which does not, I generally do not use separate forceps, but if one wants to use it, that is a good idea again. So we have got a pretty thin. I again like, it doesn't matter because marker, we are not involving stem cells, so it doesn't matter which side you put on which, but I still like to prefer the orientation, and this marker is not working at all. So I'm just giving this thing, so I know that this is the limbal side. Okay. So I'm done with my graft. I do not do anything on this side. There are some people who put amniotic membrane. There's nothing wrong, but it heals very well in 2 or 3 days. Now plain forceps and McPherson. Give me McPherson also. McPherson. वहीं पे है. Okay, you keep it. This is your conjunctival epithelium side up. This is your the other side. If you can see it, it's already pretty thin graft. One can still make it thinner if you want, because generally on the posterior side, tenons is little adherent, vanas. So we can very flush, just don't go like this, We can cut the tenons and just make it even thinner. ग्लू लिया है टेबल पे? टेबल पे ग्लू लिया है क्या? It's pretty thin. टेबल पे ग्लू लिया है. एक स्पॉन्ज देना मुझे. नया स्पॉन्ज भी ले सकते हैं आप. नया स्पॉन्ज ले लेना. ड्राई स्पॉन्ज. ना टच मत करना. McPherson.
So just to let the surgeons know from our side that the hall is near full to capacity. So I think you all should feel even better about operating, and we are all enjoying the excellent surgeries until now. And we hope to continue the entire evening.
This is covering quite a lot. We should not go with the conjunctival graft like this, because it gives a very bad cosmetic appearance. Just keep a slight distance and keep it posteriorly, slightly posterior to your normal limbus. Okay. Tooth forceps देना हाथ में. And it's covering my whole conjunctiva till the caruncle. So this will give a much better cosmetic appearance. You will not even come to know later on, if this opacity was not there, that pterygium is done in this case. Once we have put this, nahi, kuch bhi clean mat karna hai. Once we have put this properly, now what we can do is we can just take this half, reflect it back, clean it with a sponge, dry sponge. And अभी glue एक के बाद एक देना है मुझे, ठीक है? So whenever you are applying a glue, it has to be very dry. The area has to be dry. दूसरा देना, तैयार है दूसरा तो देना मुझे. हाँ मैं एक सेकेंड, और एकदम इमीडिएटली मेरे हाथ में मैकफर्सन देना है.
So, Dr. Vaishali, can you hear me?
It doesn't matter which part you put first.
Yes,
the
Harshul bhai, we can hear you very well.
So I've shared the YouTube link for live surgeries in our ROS group and everywhere. So I'll request all the members to share it everywhere they want to, so that everybody can watch the live surgeries which are going on from Suvi Eye Hospital.
And Sheetal, is there a particular glue that you prefer, or either of the brands is
No,
okay?
I prefer Tissel because I've tried the other glues. Many a times they don't work. Again, there are a lot of surgeons who do tooth forceps, who do the blood. They use the blood. You can use it, especially when you're doing it. I've never used it though. But you have to be a little more patient with the blood because it takes a little more time to stay, and you have to keep on ironing it. Glue dena. So once our other part is stuck, reflect the second half and put your glue. है मेरे हाथ में. Plain forceps. Just iron it out, the excess glue will flow.
Dr. Santosh is there in hall. Can we have his views about using autologous blood for grafting?
Again, never pull the glue. If you have excess glue, tooth forceps, cut it with your vanas, because if you try to pull it, the whole graft might come. So always like take this and cut it. Cut the glue. Cut the glue.
It works well.
Yes, sir.
Because there is no expense at all. So many surgeons prefer blood. And there is a glueless, bloodless surgery as well. You simply lay the amniotic membrane or conjunctival autograft on a dry field and simply cauterize the edges. And if you have RF electrode, you hold the edges of whatever graft that you have used along with the edge of the conjunctiva and just a low energy burn, and that's it. It auto fixes the edges. So that's one way of doing it. So there are many ways of doing it.
Yeah. As I said, it works pretty well. I generally don't use it because the kind of pterygiums we use is most of the times a recurrent pterygium. So we do not want to ever kind of, lose the precious graft. So that's the reason most of the cornea surgeons will use glue. But yes, that is also a very good idea. And we are done with the pterygium.
Wow.
Visco. This will heal very nicely. Again, there are a lot of people who do mini slit for the pterygiums. Again, I do not believe in that because I feel the pterygium has a very localized loss of stem cells, and there are very good stem cells which are there. So I really don't think for even recurrent pterygiums we ever need mini slit or something like that. So now when you're removing the speculum, you have to be careful that there are no glue attachments. If they are there, you have to cut it. Vanas.
Sheetal, did you apply methyl cellulose on the cornea, or?
Yes, right now I have just put it.
And would you wash it off later or just patch the eye for now?
No, I'll just keep it over there over the cornea. It acts like a lubricating.
Okay. Wonderful surgery.
Thank you, ma'am.
Thank you
Wonderful
so much.
surgery.
Sheetal,
Yeah,
amazing.
thank you.
Ma'am, I have a question.
Yes, please. Sanjay, go ahead.
Ma'am, can you elaborate the importance or the use of the corneal polisher devices, battery operated? I have got one of these device from the Precon, and I'm using it to polish the remnants of the pterygium over the cornea. Instead of 15
It's very
Yes,
good.
please.
If you have an access to that, you should use it. Just be careful that you are not thinning the cornea too much, because if you thin the cornea, you will cause localized ectasia or sometimes perforation. Again, a very good idea before pterygium, especially if you are handling recurrent pterygium, to do the OCT and see the depth, so you know that what kind of cornea you're dealing with.
Device is not very costly. It is almost 8,000 to 9,000 rupees.
Of course, these devices are very good.
One more thing, ma'am.
But
In the patients who are not able to pay the amount for the glue, we are using bipolar cautery, simply using the bipolar cautery to cauterize the edges of the autograph, and it is working well. So what are the harms, or what is the difference between the glue and the cautery?
Yeah, I don't think cautery is a very good idea, and the healing with the cautery will again not be very good. First, it will retract the conjunctiva a bit and it causes fibrosis. So if you do not have access to glue, the blood, what Dr. Hunawar also said, is a very, very good idea. And it sticks well. You just have to be slightly more patient than the glue. Glue sticks very fast. Blood, you have to iron it little better than the glue. But no need to cauterize.
Yeah. Thank you so much, Sheetal.
Thank you, ma'am.
Demonstrating wonderful
thank you so
surgery.
much.
Thank you so much.
Hello, I want
Yes.
to ask one thing. Instead of giving injection peribulbar, can we inject the Xylocan directly in the body of the pterygium? What I am doing, I am injecting the Xylocan directly in the body of the pterygium instead of giving injection in peribulbar.
One can
Wonderfully.
one can do it. It depends on the comfort. But again, for the conjunctival autograft, you are going to handle your superior conjunctiva also. So only giving it over there may not make a difference. But maybe the way I do it, you can just put the subconjunctival block in the superior conjunctiva while taking an autograft, and that should suffice.
Hello. I think we'll now shift to.
There's a question from the audience, please.
Just a minute.
अच्छा हो गया हाँ.
Now we are shifting to SICS surgery from Dr. Amulya Sahu,
मेरा सामान पूरा हाँ.
because patient is ready and patient has already been blocked.
ये हमारा है आपका है.
Arshul, should we ask Dr. Hanover to wait? He's ready with his presentation.
Hello. Hello. I am Dr. Lal.
Yes, sir.
Yes, I am working in this department for last 50 years.
Okay, sir.
Since
Sir.
70 onward. And I am doing pterygium since then.
Yes, sir.
Pterygium in 4 figures, more than 4 figures, and got recurrence only once. I am not doing any transplantation or anything. Just one thing to remember in pterygium: remove the pterygium part, not beyond the insertion of the medial or lateral rectus, just 3-4 millimeter. And the same way, circular,
Dr.
when the pterygium is there, scrape the pterygium as Dr. Saab did in this, scrape the cornea as usual, throw away the pterygium.
Go ahead, lunch.
And scrape the limbal area.
I have now.
1 millimeter of limbal area. Just cornea, sclera bead, there just with
They want to
spatula.
let it
Just
out.
with a spatula, 1 millimeter, 3-4 times rub it. I
Madam,
think
कोई बात.
there are
मैडम को बोलना लीजिए.
pterygium germinal cells
मेरे इंस्ट्रूमेंट ऑटो
that limbal area, just beyond limbal.
टाइम होगा तो
If you scrape them 3-4 times, wash it, and I put drop mitomycin C, 2 drops or 3 drops for 3 minutes or 2 minutes, wash it and send him. No, he will never come to you again.
Thank you, sir. Thank you.
Pterygium excision, scraping of limbal area, 1 millimeter size, just with spatula. And then mitomycin C drops, you get 1 vial, dissolve in 7 cc, and put 3-4 drops. And close the eyes for
there, no?
Block is not there.
Wash it and let him go.
Acha, acha.
That's all. Never recurrence, never.
Okay, sir.
No
Thank you
scar,
all,
no other trouble, no.
Can we have feed from this microscope?
I'm
Level
agree
one?
with you, sir. I have been doing this thing for the last 5-7 years, and same thing is with me. There is no recurrence.
Thank you, Dr. Lal.
Okay. Let us go with the next surgery, please. Dr. Harshul?
Yes, sir. Sir, we are just starting in 1 minute, sir. सर के इंस्ट्रूमेंट्स आ गए? अच्छा, एक मिनट. इंस्ट्रूमेंट्स कहाँ हैं सर के? ऑटोक्लेव नहीं हुआ? अच्छा. पांडे सर? एक ड्रम खाली है.
Harshul bhai, in the meantime, can we have Dr. Honawar sir's talk here in the hall, please?
Just a minute. Let us have a clarity. I think.
Okay.
Mila? Acha. No, just Dr. Vaishali, just 1 minute. अच्छा, एक मिनट आ जाएगा. पांडे बॉस ये ट्रे.
While we are waiting for all of us in the hall, we have a corneal expert on our panel, Dr. Neeraj Shah. Neeraj, would you do conjunctival autograft or an amniotic membrane for every pterygium, or is there a set of criteria that you have?
So the first choice is conjunctival autograft. Suppose it is not possible, suppose it's a recurrent pterygium, earlier a graft has been taken, or it's a double pterygium, then I would probably need an AMG as well. And in case of an double pterygium, you could possibly split the CAG, make a base of AMG on either sides and put the both the halves on either side so as to cover the bare sclera.
Do you think it's a good idea to operate both the pterygium, one eye, at the same sitting?
Yes, sir, we can do that. And secondly, in such cases, we can also use mitomycin.
I think we all discourage that, to operate both the pterygium in one sitting.
No, in the same eye.
Same eye. Dr. Hanover, please.
It will take just 5 minutes. So by the time we can have Dr. Santosh talk there.
Both pterygium at the same time.
Both medial lateral, sir.
Medial lateral can be done, so there is no problem. Not a problem.
Can be done.
There is no contraindication.
But you don't leave ever a bare sclera.
We can take superior limbal conjunctival graft, then divide it into two parts. One part we can graft to the medial side, one part we can graft to the lateral side.
Exactly.
That is the normal thing.
Do you use concurrently this mitomycin C or any other antifibrotic agents, especially in case of recurrent pterygium, where we say that it is only fibrovascular growth and not a pterygia tissue as such?
Yes, I do use mitomycin C, so we can
along with autografting.
Yes.
Say if when the patient came to you for third time, once he was operated, again he was operated, and you see there is paucity of this conjunctival tissue, then what is your strategy?
In case of absence of EAG,
बैग किधर है आपका बैग?
AMG.
आपका बैग किधर है सर?
Does AMG
कोई
do
नहीं.
equal works?
इसको ब्लॉक
No,
किया
no,
है या
definitely
नॉर्मल है?
AG
तो जस्ट हम
has a
वो
much better
talk
outcome
करते
as
हैं,
compared
sort out
to
करते हैं. एक मिनट सर, आप आराम से बैठिए सर.
The difference would be that if you are taking an AMG, you should take a larger graft, a larger area, because usually AMG tends to shrink and shrink very quickly. You might end up having fiber optic area right in the visible palpebral area. So
Have you seen pyogenic granulomas in bare areas after these doing conjunctival autografting?
not pyogenic, but granulomas, yes.
Granulomas. So how do you treat them?
So fortunately, I have encountered very small ones. Whatever you have,
Okay.
you just excise it, and if at all there is any bleeder, you can cauterize that. Usually happens at the junction of the graft junction.
Have you any experience of using 5-fluorouracil injections in atrophic pterygia?
No, I have not used F5FU.
Anybody from the hall has experience with 5FU?
Mitomycin is a better drug rather
Sir,
than this 5 euro. Still, one thing. Second thing is,
Hello?
in that case, that shows here in live surgery, I prefer to give less conjunctival dissection because conjunctiva is not the main culprit. Culprit is the tenon's membrane. So you cut less the conjunctiva and go undermine it. And that perfect method she was asking is that remove the tenon membrane all around up to the limbal area, up to the fat. If you show the fat level, then you use that, you cut subtenon membrane up to that. Perfect method is, doesn't mean that you cut conjunctiva because there is the chance of recurrence is because of two things. One is the tenous membrane, and second thing is Barrett's sclera. If Barrett's sclera is there, then chances of recurrence is more. If tenous membrane is not thoroughly removed, then chances of recurrence is more. So these are two things which I think is better if you, and it will take lot of big graft, 10, 11 millimeter, rather than this surgery could have done with 7 millimeter graft.
I 100% agree with you. Actually,
Yeah.
what my choice would be to undermine the tenons underneath the conjunctiva and take, for example, if the bare sclera area is 10 by 10, I would probably take about 7 by 7 because the conjunctiva also wants to make the graft, it thins out, thins out, and the rest of the conjunctiva also comes in. Close the 10 by 10 area by a 7 by 7 graft.
Also, I think a lot of these pterygium patients, especially if they are a little older, have some calluses of their native conjunctiva. So having a same size graft might actually lead to bunching or more chances of edge heaping post-op and granuloma.
Dr. Vaishali, can you hear me?
Autologous blood, I mean, like the things are very smooth and the recovery is very good. Though it just takes time to, stick onto it. So what I feel is I prefer autologous blood to glue.
Dr. Vaishali,
Sir, one small question.
can you hear me?
Excuse me, sir.
Dr. Vaishali?
Sir, one or two patients
We
around.
cannot hear you in this. I can hear you on YouTube.
Ma'am, go ahead.
Dr. Vaishali?
No, Dr. Harshul is trying to talk to us, I think.
Dr. Vaishali?
Sir,
Go
around
ahead.
two patients, young patients only operated pterygium with autograft and used mitomycin for around 2 minutes, 0.04%. And in post-op, what I observed that they had a kind of fibrous tissue ring kind of thing around the whole of the autograft, like the nasal side margin of the autograft. And in between the retracted conjunctiva and the autograft. However, it was, margin was only around of 1 millimeter gap somewhere, but there was a complete white tissue kind of thing. So how
granulation
do we
tissue.
handle things?
Dr. Vaishali, can you hear me?
Along the conjunctival autograft margin. So is it a granulation tissue, fibrous tissue? And how do we treat it like in, it was immediately post-op, like almost second day post-op only.
Dr. Vaishali, can you hear me?
Yes, we can hear you.
Okay, so it will take 10 minutes for surgery to start. So I'll request Dr. Hunavar to give his talk on deferred live surgery demonstration of ptosis and DCR surgeries.
We'll come to your question.
Sure, sir.
Pour a cup of tea.
ये bipolar लगा के रखो कर दो हाँ After
Please switch. Mike, please. So sorry about not having to do a live surgery. My instruments did not arrive from Hyderabad. It's somewhere stuck with Indigo. Anyway, so I'll show a couple of cases of congenital ptosis. Basically, we have a huge list of surgeries for congenital ptosis, and depending on levator action,
नहीं वो इंस्ट्रूमेंट जो है जो स्पेशली आपको चाहिए तो ये हो जाएगा.
For example, this young lady who has about 2
दोबारा कर रहे हैं.
millimeter levator action, the first thing that we do would be a phenylephrine test. If that is positive, there is no controversy at all, we would do mullerectomy. But if it is negative, then you can definitely consider Fassler Savart procedure as an alternative. Typical indications would be 2 millimeter ptosis and 10 millimeter levator action. And the standard thumb rule is that for every millimeter of ptosis, you excise 2 millimeter of the tarsus and tarsal conjunctiva. The criteria must be you should leave at least 4 millimeter of residual tarsus behind. So without wasting much time, I'll go to the surgery. This is the Fassler Savart procedure that we are doing under frontal block, which is only a sensory block. Frontal block is a sensory block and the kinetics of the lid would be maintained. Then we evert the lid and mark the center of the tarsus in relationship to the pupillary axis. And through the everted lid, upper edge of the tarsus, we pass 3 sutures. The first suture is slightly temporal to the central mark. The second one temporal and the third one nasal. This is to have traction over the eyelid. Then the second set of sutures passes from the fornix to the lid margin, just short of the lid margin. I will show you the purpose of the second set of sutures a little later. When you pass the temporal suture through the fornix, you should be careful not to pass it through the palpebral lobe of the lacrimal gland, otherwise you will have brisk bleeding. These set of sutures actually hold the tarsus in position and immobilize the lid, give stability to the lid. Once you've done that, you mark the amount of excision in the center of the lid. Suppose you have to excise 4 millimeter, it is marked right at the center, and then towards the medial and lateral side, you taper it to be exactly parallel to the lid contour. You should not excise 4 millimeter extreme nasally or temporally. See that exactly matching the contour of the lid margin. So it's equidistant from the lid margin all over. That's a RF electrode that I'm using that causes hemostasis. Then using a RF electrode, you make a small groove in the tarsal conjunctiva. You can see exactly what you're doing when there is good hemostasis. You don't have to worry about damaging tissues or cutting tissues that are unintentionally cut. Go deeper. Now we have gone nearly full thickness through the tarsus. You can see the gap forming. That means that we have gone full thickness through the tarsus. Now we lift it off and excise the conjunctival component. So it excises 4 millimeter of the tarsus and tarsal conjunctiva and exactly an equal amount of palpebral conjunctiva, which is folded posteriorly. So that is the tissue that we excise. Levator is untouched. It's a quick surgery and it actually follows the thumb rule. It's a very predictable surgery. Then we mark 2 ends of the lid crease, the proposed lid crease. Pass a 6-0 plain catgut suture, knot it. We were doing sutureless surgeries earlier, but that is not very predictable. So sutures are good. Pass it posteriorly. And then the second set of sutures that I had passed will hold the conjunctival edge very accessible now. You don't have to keep digging into the fornix. And this is a buried suture. The suture will not be exposed. If you have any fear that this suture will be exposed, you can always put a bandage contact lens for a week. These are absolutely buried sutures. Take it through the other end and tie. So it's a very simple, straightforward surgery. Posterior approach surgery. Take off the sutures and that's it. So basically the results are very predictable and you can see that in this patient, the lid crease has also normalized. So there was earlier a fear that if the lid crease is high, it may not normalize. No, that is not really true. One more patient in the right eye where we are done, you had a high lid crease, and that's nearly normalized following surgery. So lid crease is never an issue with Fassner-Lesavet procedure. In patients who have much worse levator action and much severe ptosis, we do levator resection. Now we go by Berkey's rule. For a beginner surgeon, if you're a beginner surgeon, then you always have to go by a thumb rule. And the thumb rule is that if levator action is 6 to 7 millimeter, you leave the lid at the end of the surgery exactly where you want it to be postoperatively. If the levator action is worse, you have to overcorrect on the table because such lids drop postoperatively. If the levator action is better, say 8 to 9 or more than 10 millimeter, then you have to undercorrect on the table because such lids actually lift postoperatively. So I'll go to the video of levator resection. Again, this surgery is performed under frontal block, which is a sensory block and not a motor block. First step is always to mark the lid crease. Lid crease should be exactly symmetrical with the contralateral lid because that is one element of cosmesis patients want. You can see that I'm not using a Bart Parker knife. I'm using a RF electrode. You can see the kind of hemostasis that we get. So you see the true color of the tissues and that help you identify the plane. Suborbicularis dissection to expose the orbital septum. Change in color from pink to yellow indicates that we are close to the orbital septum. Now we are working on the orbital septum, not opening it. Then that is suborbicularis dissection to expose the anterior surface of the tarsus. We expose 4 millimeter of the anterior surface of the tarsus. That is where we pass our sutures. Then we evert the lid on a Demers and inject subconjunctival xylocaine to create a plane of cleavage between conjunctiva molars and the levator aponeurosis. This is also an important step for a beginner surgeon so that you don't buttonhole the conjunctiva when we disinsert the levator. Then we put the lid back and pass a set of 3 sutures through the levator aponeurosis to tent it up. 40 silk sutures is what is used for traction. As we go by, in fact, when you have more experience, you can modify the steps. Now we disinsert the levator aponeurosis. You can see that tenting up actually helps you get under the levator aponeurosis. And once you are gone full thickness, the plane becomes perpendicular. You have full thickness now, then you simply bring in a dry cotton tip applicator and peel the conjunctiva molars off levator aponeurosis. So the posterior dissection is now over. You come back to the anterior surface. Now open the orbital septum and that legendary pad of fat gets exposed, which shows that we are anterior to the levator aponeurosis. Retract with the Demers and you're right on top of the levator aponeurosis now. And the temporal side on the left side, what you see is the Whitnell's ligament. You always expose the Whitnell's ligament, but don't ever cut it. We simply cut the horns a little bit to mobilize the levator, but never damage the Whitnell's, which is the fulcrum for the levator. Then pass the suture on the tarsus, 4 millimeter. Make sure that it is not full thickness. This is 6-proline suture. Pass it through the levator aponeurosis, right under the Whitnell's ligament, not through the Whitnell's or posterior to it. If you pass it through the Whitnell's, it becomes Whitnell's sling. If you pass it posterior to it, then it becomes supramaximal resection. 3 sutures, 1 medial, 1 lateral, 1 center, all double-armed 6-proline sutures. Then you tie these sutures with enough tightness to get the correction of your choice. So I'm showing you simple steps of performing levator resection for a beginner surgeon in a more predictable fashion. So all you need to do is tie the sutures with enough tightness to get the correction of your choice. All the 3 sutures are tied, the contour checked. Make sure that there are no notch or abnormal contour. Excise the excess aponeurosis, leaving a good stump, and then form the lid crease. Lid crease is always formed by reattaching orbicularis to the LPS aponeurosis. So orbicularis, stump of levator, and orbicularis again. So that is to give a dynamic lid crease which disappears when the patient looks down and becomes prominent when the patient looks up. That's how the patients want their lid crease to be. It should not be a permanent lid crease. 3 such sutures for the lid crease. And of course, skin to be sutured. So that completes levator resection and the results are fairly predictable. Only thing is that you should take care of the lid crease height. This is again a patient of levator resection. where Whitnell's link has been performed, where the sutures have been passed through the Whitnell's ligament. So that is briefly about ptosis. I'll show you a DCR surgery. DCR is a workhorse surgery for oculoplasty surgeons. Of course, it is the most common surgery that an oculoplasty surgeon or anybody who's interested in oculoplasty would be doing. But it's becoming a lost skill because we are giving away our DCRs to ENT surgeons, although it has the highest success rate after cataract surgery. It has 95 to 98% success if well done. And it's a relatively short surgical time done under local anesthesia. You can use your operating microscope for a better visualization, but we are not doing it. We are giving it away to ENT surgeons. I'll show you a simple way of performing DCR with minimal scarring. The scar has to be curvilinear, and generally you avoid this portion which is above the medial canthal tendon and limit it to below the medial canthal tendon and exactly over the anterior lacrimal crest. Now, when you want hemostasis in DCR, you have to memorize this picture because this picture shows everything. This picture shows the angular vein, the nasal vein, and the inferior palpebral vein, everything. So if this red line is your position of incision, then you'll not have any major crucial vein in that area at all. So you should never be worried about bleeding in the anterior planes in DCR as long as your medial incision right over the anterior lacrimal crest. So this is the anterior lacrimal crest. This is the medial canthal tendon. And if you make your incision right under the medial canthal tendon for about 10 millimeter along the anterior lacrimal crest, you're absolutely in the safe zone. For the flap, skin muscle flap, you can use a cat's paw retractor to retract this flap so that your angular vein will be under the cat's paw retractor and you'll never damage it. And arteries actually follow the course of the veins, so you'll not cut an artery as well. Now, second thing is sometimes you want to cut the medial canthal tendon. The most important tip I can give you about cutting the medial canthal tendon is never cut above soft tissue because the common canaliculus will lie right under the medial canthal tendon. And if you're a beginner surgeon, you may damage the common canaliculus, resulting in failure of DCR because CC block. So you always cut medial canthal tendon on the bone so that you don't damage the sac or the common canaliculus. I'll go to the surgery. This surgery is being performed under local anesthesia. I'm marking the incision, which is right on the anterior lacrimal crest, curvilinear incision. You can also use a lower lid crease incision for better cosmesis, but this gives a good cosmesis. This suture mark will not be seen after about 6 weeks or 8 weeks. Incision of skin and orbicularis, stretch and incise, don't go deeper. Then you split the orbicularis. When you split the muscle, it doesn't generally bleed much. Cat's paw retractor takes away all the deeper tissues, and then you work towards the anterior lacrimal crest. Again, splitting the tissues, not cutting them in any way, and dissecting them in the plane of the periosteum. Sometimes use the suction cannula itself to dissect. That makes it easy, that makes it quick. Our idea is to reach the anterior lacrimal crest. Once you reach the anterior lacrimal crest, your plane of dissection should be between periosteum and the bone. Never get under the periosteum because there will be peri-sac plexus of veins which will bleed irritatingly. Now you go to the junction of the lamina papillaris of ethmoid and the lacrimal bone, and your bone puncture, the posterior aspect of the ostium, will begin at the junction of lamina papillaris of ethmoid and the lacrimal bone. That is the posterior edge of the ostium. Anteriorly, you go about 6 to 8 millimeter higher than the anterior lacrimal crest. That is your anterior edge of the ostium. Inferiorly, you have to expose the sac duct junction. Superiorly, you have to be 2 millimeter higher than the common internal punctum, that is common canaliculus. If you follow these anatomical rules of the ostium, then your ostium will be perfect in position. You don't have to measure the ostium with a 25 paise coin that you have never seen on the tip of your professor's little finger, which may vary in size. So it's always by the anatomical landmarks. Then we put in a probe through the one of the puncta, inferior or superior. And this probe should abut the lacrimal sac at the junction of the medial wall and the floor of the sac. That is where the probe comes out. I actually exit the probe there, so I know exactly where I am. So probe has come out now. And then I make an incision right from the sac duct junction to the fundus of the sac. That's a vertical incision. Content of the sac come out. Then 2 horizontal incision at the extreme lower end, that is sac duct junction, extreme upper end, that is the fundus of the sac, and you open the sac like a book. You see the anterior flap and the posterior flap. Now you excise the posterior flap under visualization. Posterior flap should be excised or sutured or glued. It should never be left alone, because then it will form a scaffold on the ostium and close it again. So once you have excised the posterior flap, you make the nasal mucosal flap, inferior edge of the ostium first, a vertical incision, superior edge, a vertical incision, then a horizontal incision at 2/3 of the depth to meet the two. Then the posterior mucosal flap should also be excised under visualization. Then you suture the flaps. I prefer a surface to surface anastomosis, which means that I take a larger bite from the sac flap and a smaller bite from the mucosal flap, and make sure that the sac flap overlaps the mucosal flap. This is a more reliable anastomosis than an edge-to-edge anastomosis. With this, you'll be able to titrate the flap tightness as well. If it is too lax, then you can excise a bit of the flap. 3 such vicryl sutures is all that is required for the anastomosis. If you have any bleeding at any point in time, you can use a few drops of any topical agent such as alpha-gal. Orbicularis closure. Orbicularis closure should be meticulous. Once we close the orbicularis, skin presents itself, and you simply have to close the skin with any non-absorbable suture, and that's it. So it's a quick DCR, takes about 15-20 minutes to do, and we always do an intracanalicular irrigation to demonstrate free flow, and that's the end of surgery. Thank you so much. If you have any quick questions, I'll be happy to answer if the next set. Yeah, please.
So we are shifting to that.
Please. Thank you so much.
Thank you so much.
Thank you much for the meticulous surgery, sir.
Can you hear me there? Dr. Khilani, sir? Can you hear me?
Arshul, we are here.
Yeah, can you hear me, sir?
Yes.
Okay. Thank you so much, Dr. Hunawar, sir, for demonstrating the deferred live surgery for us. And now we have Dr. Amulya Sahu will be demonstrating SICS surgery, 2 millimeter SICS surgery. Over to you, Amulya, sir.
Yes, sir. Thank you. Tell them this got delayed because of this.
Can we have the microscope view, please? Yes. Okay. Amulya, sir? Yeah, please.
Yeah.
Sir.
So this is a 82 degree उसका ये है. Marking करो इसको.
Can you hear Dr. Amulya's voice?
Sir, can you speak a little louder, please?
So the axis is 82 degrees, stiff axis. This हाँ इधर लगा.
Mic set करना. Sir is saying the steep axis is at 82 degrees.
इसको डालो. Saline डालो. Is visible there?
Yes, sir, it's visible and audible.
धनराज जी, हाँ बस लाइट को खाली देखते रहना. अभी स्टार्ट कर रहे हैं तो कुछ टेंशन नहीं.
Sir, is the patient under topical or is it a block?
नहीं, I started topical, but it is now delayed, so I thought it is better not to make the patient tense. So I have given the block. Then seizure दो. Seizure क्या? नहीं मेरा seizure. Forceps दे.
So Amulya sir, all your incisions are 2 mm for all grade of cataracts, or it changes according to the grade of cataract?
If it's a very hard cataract, I usually take a bigger incision. Depends on the size. Very hard cataract, so it is better to take a bigger incision rather than, because with a small incision, if you are removing hard things, the endothelium problems will be there. So, not only, there is no dogma. Sometimes the very, like we have a case with Suresh had kept it here. So this was a matured cataract, but it will be soft inside. So we can take such cases. Bipolar cat, bipolar. जॉनसन बोर्ड रखो, जॉनसन बोर्ड है। या या दबाओ।
यही हो जाने दो। फिर आप आ जाओ, वन सीक्वेंस सही हो जाएगी। हाँ, सुनो
Not coming.
या आप उस पे करोगे।
So, give it.
ब्रेक हो जाएगा।
Mark and tunnel knife. वो नाइफ है, हाँ नहीं दी इंसिजन करने के लिए। हर्षुल क्रिश्चियन लाइक टू क्रिश्चियन क्रिश्चियन साइड फोर्ट
15 डिग्री। डॉक्टर पार्था ना उसके बाद ना वो ले लो डॉक्टर अरुण को, डॉक्टर सोनू
द क्रिश्चियन,
फिर इधर आप, फिर डॉक्टर देंद्र, फिर आप माइडस। हाँ हाँ गीता नहीं, रमेश चंद है ना, नहीं बट अयान से ना तो गीता शर्मा आएगा। अयान से ना गीता शर्मा है ना, कौन सी पेशेंट लोग वो नहीं कर रहे हैं, ठीक है ना। हाँ ठीक। Sir, how much is this internal incision size which you are creating pockets on side?
Around 7.
Sir?
Around 7.
Okay.
Side port.
It's a big doorway out inside, narrowing down. एसी के आने में तो वहीं से आएगा, बट यहाँ कंप्रेस होते हुए आ जाएगा.
Stain. स्टेन जो है ना, कलरिंग करना, कलर इधर रखा था ना, कलर इधर. मिथाइलिन ब्लू रखा था इधर.
गीता शर्मा नॉर्मल
इधर रखा, छोटा सीरीज में था ना. किधर गया तुम?
हाउ इज इट ग्रेट.
मिथाइलिन ब्लू दो ना.
46. ठीक है.
इधर रखने के भी उठा के ले लेते.
इसको सर वो हमने लास्ट में अपने लिए रखी हुई है, स्मॉल प्यूपिल और सारी.
मिथाइलिन ब्लू दो.
पहले मास्टर्स फ्री हो जाए. नहीं, फिर बच्चे लोग आएंगे. अच्छा है.
$26 number needle दो. टू सीसी सिरिंज, ये नहीं, 2 सीसी सिरिंज दे दो. So you
Yes,
can
sir.
you can tell them that the delay is because I am selecting the instrument.
Yeah.
I had kept the methylene blue, somebody has picked up from
Yeah.
there. So all these delays are happening because of this. They don't know the instruments, so I can't blame them. That will spoil everything. इसको है जो मैं अभी दबाया, जो इसको साइड पर दे. टनल नाइफ लाना, नाइफ लेकर रखो. रिसेंट नहीं, उसमें टाइम नहीं. फुर्सत इधर उधर क्यों करते हो?
So why you made the second side port, sir, there?
So while cortical cleaning is there now,
Hmm.
it makes things easy for the cortical cleaning because I will be using a Simco का ready हुआ कि नहीं? Oh, Harshul,
Yes, sir.
please see that they have the Simco ready because Simco
Simco is there, sir. Yes.
Simco is there, but they have used the अभी सब bottle फटल सब ready किए. देखो क्योंकि उनको बोलने का वो उसको बोलते हैं उसको that should not happen. Please.
So what is the size of capsular axis you aim for,
This,
sir?
this is a
in
grade
SIC?
grade 3 cataract है.
You aim for slightly bigger capsular axis?
Yeah, I'll keep it a little bigger because it is not a very because I want to divide in the bag. That is why. So at this stage, I want to enter the AC in the 12 position and take it. आपने सिम को रेडी किया कि नहीं सर? आएगा बराबर? हाँ, ठीक है. See, this is a 12 o'clock position. If I would have dragged this from here,
Yes, sir.
then chances that it would have slipped. So what I will go from 12 o'clock and take it away from there. I'm not able to see because the methylene blue नहीं ये नहीं है दो ना नाइफ दो ये क्या कर रहे हो
क्या चाहिए?
जो भी है
कोई भी दे दो.
इस पहले रेडी करके रखना मांगता है ना. दिस इज नॉट फेयर. नहीं है तो छोड़ो. है कि नहीं है?
2.2 एल्कोन का दे दो ना. क्रिसेंट इधर रखा होगा ना टेबल पे. ठीक है. हाँ दे. क्रिसेंट नहीं, एंट्री चाहिए ना. ये लो. ये लीजिए. Yeah.
थोड़ा नीचे देखो. हाँ बस उतने ज्यादा नहीं.
So, sir, do you keep your incision at the same site or your site changes according to astigmatism also?
Yes.
Or you,
It is always on the stiff axis.
sir?
It is always on the stiff axis.
Okay.
See there, from the side port, if I would have gone, I was feeling that I may drag it to the periphery. So I went through the 12 o'clock. It always better to not take a chance.
Yes, sir. Yeah. That's a perfect axis, sir. Perfect axis.
Had this. So, huh? मेरा हाँ चलो कोई बात नहीं इसे ही कर देते हैं अभी टाइम नहीं This is not my instrument.
Sir, with a 2 millimeter incision, which is scleral, you sometimes find it difficult to pivot the axis?
So normally what we have been taught is not to do hydrodissection from side port incisions. That's what we usually do.
Why?
So
Why?
I saw you did.
No, what is the, why not? Because the chamber remains maintained,
Yeah.
and you don't infuse too much of this thing.
Yes, I think it should be very little and should be controlled, especially if you go through. Yes.
Because with that little bit of these things, if you are using my jet, then it will be the very good thing, you know. So, and as you saw the use of the side port in both sides, now I will be dividing the lessee. डिवीजन के लिए इंस्ट्रूमेंट के जरूरत तो प्रैक्टिस है नो
लीक कर रहा है चलेगा
डिवाइडर किधर है नहीं नहीं ये नहीं This is a very soft kind of cataract, so very nice dissection, sir. So this instrument is very good in bisecting it. Yes.
Yeah.
This becomes a little difficult because it's soft with blocks.
So who manufactures this instrument, sir, which you just shown?
वो नारायण करके है बॉम्बे में.
Okay. Yes, then of course. Yeah.
So I have to depend this thing to make it little bit of, so that I can go behind
So in a
and.
very soft one, do you try to bisect it or you just try to collapse the entire nucleus up? And-
I would like to have a grade 3, at least grade little time hard. So, but it's okay. Now one piece has come out.
Yes.
Then this is the vectis. And this is, you see that there is a edge, there is a hanging edge here.
Yes, yes.
That will engage this piece. And then I am gliding it out. I am not, there is no force upward. It is pressing the floor of this thing.
Yes, yes.
सफा करो. So then all these things you can flush it out also. And this piece I have to take it out. Forceps. ये क्या है मन? Vectis.
Will be shifting. Microscope.
सफा करो.
We'll have to wait till.
नहीं ऊपर नीचे थोड़ा देखो नीचे. हाँ ऐसे रखो. I want to flush out. Dialer. There is this piece I have to.
वो माइक्रोस्कोप लगवा देते ना, टाइम सेव हो जाता है.
Just to keep it in mind that the pointed end should be there towards you, but when I was engaging that, it went to the side. Otherwise, it just glides out totally. So I'm just moving it.
So is there any role of irrigating vectors in taking out the nuclear pieces or?
No, there is not.
Sir?
No, there is no need yet. Because this will come out like just like that. But
Yeah.
the matter is over. सिम को भी दे देंगे. Yes, थोड़ा.
सिम को लगा देते हैं. चेक किया ना, ओपन है ना सिम को.
So here I will show this the role of this jet.
Yeah, it takes off the entire.
Jet will give me a little more clean field. वो किधर हो jet? क्या करते हो jet किधर है? Saline jet. क्या कर इंस्ट्रूमेंट को इधर उधर मत करो. ठीक है छोड़ो. हाँ Sure. Simco there. So I have got a clean field now. Hmm.
Can we center it, sir? Better, little bit.
Uh-huh.
Can you center the eye?
Oh, yeah, 1 minute. This piece is coming in the way. Is okay?
Yeah, I think. Is the centering fine there in hall? We can't hear from hall.
Yes, sir.
Audio is not coming from hall.
Centering is
Dr.
okay.
Vaishali?
Centering is
Dr.
okay.
Sandeep, are you there?
Centering is okay.
They're not communicating.
Yes, so much engrossed in the surgery.
We can't hear from hall also.
उधर से आवाज आना चाहिए.
पांडे बोल. हॉल से आवाज नहीं आ रहा है.
Hello, Arshul.
Yes,
I'm
yes,
Dr.
sir.
Ghulam Ali. Please center the eye.
Yes. थोड़ा सेंटरिंग करेंगे सर.
Little bit. Okay, it's okay now.
वो माइक्रोफोन लगना जरूरी है. फिर हम बहुत लेट हो जाएंगे.
Harshul, you are asking me na? Harshul.
Yes, sir.
You are asking me why the second side port.
Yes, sir.
Now you see.
No, I got the answer, sir.
Yeah.
Yeah. And moreover, you can do Rexis also going from the other side port easily.
Sir, is this 25 gauge Simcoe cannula?
Yeah. Yes.
And do you all also use J cannula sometimes?
Which cannula?
J cannula.
No. I have tried it and it looks too. Maybe I have to modify it. It looks too heavy when it goes there. So I have to use few times. Then I gave it off. So I think I have to make it little more slick. J cannula also helps, but for a microsurgery like this, it is too big. I think if you are giving a big incision, maybe it has a little role. This many a time you will find the plate mobilization becomes very difficult. Huh? So, क्योंकि plate is a sometimes it really you have to have the patience to mobilize a plate. Otherwise, you can really damage it.
Sir, if at all PCR occurs, although it's long timing, but if at all PCR occurs, how comfortable it is to use vanas through 2 millimeter incision, sir?
If you don't have other facility, go ahead with that, ना? क्या करोगे? फैसिलिटी है तो विट्रेक्टोमी करोगे, नहीं है तो सीजर यूज करने का. तो चॉइस क्या है तुम्हारे पास?
So then the incision has to be extended in which plane, sir?
Why? बना सीजर इसमें से यूज कर सकते हो ना आराम से. एक्सटेंड क्यों करोगे? एक्सटेंड करने का जब कॉन्फिडेंस नहीं होता है तो करोगे. इफ यू हैव नॉट डन ए 2 millimeter, you are used to a bigger incision, तो कैसे करोगे? आपको तो करना ही पड़ेगा एक्सटेंशन. But
yeah, this is the visco expression. Yeah.
Because I was not catching it, so I said better I do this way.
Yes.
rather than ये थोड़ा कम हो जाएगा ना तो मिलेगा मेरे को मार्जिन मिलेगा खींचने के लिए. So you have to improvise when you are. So one improvisation you saw that I came to 12 o'clock to take out the axis properly. You can't be rigid. So now I can catch this piece which is left there.
Actually, sir, I think if you have your second sideboard little, away, so you can easily reach this superior cortical, this cortical matter.
हाँ, क्या बोल रहे हो मेरे को? If I have the
If you have second sideboard, like 2 to 3 clock away, so you can easily approach you did visco expression. So like in the way we use in FECO, we do bimanual which are almost 180-degree apart incisions.
उसमें थोड़ा maybe
Because these are very close to the main incision, so you can't really turn it superiorly and take out sub incisional.
तो हम हमारा बायमैनुअल सिम को यूज करके मेरे को बताओ. Then I will learn from you. तुम लोग you are doing all the time FECO. तो और हमको एडवाइस कर रहे हो तो मैं अभी SICS करो, then I am definitely going to learn from you. हाँ, ये 100% FECO surgeon है.
Today I'll do SICS.
तो 12 o'clock में हो सकता है, मगर 12 o'clock आपका क्या होता है, पावर पॉइंट में ये खींच लेता है हमारे लिए बहुत. देखो ये अगर मैं इधर से जाऊं, देखो 12 o'clock, देखो मैं इधर रखूंगा, मेरे को ऐसा घुमाने के लिए बहुत प्रॉब्लम होगा. बिकॉज इट इज विद द हैंड. तुम्हारे लिए खाली जो है ना वो सक्शन ले लेता है फटाक के. हाँ, तो इधर इधर वो नहीं होता है. हमारा दोनों हाथ कंफर्टेबल बैठना मांगता है. तो नाउ यू सी ये चंक आ जाना चाहिए. आई हैव कॉट इट. हाँ, ओके, चलो पॉलिश दे दो. हो गया. Now I'm just polishing the posterior capsule. तब इंजेक्ट कर देंगे लेंस को.
बहुत अच्छा.
धनराज
जी.
अच्छा हो गया. अब ये लेंस डाल देंगे. बढ़िया हो गया. आप बहुत अच्छा पेशेंट है.
इसका कैमरा सेट हो गया था. बहुत बढ़िया माइक्रोस्कोप है. आई यूज्ड इट यस्टरडे.
उधर दिखता है कि नहीं? इधर थोड़ा है.
कोएक्सियल है.
थोड़ा है. लेंस रेडी करो. इंजेक्ट
कहते हैं सर के ऊपर से फेंको.
क्या नाम है बेटा आपका? हाँ, जसवंत. देखो लेंस रेडी है. हाँ, चलो दे दो. निकालो, दे दो. लोड कर सकते हो? मैं करूँ? हाँ, कैटरीज दो ना.
ऑन करना.
नहीं होता तो मैं डाल दूँ तो डायरेक्ट. सुरेश, मैं डायरेक्ट डाल दूँ? डायरेक्ट डालूँ? दे दो. डायरेक्ट कर दे.
ऑन कर.
हाँ, डायरेक्ट कर दे. खाली निकाल दो, मेरे को दे दो. अब हर्षुल, आप हर्षुल कुछ ये नहीं कमेंट नहीं कर रहे हो? कमेंट तो मैं डायरेक्ट डालता हूँ.
यस सर.
डायरेक्ट डाल रहा हूँ.
यस यस.
हाँ
यस यस.
हाँ, तो फिर वो लेंस बैंड नहीं होगा ना. हमने बोला ना उसको बैंड नहीं करो.
Sir, what do you prefer to give in post-operative period usually?
हाँ,
Post-operative regime, sir.
डायरेक्ट वो दो ना लेंस फोल्डिंग. ये हाँ ठीक है, चलेगा.
Yes. So Amulya sir is going to put the lens without cartridge through this incision. There's a single piece hydrophobic lens. Forceps.
थोड़ा ये हाँ इसका
Visco is there.
इसका थोड़ा आ जाएगा, ये बाल भी आ रहा है साथ. I could have injected easily, but I want to show the SIC surgeon को थोड़ा ये पहला उसको एंगेज कर दिया, फिर
Wow. This is a hydrophobic IOL which goes through 2 mm incision without folding it. All the time. Yeah, so that it can curve up on itself. Yes. अच्छा है ना बस माइक्रोस्कोप.
हेलो नहीं, अभी सुनो, से लाइट को देखो, हाँ अभी लेंस बैठा दिया है, आपको थोड़ा टाइम लगा, ये नहीं डायलर दो. ये दूसरा डायलर है ना मेरा, ये अलग टाइप का डायलर है. So this is a my modified dialer. You see, it holds the lens haptics. Instead of engaging it, it holds it and mobilizes it very smoothly. See, I will hold it here and take it like this and put it behind. Okay. Now, see it. You see it is how it is made. Now here, because I have to bring it here to a very nice position. वही डायलर दोनों, पहले डायलर.
Okay.
Yeah.
So both the haptics are in capsular bag now. Perfect.
थोड़ा
Yeah. So it's very important to remove all the OVD from behind as well as in front of the optic. Fine.
तेरी ये किधर है?
नहीं ये नहीं
लगा
होगा,
लगा
वो वाला होगा।
Is it okay, Harsul?
Yes, sir.
Well,
Need to shift, yeah.
why this gap? This gap. No, I don't want to linger it little more.
Huh?
Why this is gap? Yeah. नहीं यार दे दे चल
Here दे दो। बस माइक्रोफोन शिफ्ट करेंगे आप।
पहले कर पिन है क्या देना डाइल्यूट करके दे देखो
हाँ डाइल्यूट है।
यार इसका
बढ़िया सर। Thank you so much, sir.
Okay.
Thank you so much, sir.
Thank you, Dr. Sahu.
Yeah.
Excellent, sir. Arsul, who is next?
Dr. Arun Kshetrapal is going to do next. That's a Hoya lens he is going to implant. Hoya Nenex IOL, which
चलो
so Dr. Arun started the case. He made incisions. He did capsulorhexis to save some time for us.
लाइट बढ़ाओ यार लाइट बहुत कम है
Microscope का foot pedal दे दीजिए please.
Good evening, Dr. Arun.
Good evening, can you hear me?
Yeah, yes. Loud and clear.
Are you getting my microscope feed?
Yes, yes.
Now it's coming.
So what I'm doing is, this is a 70-year-old male, a gentleman. We are operating his left eye. थोड़ा सा इसको टाइट करना पड़ेगा, इसको टाइट, ये इधर से टाइट करेगा. Let me adjust the microscope, please. Yeah. ठीक है.
एक मिनट.
हाँ ये इधर आएगा, दोनों ही राइट से करूंगा यार. ये इसको दो ही डॉग, एक मिनट में दबा देता.
अरे बाबा, मैं पूरा वोटी निपटा देता.
Yes. Is my microscope centered? Okay. The patient is on ecosprim, so you can see a lot of bleed. What we have done is we have made the rex hydrodissection. We have made the side ports, we have made the main port, and we are doing the. We have done the capsulorhexis.
हाँ.
This patient has नहीं light में देखें आप please. हाँ. Has
क्या कह रहे हो?
0.5 astigmatism on the cornea. बेटा इसके ऊपर से सलाइन हटाओ यार. Stop.
ये उधर है वो.
And We are implanting Hoya Nenex in this patient.
सीरियल में लिस्ट भेजता हूँ आपको ना. I'll send you. अभी लिस्ट भेज रहा हूँ.
Soft कर दो यार side से. So I'm trying and rotating the nucleus. If I'm able to rotate the nucleus.
नहीं नहीं.
Dr. Arun, this is a grade 3 cataract.
Yes, this is a grade 3 cataract with PSC.
So what is your plan? Direct chop or stop and chop?
I usually prefer direct chop, but let's see. Because the machine is new to me, this is what we are using is a Centurion vision system. It's a Sentry handpiece. The Sentry handpiece is the one which detects the height of the eye automatically, and we are using active fluidics. Light में देखें आप.
ठीक है.
नहीं ये मत डालो.
अब सब खींच देंगे लोग, मालूम है.
So this is a direct chop which is done.
मालूम
And
है.
can I have the fragment removal, please? Corner removal done. So I have done a direct chop.
Dr. Arun?
Yes.
Dr. Jala here. Yeah. Which machine you are using?
This is a Centurion vision system with an active Sentry handpiece.
Centurion?
Centurion machine.
Okay.
हाँ. भी इसके बाद ये माइक्रोस्कोप सेट रखना है यार. 2 पे वर्क करेगा, ऐसे नहीं हो सकता. इसको बाहर ले लेंगे अभी, या साइड में कर लो जैसे भी हो. लाइक अ सेट ठीक आ रहा था उससे. हाँ पांडे जी करेंगे, कर लेंगे वो. पांडे बस अभी.
And we'll be putting in a
शुरू हो रहा है ना
lens.
वहाँ पे वो लाइका सेट रहेगा, उसमें फीड जा रहा है, उस पे करेंगे केस. हाँ.
Arun, what are the parameters you are using?
What are the
parameters you are using?
Parameters? I don't know. The company man has set it. I think it's 45% torsional power. Can I have the viscode, please? And what are the
This
can you
the balance strip in the Centurion vision system is very good. The balance strip.
micro e-forceps. Can you see something inside the AC?
That bubble.
Very nice.
I don't know whether it's appreciable or not. There was a big.
कुछ निकाला तो है पर क्या है दिख नहीं रहा.
Now, आइए आइए.
सर आ जाओ.
So the nucleus is out.
Sir, do you prefer to stop ecospirin before the surgery?
Yes, we do. But in certain cases, yes. Because it's usually not a problem. Light में देखें आप.
For how many days, sir? 5 days?
Partha sir, ready?
So the conjunctiva is over the corneas. The incision is now I can
ड्रेप कर
enter.
दो जल्दी से. ड्रेप ड्रेप.
ये इसको पीछे करो, जो आइए कहाँ आई है।
अरे ड्रिप करूँ, केस खत्म हो गया।
You don't really need to stop ecosprim, but if the patient is on clopidogrel or something like that, then you need to stop it. And clopidogrel is usually stopped 4 to 5 days before the surgery. But mostly in cataract surgery, you don't need to stop these drugs.
2.7 भाई, हाँ खोलो ना। 2.2 या यूजिंग ना। 2.2 ये इधर दो।
लाइट में देखिए आप प्लीज, हिलाइएगा नहीं, है ना। So whenever you're doing a biomanual, your IA goes in first. The irrigation goes in first.
Side port you need.
Dr. Arun. Hello. Hello.
फटाफट करो, खत्म हो गया केस। ड्रिप कर दादा, स्लो नहीं है ना।
This is the mistake which you should not do, that you should not
आ गई ब्लेड, आ गई ब्लेड, आ गई। बाहर रुक संदीप,
break
थोड़ा सा
the
बाहर
instrument main port. It should be
Already बहुत
always
वो है।
side port. मेरे को viscode दीजिएगा। I think I need to make my side port properly.
शीट खोलो।
मेरे को वो दीजिएगा, एक सॉप दीजिएगा, ये रहे।
1 2 3 4 5
So,
Side
is this
port.
patient on blood thinner or something, Dr. Arun?
Yes, he is on ecosprin side
Oh.
port. 15 days.
Sometimes it has been seen, sir, that adrenaline swab also helps in seizing this blood.
So I'll make another
experiences?
side port because the conjunctiva is approaching over here.
जरूरत ही क्या थी?
Can you tell us something about the lens which you are going to implant?
Yes,
Dr. Arun?
I'll come to that also. I'm not getting any irrigation aspiration. So let me first finish with my irrigation aspiration. ऊपर से सलाइन एक्स्ट्रा हटाइएगा। So now all the cortical matter is out. Can I have viscode? Open the lens, please. So this is a 22.5 diopter lens. Viscode first. Now, so here is the lens. This is a multi-cert lens. And if you can appreciate that there's a 1 written here. Can you appreciate this one? Can you see that?
Yes, yes.
Is it visible?
Yeah.
Written here, and then there's a 3 written here.
Yes.
So this is a preloaded lens, and if you can see that there's a nozzle here.
Yeah.
So it stops this nozzle, the injector going too much inside the anterior chamber. So first we'll see that there's a 1 written here. So you put in a viscoelastic HPMC दे दो, कुछ ही दे दो. So what you do is you put HPMC through this or any viscoelastic, and you can see it going inside. Can you appreciate that?
Yes, yes, yes.
Yes. So we have put in the viscoelastic. Now we come to number 2. So you press these two and you remove this cover from here.
Sir, deep set.
Now there's a 3 written here and 3 written here. You press on these two side things and push it forward, and now your lens is loaded inside the cartridge. You remove it from the packing. Now the beautiful part of this insert is that you can see it can be inserted by rotating this, or it can be inserted by pushing this nozzle. So it has a dual function. You can either rotate it if you are used to doing a bimanual incision by rotating, or you can just push in the lens like any other lens you do. The beauty of this is that it is so smooth, it goes so smoothly. So here I go, and here's a stopper. Now with the new insert system, I prefer to just push it inside. Bahut sir ko thoda sa idhar rakhe. And it goes in so smoothly, and you will observe that it opens up so slowly and gradually. Dialer. And this lens can go through 1.8 millimeter very, very easily, very, very comfortably. Well centered lens. Now the surface of this lens, active oxygen ingredient, which inhibits the lens and equatorial cells to grow. So if the next case is ready, you can take this microscope. I'm over with my case. We can finish the next case with us.
Thank you so much, Dr. Arun, for demonstrating.
Thank you, Dr. Arun.
wonderfully.
And
Can you have the microscope?
before I hand over the microscope, I would like to show you the injector. Tanker nahi diya? Inject. Wo kahan hai? Cartridge injector. Acha, they have thrown it, but I wanted to show you once again. It's so easy to push that lens through it, and it goes so smoothly and so easily. It's like cutting through a butter, a hot knife cutting through butter.
Dr. How many cases you have done so far?
No, I have done somewhere between 500 to 1,000 cases.
Okay.
And my experience has been excellent with this. नहीं वही वाला अपा वो उधर कर दी चलो ये दे दो फिर.
There is no damage to the haptic or
Never. I have never encountered any stuck haptic or any other complication with this lens. This is a great lens. नहीं आएगा.
Thank you so much, Dr. Arun.
Thank you very much.
Dr. Jhala, can you hear me?
Yeah.
Okay, so now we are shifting to table 1. Dr. Partha Biswas is going to do IHANS, IOL implantation in this case.
Okay.
Welcome, Dr. Partha Biswas, sir.
Yes.
Committee of Quality of
Can you have the mic on? Yeah, Dr. Pathas, please.
राइट नहीं राइट पे फुट पैडल ऑफ द मशीन फेको मशीन होगा. बेंड करना है इसको बेंड करेंगे और सब.
Yes.
फुट पैडल ठीक करो यार.
This is also the Zeiss. The microscope is from Zeiss or other company?
No, I'll just.
Yes, sir. Dr. Jhala, yeah, please.
This microscope is from Zeiss or from some other company?
Microscope.
Dr. Partha is using.
Dr. Partha
ये
is
वाला
using
राइट
Lumira eye.
में,
Yes.
ये वो लेफ्ट पे.
Size Lumira.
बाईं तरफ दे दो और बीच में जो है ये.
Can you have the microscope view of Dr. Partha of table 1 microscope view? Yes.
Dr. Partha, sir, is world famous for making the court martial for ophthalmologist, and he has done this presentation, I think, in 60 countries.
Thank you very much. Am I audible in the hall?
Yes, sir. Yes, sir. Good evening,
Okay.
sir.
Good evening, everybody, and it's wonderful to be here in Kota and at Suvi Hospital. The wonderful facilities are all here for everyone to see. So I'm going to try and make a cystotome out of this needle, which I'm doing, I think, after 10 years. Okay. But I have Yashwant with me, so I'm very, very happy that Yashwant is going to assist me, and I've seen his movements. They are so apt and excellent that I think, he's comfortable assisting any surgeon. There we are. So this is what happens if you make it after 10 years. So give me another 26 gauge और एक दे दीजिए. हाँ, एक और 26 gauge needle दीजिए मुझे. This is a patient with a deep set eye, and the draping in such eyes are very important. So it's important that we do a good draping for these patients. And Yashwant has really been able to do a very, very good draping for this patient. So and I'm going to use the Signature Pro machine. Now, the Signature Pro machine is definitely one of the best machines that we have. And of course, all of us are really spoiled with the benefits of all the machines that we have. So as you can see that a little bit of damming is there because of if there's a deep set eye. Mata ji, aankh se seedha dekhte rahenge. But our patient is an excellent patient, and she is very, very cooperative, I think. माता जी सीधा देखते रहो जी, हल्का नीचे देखो माता जी, हल्का नीचे. हाँ, बस बहुत बढ़िया. So we are using the side port knife from Halcon 1.2. सीधा देखिए माता जी अभी. हाँ, बहुत बढ़िया. A little bit of oculant so the patient is comfortable. So should we use oculant for every case, or should we not use oculant for every case? That is a question. I do think the benefit of oculant is great, and to use anesthetic to set the patient in a position so that he or she can cooperate well. Wash दीजिएगा.
Yeah, I think, sir, patient is very comfortable if we use Oculan, especially
नहीं,
during
wash.
IL implantation
जल
and all
दीजिए,
those where the
पानी
pressure
दीजिए.
becomes very
BSS
high.
दीजिए, BSS दीजिए. हाँ जी. Just wash it off with BSS.
What is the opinion of the panel? Do they use Oculan or lignocaine in every case of topical cataract surgery, or Dr. Ghulam Ali?
We should use Oculan in every case.
Yeah, I use in all cases.
Yes.
But I am asking Dr. Partha that with the patient with such a good glow, you use
gel दीजिए, methyl cellulose.
stain in every patient.
So we, हाँ जी.
You use stain in every patient with good glow also.
Oculan in every patient, and even for my
staining
phakic-
is using.
Staining of the capsule.
Staining, no, trypan blue, not in every case, sir. But I just thought that, we need to do a good Rexis, and especially with such stalwarts watching. So I don't want to err in my Rexis. And
You mean to say you are use stain in every life surgery?
No,
Yeah,
that also not, sir. But the visibility of the Rexis comes on very well if we do a good staining for the
It
patient.
varies from state to state. In Rajasthan, he uses.
Rexis दीजिए. ठीक है, दिस इज फाइन आल्सो। सीधा देखिए माता जी, सीधा देखिए। So I've used viscoat and after that methyl cellulose. So the benefit of methyl cellulose and viscoat is very much there. And usually I also use a Rexis marker, which really gives a good assessment of what is the Rexis size that we are doing. So,
Sir, which axis marker you use regularly?
5.5 or 6 millimeters Rexis marker is what. Now what has happened is the Rexis has run out.
नीचे लगा देना.
Micro forceps दीजिएगा. Micro.
नहीं, माइक्रो फोर्सेप्स.
माइक्रो फोर्सेप्स देना है, मेन पोर्ट देना है और माइक्रो फोर्सेप्स देना पड़ेगा. मेन पोर्ट दे दीजिए, माइक्रो रेक्सिस फोर्सेप्स देंगे. ये क्या ये फोर्सेप्स है, रेक्सिस फोर्सेप्स है क्या? हाँ, ये रेक्सिस फोर्सेप्स. और एक फोर्सेप्स दीजिए मुझको, और एक दूसरा फोर्सेप्स है साइड पोर्ट के लिए. ये जल्दी
अमित मिश्रा. हाँ, क्या करूं?
अच्छा, ये दीजिए रेक्सिस. वो नहीं चाहिए.
प्रकाश को
नहीं.
किस साइज में? परफेक्ट.
रेक्सिस फोर्सेप्स.
रुको एक मिनट, रुको. निकालना है यार. लो आ जाओ. ज्यादा बॉस.
So we have been able to pull in the Rexis. It had run out. Now
वेरी गुड.
hydrodissection. Hydrodissection चाहिए.
बढ़िया है, बढ़िया बढ़िया. यही है, कोई नहीं. बढ़िया. Which one?
जल्दी इसको देंगे थोड़ा. रोटेट करना है, सीधा देखते.
पांडे बॉस.
Start. सोनू सोनू बाबा को भेज देना, वॉश करवा दें.
Not a very free rotating, so I think hydro dissection दीजिए, hydro दीजिए थोड़ा सा. जल विस्को दीजिए, फिर रोटेशन दीजिएगा, रोटेशन दीजिए. लाइट थोड़ा सा बढ़ा दी, लाइट थोड़ा बढ़ाना पड़ेगा. So now it is freely rotating and chop. नहीं, लाइट को बढ़ाना है थोड़ा. फेंको दी, हाँ फेंको.
होगा होगा देख लेते हैं. हाँ
हाँ ठीक ठीक है.
बोल देता हूँ.
So it's approximately a grade 2 cataract. सिंस्की है क्या? केवल सिंस्की दीजिए मुझको. सिंस्की हुक. सिंस्की है क्या? यही दीजिए, दे दीजिए, कोई बात नहीं, दीजिए दीजिए वही. हाँ ठीक ठीक चलो. माता जी थोड़ा सा दबाव पड़ेगा, हिलेंगे नहीं. थोड़ा सा सर को आगे कर लीजिए हमारे तरफ. हाँ
एक मिनट, एक साइड में ना. अरुण बॉस नहीं है.
So we've been able to chop it and बस जल नहीं दो, आप रहने दो प्लीज. So this is the beauty of the machine. You can see it's otherwise very stable. The chamber is quite stable. मेरे तरफ कर दो यार. हाँ. Epinucleus please. Epinucleus please. Epinucleus. Are you at epinucleus? Oh, thank you. By manual please. जल 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 विस्को ये वाला ब्लॉक है. आइए दीजिए प्लीज. So a runaway rhexis is always something that has to be dealt with a little bit of patience. One in the armamentarium, definitely we need to gel दे दीजिए please थोड़ा cornea पे gel दीजिए. आइए है आइए पे है कॉटेक्स पे है ओके थैंक यू हाँ ठीक चलेगा
ये हो रहा है ना ये तो इसके बाद अरे बेटा क्या एक मिनट रुक जा, गीता जी का चल रहा है अब डॉक्टर वीरेंद्र का शिफ्ट होना है शिव नारायण व्यास क्या बोला अरे ये नहीं है ना क्यों कंफ्यूज हो रहे हो डॉक्टर वीरेंद्र अग्रवाल ये रहा ना कि शिव नारायण व्यास अरे रमेश चंद नहीं ना यार शिव नारायण व्यास लिखा हुआ है ना क्या
माता जी सीधा देखते रहना
पेशेंट बाद में होंगे जो होंगे हाँ
Partha sir, you always use bimanual or coaxial?
Always bimanual. So I do think bimanual has a lot of advantages, and though the coaxial is also something that people use with a lot of dexterity, but I'm very comfortable with the bimanual.
ऑडियो विजुअल किधर है
Lens, please. So we are going to put an eye-hands lens. And let me tell you about the machine that we worked with. The Signature Pro, of course, has the benefits of both the peristaltic as well as the venturi. And the benefits of this machine is also that it has the white star technology where the duty cycle can be altered. And that gives the efficiency to the machine. So this is and eye hands, of course, the lens eye hands that we are going to use again is the eye hands lens again is a lens that we are using very regularly these days, and because the benefit of an intermediate vision is there. So the quality of vision is what the technics quality is, which is that wow factor that we really get for after the first post-operative day. So the eye hands again, we constantly use it for all our patients, even with diabetic retinopathy and where the contrast is not compromised. So the benefit of this lens is huge, and it's a single piece lens which we can use. Push there, hai na? ठीक है. And we can push wala push hai kya? Acha. If we had a push cartridge, then we could have inserted it in the hydro or in the BSS, but I've been given a cartridge which is the screw type, so I will have to inject visco and then नहीं ये निकल गया है दोबारा लोड करना पड़ेगा
इसको अनस्क्रू
अच्छा लाओ
अब वापस इसको
लाओ देखें होता है नहीं पूरा आ गया
you have to remove it fully. Dr. Partha, meanwhile they are loading the lens.
Yeah.
Can you tell us till what astigmatism on the cornea do you prefer these lenses?
So best less than 1, beyond 1 an astigmatism, and especially in these days where we want to give a refractive solution to our patients, it's best to go in for a toric, and that is the reason why I think most of us are doing torics beyond 1. Even if I'm using the Catalyst platform, even then beyond 1, I would like to use the toric lens, which gives a very, very stable toric control. And the astigmatic control with all our toric lenses are excellent. So जल दीजिए मुझको, पहले जल दीजिए. हाँ.
Sir, how to counsel the patient for IONS?
Yes, sir.
Can you
How
repeat?
to counsel the patient for the IONS lens?
Counseling the patient is very simple, sir. If we ourselves believe, ये 2.2 का है ना? बड़ा है, अच्छा ठीक है, थोड़ा सा, because I made a, इसे को दीजिए, because we made a 2.2 millimeter incision, so I'll just increase the incision a little bit.
And what is your preferred
lens दीजिए, please.
post-op power which you aim for? Is it 0 or 0.5 with
So,
eye hands?
Yeah, 0 or 0.5 with eye hands is again important question. माता जी सीधा देखते रहेंगे, है ना? आराम से रहेंगे. So this is the same platform as the Technis, and it has the square edge design, and it goes in very, very well. And if we are doing it with the push, then of course, as I said, that we can implant it with the hydro itself, hydro implantation, which is something that I prefer all the time. You don't need to clean up the visco, and chance of a post-operative IOP rise is not there. Because my rexis ran out in this position, so I've placed the haptics on the opposite end, and we'll आइए दीजिए please. So I do think I have court-martialed Suresh, and Suresh today court-martialed me with this runaway rexis. हाँ Suresh, ठीक है, चलो बराबर हो गया.
You manage very well, sir. You always say doctor. When you handle situation, learning is not doing the perfect surgery.
And I mean, really able assistance by Yashwant, really been very, very fast in assessing. So I just lifted the lens a little bit so that, we could take off the viscoelastic that is there. I don't want this lens to rotate and into the position where, where it is a little deficient on that side. So just to keep it as central as possible. And our patient has hydro DJ, please. Patient has also been very, very cooperative.
Excellent surgery, Dr. Partha. Very nice.
हल्का नीचे देखा माता जी, नीचे देखिए माता जी.
Can we shift the transmission to the other microscope, please?
और थोड़ा सा दीजिए.
Audio,
और थोड़ा
audio
सा.
visual.
Yes.
Yeah. So now this is another case which Dr. Suresh Pandey is going to operate. Dr. Suresh, can you tell us about the case and which lens are you putting in? Yes. You are online. Doctor, नहीं वो दो ही
ये Vigamox देना है? Vigamox देना है क्या? Thank you very much. Thank you,
Thank you, sir. Thank you.
यार उनके पास है क्या?
सर्जन को देंगे तो बेटर रहेगा ना.
Excellent, sir. Congratulations. Congratulations, Dr. Partha, sir. Am I audible?
Yes. Dr. Pandey.
Yes. Good afternoon, everyone. I welcome you all. And today we are very fortunate to have all the big shot and pioneers in ophthalmology, Dr. Partha Biswas, sir, Dr. Virendra Agarwal, sir, Dr. Sheetal ma'am, Dr. Amulya Sahu, sir, from Mumbai, and Dr. Pankaj Sharma, Dr. Sonu Goyal, Dr. Harshul Tak, Chairman Scientific Committee, ROS, and so many surgeons. We are very lucky to have you all here, and we welcome you once again to the OT of Suvi Eye Hospital. Today, I'm going to show you a case of Sifi manual lens implantation And this is a 61-year-old patient, and he's he's very outdoor. He's very fond of outdoor activities and dramatics, and so that's why he does not want any glasses. So we would like to show you the technique of cataract surgery with CP mini-well lens implantation, and with the availability of CP mini-well proxa, we have well fusion technology where you can implant the CP mini-well in the non-dominant eye and CP mini-well proxa in the non-dominant eye. So here you can see I have already done my rexis, and now I'm using the Centurion phaco machine. You can see this machine has wonderful followability, and the pieces are coming to the phaco tip. This is my another fragment where I'm just trying to remove the fragment with the Alcon Centurion machine, and you can see how nicely this machine is eating the fragments, and the cataract is out. This is only one piece here which I'm going to, and I always use the combination of cohesive and dispersive viscoelastic, and my preference is the conducting based viscoelastic, and with the availability of the sodium hyaluronate like Giant Plus, this gives an excellent coating to the corneal endothelium. And as you have seen that the lens is out, and now I'm going to remove the cortical material. I always use bimanual irrigation aspiration, and the advantage of bimanual aspiration is that you can access the capsular fornicage 360 degree. Here you can see the bimanual irrigation aspiration being done, and this is a wonderful technique. You can see how nicely the epinuclear plate and the cortical material can be removed from the capsular bag, and you see this is the epinuclear plate is coming out, and you can use the bimanual device to remove the cortex and epinuclear plate. And here I'm just going to change the bimanual irrigation aspiration system, and here you can see the epinuclear plate is coming out, and you can just go behind the epinuclear plate, and then this will dislodge the epinuclear plate. And notice the wonderful followability of the Alcon Centurion machine. And here you can see how nicely the epinuclear plate and cortical material is coming out, and the case is almost about to finish. And now we are going to remove the residual cortex, and then I will going to implant the CP mini-well lens, in this case 19.5 diopter. So this is the beauty of the bimanual irrigation aspiration, that you can really go in the capsule fornicage and remove the cortical material. And once there is some residual cortex is there, as you can see in it at 12 o'clock, you can change the bimanual irrigation aspiration, and then you just remove the residual cortex. And now I'm going to show you the implantation of Zydus CP mini-well lens. Here, this is the 19.5 diopter Zydus CP mini-well lens, and here this is a preloaded lens, and the beautiful this is preloaded lens. You hold with the left hand. I'm holding with the left hand. I'm left-handed surgeon, and you just see the click. This is a click here, and then you just put some viscoelastic. And here I'm just putting some viscoelastic here, just little amount of viscoelastic. And after putting the viscoelastic, you remove this is the part, and then just close this part, and now lens is ready to go. So this is a Zydus CP mini-well lens, and just you push it, and just you can see it should come out very nicely, very smoothly, without any problem. And the pupil is little smaller, so I'm just going to fill up the bag with the viscoelastic, and make sure that you fill up the bag with the viscoelastic nicely. And I put the HPMC on the top of the cornea. Dollar. And then here, this is the injector, and just this can be implanted through 2.2 millimeter, 2.8 millimeter. Here, I'm just using 2.8 millimeter. And here you can see the lens is going to be delivered in the bag. And this is the trailing haptic, and this is the mark here. You can see this mark should be on the right side. And this is, you can see this is very nicely, the CP manual is being unfolded. Just be slow and take your time, and then you just put in the bag. And you can see this looks like monofocal lens. This is EDOF lens. There is no diffractive rings. You cannot see any diffractive rings on this lens. And this has the positive and negative spherical aberrations at the 3 millimeter central optical zone. And the proxa, CP manual proxa have a combination of negative and positive spherical aberration at the 4 millimeter central optical zone. And the advantage of this lens is that this gives excellent vision for near distance and intermediate. And with the combination of CP manual well fusion technology, you can implant the CP manual lens in the dominant eye and proxa in the non-dominant eye, and that will give you very clear vision at 33 centimeter, very clear intermediate vision and clear distance vision without any incidence of glare and halo. Yes, sir.
What is the advantage of 4 haptics lens over routine lens? This is 4
I'm
haptic
removing the
lens.
viscoelastic behind the capsular bag. So, and glaucomatous cases also, and this have very good contrast sensitivity with 95% light transmission. And so far I have done more than 500 cases of CP manual lens implantation with excellent visual results in almost every case. And this is one of the best technology which I prefer for my patient who want independence from glasses and who wants excellent vision for near distance and intermediate. And you can see the surgery. I have finished the lens implantation. Now we are going to seal the incision, and the surgery is over now.
Beautiful surgery, Dr. Pandey. Thank you very much.
Thank you.
Dr. Pandey, is this lens dependent on pupil size?
Yeah, this is dependent on the pupil size.
Did you assess the pupil size before surgery?
Yes, I assessed the pupil size before surgery.
How much is the pupil size required to work it normally?
The pupil size should be like, should not be very people, and most of this young patient, like this is young case, and in the old cases where the pupil is very small, then it may. I have done a couple of cases with the smaller people also without much problem, but this is a young case, and he's a like he's a stage artist, so he needs some without glare and halos. So that is the reason why we selected this lens, CP manual lens, and he's an artist, and
what did you injected in the last? The turbid something turbid.
I put the intracameral moxifloxacin and intracameral triamcinolone.
Why triamcinolone?
Triamcinolone. I just use small amount intracameral triamcinolone in almost each of my cases. It's like 2 milligram 0.05 ml, and this gives very quiet eye next day. Intracameral injection of preservative-free triamcinolone injection. This gives very clear cornea and quiet eye on next day. And this is the how it lens comes in the package. And thank you so much for your kind attention. Thank you once again.
Thank you, Dr. Pandey, sir.
Thank you.
That
Sir.
was a wonderful
Thank you, Dr. Sonu. Thank you.
demonstration of the EDOF. Do you do mix and match in this?
Yes, sir. I do mix and match. I put CP manual in one eye and prox in another eye.
Wonderful. And I think it gives you, without any positive dysphotopsia, glare and halos, a wonderful all continuous vision. So next now we have Dr. Virendra Agarwal, who is implanting Synergy Toric. So I think Johnson and Johnson in their basket have got a wonderful full range of lenses. So I think Dr. Virendra Agarwal, you would second me that?
Yes.
Right from their Technis One platform that they have started. So I think from Technis One platform to their Toric, and then came in their multifocals, then came in the Symphony, and now on the Technis 2 platform, their Torics with their frosted haptic designs. And now this Synergy, which is again a CRV or a continuous range of vision lenses, and came in the Synergy Toric lenses. So I think Synergy Toric would be a great boon. Yeah, Dr. Virendra Agarwal, what will be your preference for Toric? So what is the
Mike? Yeah, I think what Sonu has spoken about the Technis platform and J&J, it is growing like anything, and I'm very, very happy with the lenses, the Technis platform lenses, and particularly the multifocal lenses. शिवनारायण जी हिलना नहीं है, लाइट में देखना है.
Dr. Virendra,
I am audible. Yes.
Just tell someone to tell us what is the criteria, what are the astigmatism and anything pre-op data. Show us the pre-op data.
Sonu.
Pre-operative workup of the patient, please show us.
The axis of the cylinder is 176 and the amount of cylinder is 1.25 on cornea. I hope model is 2.25. I prefer using MVR for my side ports. Just a minute, let me increase.
So the axis of placement would be
Light में
176 here.
Yeah.
And
शिवनारायण जी हिलना नहीं है.
Sonu, not audible.
Can you hear us now?
Yes.
So this Technis Synergy, he's doing on an axis of 176. It is a 19.5 with 1.5 diopter cylinder. And as all we know, that more than one diopter of cylinder would be a choice where you would, always do a toric lens as compared to plain non-toric. So the beauty of this Synergy Toric is that the haptics are frosted. So I think this gives an excellent rotational stability once this lens goes and sits inside the bag. And the Synergy platform, combines the beauty of both the worlds because it has the beauty of their Technis multifocal, which has been a proven platform, along with their Symphony, which came as an EDOF lens. So combination of Symphony and the Technis multifocal gives you a continuous range of vision, and it takes care of the chromatic aberrations and gives you that extended depth. So on the proven Technis 1 platform, with their toricity, the stability being taken care by the Technis, the Toric 2 platform with the haptics frosted, I think this works wonderful when you are addressing the presbyopic patients and you are fulfilling the needs for these patients who require continuous range of vision IOL. So very beautifully, Dr. Virendra Agarwal is demonstrating here, and the axis has been marked. He'll be placing the lens at 176. So fashioning a rexis, and I think we both are blessed to have the Catalyst platform from again Johnson & Johnson, which gives you exactly the round regular axis of maybe 5.2 millimeters, which is required in most of these patients. So I think the effective lens position when you are dealing with these premium patients is very important, because these patients do not want any residual refractive error. So I think attaining emmetropia is one very important key factor when you are taking care of these patients. So a good biometry, preferably an optical biometer, and a good surgical outcome starting from a good centered rexis.
In this case, because of the marking on the center of the cornea, visibility is slightly compromised. शिवनारायण जी लाइट के बिल्कुल बीचों बीच देखना है, हिलना नहीं है, दोनों आप खुला रखना है. Thank you, Sonu, for giving the brief about the Synergy Toric and the Technics platform.
So, Virendra, why the marking on the center is appearing? Why not only the margins?
My assistant applied that dye on all the part of the marking.
Okay.
It has come in the center.
That's why this is becoming difficult for you now.
It is giving me some compromise in the
So,
visibility.
Actually,
I'm
Dr.
not
Virender
seeing-
is used to using his markerless system. I think he's beyond all these marking systems. I hope I'm correct, Dr. Virender Agarwal.
You are right.
You're
I'm not
blessed to
using
have all
nowadays-
those modern gadgets.
Nowadays, I'm for almost 6 years plus, I'm using markerless thing. शिवनारायण जी, please हिलो नहीं, लाइट के बीच
So
में
I think
देखो.
with the markerless online systems like Callisto or on the Alcon platform, you have that Virion. I think this gives you that level of accuracy which is required when you are dealing with these toric IOLs, and as close to 1 degree what you require when you're dealing with toric IOLs or toric ICLs. And specifically, this holds true when you're dealing with high level of astigmatism. So astigmatism more than 4 diopters or 5 diopters, even a small degree of off axis would result in very high error, post-operatively high error of refractive situations.
There are many people who do direct chop. I prefer to make a small trench. Okay. Today I am doing with the Kelman tip. I usually do straight tip, but let me try this also. The machine is beautiful, as Dr. Partha has said. I am keeping the bottle height of 50. Uncle ji, please hilo nahi.
So Dr. Virendra Agarwal is here using the Signature Pro, and his settings are aspiration is 28, vacuum is 200, and the power is 40. So I think again, the Signature Pro from the Johnson & Johnson is a beautiful system, and me and Dr. Virendra Agarwal has been using for almost 10 years, I believe, more than 10 years.
More than 10 years.
So the handpiece gives you both the longitudinal as well as the torsional cutting, and on the fly with the beautiful foot pedal, you can switch between the Venturi and the peristaltic mode on this platform.
Even with the low vacuum, I can hold and divide. So I prefer to do division into bag itself with a very low power and low vacuum also. Sometimes you can use high vacuum depending on the type of the nucleus. This nucleus is not very hard and is getting hold with the low power and low vacuum. So I am using the same. Doing this thing into the bag itself gives you an advantage that it saves the corneal endothelium, and the next day you can see the cornea which is clear. The another advantage that Hiloni, uncle, Hiloni, please.
So I think Dr. Virendra Agarwal, you would
try to fill the again and again with the visco, but I can use visco whenever required, and I do them into a different small pieces, 6 to 8 pieces, and after this, when I will shift to the phaco chop or direct setting of increased vacuum, Hiloni, uncle, please, Hiloni.
So
So I have now I
one
increase
good
the vacuum. Please, bahar se. So now the vacuum is 450, and you can see the chamber is stable. All the pieces are coming in the center itself.
So I think this excellent chamber stability comes from the foot pedal and the responsiveness. So I think this equipment gives you a very high response rate. The moment there is before the shallowing, it responds and the chamber remains rock hard stable, even in conditions like this that you see.
I hope I am centered. My lower half is not having a corneal clarity, so I have to do all phaco in the superior half. My bottle height is again 50 centimeter only, and vacuum is 450. With this also you can see that the chamber is stable.
So I think with the
लाइट में देखते रहो, हिलना नहीं है। आइए, ये थोड़ा लंबा करना है, चलो। So as Sonu was saying in the beginning that the platform and the advantage, the chromatic aberration is the biggest advantage of the new multifocal lenses, because this chromatic aberration gives a very sharp vision. The another thing is it is having a blue light absorption, UV light absorption, and because the UV light absorption, the basic glare coming for nowadays light, which we are LED lights, can also be reduced. That was my
So I think most of these LED lights would have that violet spectrum, and this lens, the Synergy, beautifully blocks the violet wavelength. So I think that is one very key factor which helps in preventing those starburst and the other photic phenomena. And at the same time, Dr. Virender, you would agree, when we compare the different trifocals on various platforms, I think this gives a very good vision even in low contrast situations.
I will share my experience that whenever I used to implant multifocal lens, in my room I have 4 tube lights and 1 tube light is behind the patient. So whenever patient comes with the multifocal lens, my code was give the newspaper number 1. So number 1 was that make the patient light on which is behind the patient. And by the time patient have the newspaper, the light is on and he start reading. But one day there was one smart patient. He asked me, "Sir, ये तो light बढ़ा दी है इसलिए मुझे दिख रहा है." अब now there was no other choice to keep that light off. So then what I did, I asked the attendant to keep it off. He did that. He was reading. Then I become courageous and I asked to stop the another, then third, and then I asked, should I stop all the lights or keep the lights? So he said, I am happy. It can be done in the very low light conditions also. So that is the biggest advantage of this chromatic aberration, that the lighting is not required as a much one. At the same time, it increases the depth of focus. The another advantage with the Synergy experience without toric, that my patient actually reads at all the distances wherever he wants. The initial experience was that I used to say that for multifocal lenses, I have to teach you because there is a lens with the new working system for which you are not tuned. And now I ask him to hold at his convenient distance and he is reading. So that is the biggest advantage, that all patients are happy that they are working without depending on the glasses and required to change the practice or the habit of holding the books or whatever. Nowadays, we are lucky that majority of the patients are not reading on the newspaper many times, and they are just using gadgets which are otherwise also helping to give a good near vision. And with this, I am very confident to implant in even VIPs. And there are people who say, and the last conference I learned from the Dr. Titial, that the patients who are particularly politicians, they never complain. Yeah, change karo.
So I think
I'm just holding because bottle is being to be
the
changed.
incidence of positive dysphotopsia, the glare and the halos in my practice has also been negligible. I think you would second that, Dr. Virender.
Yeah, what I feel is that the negative dysphotopsia, the moment patient says something, we actually know that there is a negative dysphotopsia. So we also agree to the patient, and we never ever try to ask him to bear with something which is not expected by him, to give time to resolve. So now that complaint is also reduced. That is the advantage. And here I will request everyone that please don't speak anything negative for the multifocality. Dr. Suresh Pandey has shown a very excellent way to control or give vision for the near vision without a multifocal lens. But multifocality is more precise in my experience, because patient is having actually crisp vision at least for at least one fixed distance. With the continuous range of vision Synergy IOL, that requirement of continuity is also there. So I think we all can implant this new lens.
So I think the message through this podium should be that presbyopia has to be addressed. And with the use of these modern day lenses, it can be safely addressed, but it is the choice of the patients which is very important. And the quality of the surgery and a good optical biometry has to be ensured to get an optimal result. And I think, Dr. Virender, you would agree that in cases of astigmatism, you have to ensure that it is always a symmetrical astigmatism. Never ever in high astigmatism you should do without a topography, because these could be cases of aborted keratoconus or some kind of abnormal corneas where you would end up in a lot of patient dissatisfaction.
Yeah, this was the same message I spoke in the morning itself, that now it is not cataract surgery, it is a cataract refractive surgery. And patient expectation are based on the experience of the somebody else, but everybody's eye is different. So you need to assess that particular eye, how it is going to behave. Pollution. There is some plaque in the posterior part, but that is coming within the range of this marking on the cornea, but I will try to do some polish. And this is a special polisher which I'll be using through main port, and I will try to do polish of that part. I don't know it is visible over there or not, but
yeah, it's visible.
Virender?
Yes, sir.
If given a chance between two, EDOF IOL with a good near vision as well as versus the multifocal IOL, which one would you like to prefer?
For myself, you are asking for, or for you?
No, for any
For
patient.
everyone, for everyone.
For anyone. For
I'm
anyone.
lucky to use all kind of EDOFs. Whatever comes in India, almost I use all. EDOFs are not bad lenses, they are good lenses. But what I say, when patient demands that I should be having a very crisp vision for near, particularly for a particular distance, then multifocality is the answer. Because EDOFs are not that reliable. And the second thing, let me tell you, most of the EDOF companies claim that the patient will not see ring. All companies lenses I implanted of EDOF, they say I'm seeing 1 or 2 rings. So that is a one big thing which we feel that is not there, is there. With multifocality, the rings are multiple. So that is deterring us to use it. And unfortunately, many people who are not using, they just pass a passing remark like that doing multifocal will be a disaster or a problem or something for you. That's why patients are more afraid of. But believe me, though the technology need to be improved, and it will improve, I think the Alcon, Johnson, and many other companies both are trying for multifocal business as a big business for the future, and they are thinking to grow on this line only. So the multifocality will become better, and definitely it should be there. But with the use of this continuous range lens, as Sonu was saying in the beginning, when I started doing the Symphony lens, I thought the answer is there. But believe me, my first comment to the company was, had it be having 2 more rings, the Symphony will succeed. Because patient wants near vision as a crisp vision when you say it is a multifocal lens. And that somehow EDOF lenses are not there. Some experience with some surgeons on a limited number of basis is there, which is very good, very good. And like the IANS, Dr. Partha has shown, it is giving some vision for the daily routine work, but is not fulfilling the need. Because in India, still there are people who want to read the print. There are people who are on the gadgets, but there are still many patients who are for the print. And let me tell you one experience again with the Symphony. I implanted one patient, and she came from a reference of a very good, happy patient of multifocal lens. That time the new lens Symphony came, I implanted. And after implanted, she was very unhappy. I was very happy that I have done centered everything. She should be happy. But the moment I saw that she was holding the newspaper and her arm length was very, very small. She was not having a normal arm length, and she cannot hold the things at a distance. But with the synergy I am seeing, that arm length factor is also not working. But definitely my experience says whenever you implant a multifocal lens, before implanting, ask him at what distance he wants the multifocal part or a near vision part, or let him tell that you will be having a vision at this distance. All EDOF lenses are having 40 plus centimeter for near vision, and which is not happy. And for the synergy, my experience says, though company recommends that all lenses should be implanted with the aim for 0.25 hypermetropia or 0.5 hypermetropia, I am doing them 0.25 myopia, and even to the 25 plus centimeters, they are having a near vision. Though the company says that with this, the glare will be more. But my experience of increased glare is not there. So I am keeping my A constant to keep the lenses slightly on the myopic side. not more than, preferably in any case, 0.5 is the upper limit, but between 0 to minus 0.25 or whatever it comes, the near first minus value is my aim.
But some new ADOF lenses are coming up with the claim that near vision would be 30 mm only. Let us see what will happen.
Believe me, I implanted all the lenses on the market for EDOF, all the brands, no negative and no financial interest for this particular company. But I am sharing, Shivnanji, light ke bilkul beech mein hi dekhna hai. At the end, the lens should be tapped and placed like the Purkinje images in the center. That is a must for all multifocal lenses. हिलना नहीं है, हिलना नहीं है, लाइट के सेंटर में देखना है. That is a take-home message that all multifocal lenses require more centration or better centration than other lenses. Though all the aspheric lenses, they need centration because decentration of 0.5 millimeter beyond is not tolerated by the aspheric lenses. In that way, spherical lenses tolerate it much better.
Please shift to the.
Thank you very much for this opportunity at the ROS. And I must congratulate Dr. Suresh Pandey and his team and staff who are very cooperative, and particularly the patients who are waiting for a very long, but still they are cooperating with us. Thank you, Shivnan ji. बहुत अच्छा ऑपरेशन हो गया. आंख बंद कर लो 2 मिनट.
Please tell us about this patient and the surgeon.
Sandeep boss, can you hear me?
Yeah.
Yeah, I am Mayank Agarwal. I am operating this patient for IPCL. It's a toric IPCL. I have made the main port and injecting the viscoelastic. I'll be putting a toric IPCL V2 model supplied by IOC side port.
And somebody can show preoperative data of this patient?
Yeah. Harshul, can you help the operative data?
Harshul, Sonu.
Visco then.
This is the pre-op data. Diffraction is -9 diopter. Dr. Sandeep, am I audible?
Yeah.
Yes, this is the pre-op data of this patient. Where Dr. Mayank is doing surgery. The refraction is -9 diopter spherical with -0.75 diopter cylinder. And the white to white horizontal corneal diameter is 11.32 millimeter. So we are implanting, Dr. Mayank is implanting IPCL T125 V2 model, and he will be, this is smart toric lens where you need to just mark the 0-180 degree, and Dr. Mayank is showing the demonstration of loading the lens.
Dr. Pandey, with the 0.75 degree of astigmatism, is it necessary to put a toric lens in this case? Why not normal lens?
Yeah, this is the cylinder is 0.75 diopter, so they consider the pre-existing astigmatism, and in this particular case, the flat axis is 180 degree. So that's how they, in order to compensate that the incision induced astigmatism, they added the cylindrical power to compensate the SIA, because the steep axis is 90 degree and the flat axis is 180 degree. And we are going to, Dr. Mayank is going to make incision at temporal side, and he's going to position this lens at 0-180 degree.
So this is the IPCL provided by Care Group. You can see 4 holes on the optic haptics. You should concentrate on this hole. This is little triangular shape. and this hole should be on your left side. These two holes on the optics should go superiorly. So as I am operating the right eye, these holes should go superiorly. Therefore, I'll be putting this lens the other way around. So this triangular hole on the leading left haptic, these two holes will go on the superior side of the patient's eye.
Can you show us again that triangular and?
So there are four holes. This one is a little triangular shape.
Okay.
These holes are round in shape.
Okay, okay.
This is
Fine.
triangular, this is triangular, this is round, and this is round.
Okay, so the triangular one should be on the anterior.
Left leading should have this triangular hole. These two holes on the optics should lie on the superior side so that they are covered by the lid of the patient. So this lens goes with a 2.8 millimeter incision. So I have fashioned a 2.8 millimeter uniplanar incision, and it's a hydrophilic lens.
Dr. Mang demonstrated very nicely the correct orientation of this lens, IPCL, toric lens, and it's very important to place it correctly. And you can see the loading part is much more easier than the ICL. And you can use.
So now you can examine that in the shaft, my hole is on the left side. So you have to continuously see that left leading haptic. Yeah. I'll zoom in.
What will be the incision size?
2.8 millimeter.
Okay.
Oh. Sir, एक second sir, मैं कर रहा हूँ. I'm doing it.
And anterior chamber depth requirement is as same as with the ICL and other phakic IOLs?
Anterior chamber depth in this case was 3.19 millimeter ACD internal, and the pachymetry reading was 495. So therefore, LASIK laser refractive surgery was not possible because of thin cornea, and C has very good anterior chamber depth. The ACD internal was 3.19 millimeter.
So what is the minimum criteria of depth, Dr. Pandey, to select this?
The minimum criteria for the phakic lens you can put in all cases with ACD more than 2.9 millimeter.
Okay.
And for ICL star, they recommend 3 millimeter.
Yeah.
I think the FDA criteria is 3 millimeters.
Yes.
But they have allowed for till 2.8. So I think 2.8 internal, we should never deter from 2.8. Not even 2.79, I would say. So always cross check. Nothing less than 2.8 should work for any IC study.
Yeah, that's very important point, because once you very carefully check the ACD internal, and then only the patients would be selected for any phakic lens surgery. Notice Dr. Mayank has entered in the anterior chamber and the lens is coming out, and he is implanting very slowly, very gradually. The lens is opening up, and you can see very beautiful insertion of the lens into the anterior chamber.
Visco.
And
Visco.
Dr. Mayank is going to inject the viscoelastic so that he can tuck the haptic of the IPCL behind the iris, and you can see beautiful tucking of the IPCL, and you can see the mark also. This is a smart toric IPCL, and there is no need of particular positioning of the lens. You can position this lens at 180 degree. And Dr. Mayank position 2 haptics, and now he's going to position another 2 haptics.
Mayank, please center the microscope.
Okay. Is it okay now?
Yes. Okay. Little bit. This is now decentered again.
इससे फुट से नहीं हो रहा है इस नहीं
No,
नहीं
no, 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 going away, going away.
Better now. Better. Better ऐसे रखो.
Is it okay?
Little bit. Oh, okay. This is okay now.
Best. This is best. Very good.
This is best.
So all four haptics are now been tucked in. आइए
Now Dr. Mayank is going to remove the viscoelastic
पहले आइए then file.
from the antechamber, and you can see very nice implantation of the toric IPCL.
Mike, you using ocular in IPCL or ICL cases?
Pardon, was?
You use ocular in these cases?
Oculan.
Yeah. We do use.
Okay.
Like you can use intracameral injection of Oculan, you can use intracameral injection of Phenocan, and this helps to provide the intracameral anesthesia, helps to provide to minimize the discomfort to the patient. And here you can see the patient is really comfortable, and Dr. Mayank used intracameral lignocaine, and now he's removing the viscoelastic. This step is very important, and you can see there is a hole in the center, and once you put the irrigating port near the hole, central hole, the viscoelastic comes out. Dr. Mayank, what is your technique? Any special tip or pearl you want to share with
So
audience?
this was I was doing. You should put your instrument. See this viscoelastic coming out as you put your irrigation cannula on top of the holes. The viscoelastic from beneath the eye you see coming out. So there are multiple holes in this V2 model of the IPCL. So if you put your irrigation cannula on top of it, all the viscoelastic from behind comes out.
This is very important pearl to remember, that you should take extra time to make sure that there should be no residual viscoelastic. And once you put the irrigating port near the hole, the viscoelastic will come out. And in most of these cases of phakic lens, it's important to use the hydroxypropyl methyl cellulose, and HPMC is a good viscoelastic for these cases. And you can see here, Dr. Mayank is taking his time to remove the viscoelastic from antechamber, and the lens is very nicely placed. All four haptics are behind the iris, and after removal of the viscoelastic, he is going to inject intracameral pilocarpine to make sure that all the four haptics are behind the iris, and it's very important to check the position also, and just ensure that there should be no tucking of the iris. All the four haptics should be behind the iris.
Thank you, Dr. Pandey. Excellent surgery by the Dr. Mayank Agrawal. Can you shift the lead to the other camera?
No, Philo.
Thank you very much, Dr. Sandeep. And let us congratulate Dr. Mayank for wonderful demonstration of toric phakic lens. Congratulations, Dr. Mayank.
Thank you, boss.
But our video is freezed.
Okay.
Please check at your end.
Next case will be done by Dr. Sonu Goyal, and Dr. Sonu Goyal will be implanting the toric lens from Hoya, and Dr. Sonu will be sharing the detail about the case.
So welcome to the world of Hoya, and I think Hoya needs a big round of applause because of their wonderful preloaded lens delivery system. I think unmatchable, unsurpassable, the lens delivery system that these guys have. And all those I think you have used, I think this is the only platform in the world which gives you both the screw and the injector in one go. So I think with the delivery system, the quality of lenses, they have really stolen the world market. So my patient is a 50-year-old gentleman. I'll be doing Vivinex toric here. The placement axis is 171. So if you see, these are the two reference markings, and this is the reference marking of 171 degree here that we have created. So it's a grade 2 cataract, and a standard 2 side ports. I always do 1.1 here, and I'm going topical. Phenocan is always my choice in all my surgeries, and believe me, this gives you both the advantages of anesthesia and dilatation. Fino kin hai?
Dr. Sonu, there's wonderful
Intracameral-
technique
intracameral.
what you have told about
Intracameral.
Hoya.
Kya hai ye?
I think Hoya is the first company in the world who came with the preloaded platform.
Yeah. So, and the beauty is that whether you have a +5 or a +30 visco, all the lenses would, come in the same way. Yeah. So their reproducibility is what is important. Mera cannula lagao na. So it is the reproducibility of these, the delivery system, which is very important, because most of these lenses, if you have tried those manual injectors, you would find difficulty in extreme of powers. So it is this system which actually works very well in the extremes of the power, and I think that is what gives you that safety factor when you're dealing with these kind of so the viscoelastic rexes dena yaar ek cannula
Dr.
block
Sonu,
hai.
which viscoelastic is your preferred viscoelastic before doing Rexis?
So I am a poor guy. I would always do an HPMC because when you do volumes, you have to be very, very careful. 26 gauge. And yes, in those white cataracts and brown cataracts, a combination of chondroitin with.
And for your preferred technique for capsular Rexis, you prefer combination of cystotome and protractor forceps, or you prefer only the bent cystotome?
So I would always prefer, if the patient can afford, the flex laser system that we have.
Yes, absolutely.
So that gives you an exact 5.1 millimeter and gives you the right effective lens positioning. But what we have learned is that you can manually carve that when you are dealing, and you have to be very, very gentle. So to all my residents, I know they could be linked through the YouTube, what Harshul has beautifully connected to us. So be very gentle. The chamber should not shallow. Always use the side port for the Rexis. Don't go through the main port, and you can easily carve out main port, McPherson, a 5 or a 5.1 Rexis when you want. McPherson main port. So 1.1 side ports and then a 2.2 main port is what we desire. I use a Signature Pro here, and we have already discussed Signature Pro again is a beautiful system when you're working. So the Hoya Toric, a quick word about the beauty is it's on the proven platform of Vivinex. And the beauty is that I'll show you how they have etched and sandblasted hydro. हाइड्रो ये कैनोला नहीं है बेटा, ये पॉलिशर है. आपका दे दो मेरे को, कुछ भी आपका कोई भी हाइड्रो दे दो.
Dr. Sonu,
कोई भी हाइड्रो दे दो.
what is in your experience, what is about rotational stability of the Hoya Toric
platform?
platform?
We did a parallel study with all the other platforms, and I think this works very well. So, and it is due to the hydro यार, ये syringe हटा दे, plastic syringe दे दे, plastic syringe. So because of the frosted design, and secondly the ozone treatment of the optical surface, I think when you have a combination of these two concepts, once you have the haptics which are frosted and the surface which is ozone treated, I think this lens goes and snugly fits onto the bag, and hardly you find the lens getting rotated, and you would believe understand that the most of the rotation occurs within the first 1 hour of the implantation. So I think that is crucial, and I'll demonstrate FECO, how you can during the surgery take some key points and ensure that the lens goes and snugly fits onto the bag during the surgery. So I'm using a Signature Pro. मेरा वाला है ये स्लीव तो आपने कैसे लगाया है, फटी हुई है स्लीव.
And Dr. Sonu, this is a soft cataract, so any particular tip you would like to share with the audience to manage this kind of cataract?
स्लीव फटी हुई है आपकी, स्लीव चेंज करो इसको. Can I have a new sleeve?
Like your tips or your pearls for managing the soft cataract.
So soft cataracts, I would say, are sometimes difficult because then you end up creating a saucer in the center, and you start, getting, you start holding from the periphery, and it is at that point when your patience really goes off, and you really catch the either the rexis margin, or you end up creating a break in the capsule. So what is important is that you always have to achieve a crack. So you have to divide into two fragments. That is very important. And in case if you have a saucer, very carefully, you can cartwheel these soft cataracts. Parameters have to be taken care. You have to adjust the bottle height, the vacuum, low vacuums. And I think patience is what is required if you are not able to achieve that initial crack. Am I center and is the video clear?
Yeah, very clear.
Dr. Suresh Pandey, sir. What are the parameters? So a straight chop, and I never dial. Very carefully, I would, just separate this apex. And once this is achieved, then you can easily dial the rest of the nucleus. Parameters, देखो थोड़ा surge आ रहा है. So can somebody give my parameters? So back to talking about the Hoya Vivinex toric. So because of this, the factor of the haptics getting sandblasted, roughened haptics, and the ozone treatment on the Vivinex platform, I think this basically ensures. And the third is the square edge design of the optics. I think this, on and all, gives you a very stable lens in the bag.
Dr. Sonu, what is your experience about the PCO rate with the Hoya lens?
So yes, this was a concern initially with those initial series of spherical lenses,
okay,
where the incidence of PCO was slightly high. But I think with the Vivinex platform, I think this incidence has gone really low, very low. So I think
so I think you have implanted more than 5,000 lenses so far.
I have not checked. I probably have checked with my distributor. No, I think that's a very exaggerated figure. But yes, a very huge number. Yes. And in the latest series that we have been doing, I think the PCO rate is almost negligible or maybe quite comparable. I still believe a good size Rexis and a good polishing on the posterior surface. People deter from polishing, but I would always clean my posterior capsule.
So for young residents, what is your take-home message to minimize the PCO rate and to ensure the good centration of the lens, long-term centration in the lens?
So I think it starts from the very beginning. A good size Rexis, never undercut. If you have a small Rexis, try to make it adequate, try to fashion it properly. Always have that wrap. So wrap, I mean, is a 1 millimeter coverage of the optic all around, so that you have a good, what we used to call the shrink wrap effect. So I think that creates that prevents the length epithelial cell migration onto the posterior surface. So a quick word for the bimanual vis-a-vis coaxial. You can always exchange your hands. Just watch carefully the subincisional cortex. Now this creates problem. You can easily go exchange your hands, and I think that's why I would advise people to shift from coaxial to bimanual, because this gives you a good control when you're dealing in topical phacos and when you are dealing with subincisional cortical matter. So I can, hold the posterior capsule like this. I can eat away the fibers like this, but this dangerous tricks is not at the beginner level. Polisher
for the bimanual irrigation aspiration, which kind of instrument you prefer? It's like sand-blasted cannula?
Yes, you can have a wonderful sand-blasted cannula, which can, take away your the time while you are polishing. You have to ensure, PCO we were talking, that you have to ensure that the bag is free from all the lens matter. Carefully look that there is no residual lens matter anywhere, because most of the patients post-operative uveitis, CMEs, you have those chips underneath.
And do you prefer anterior capsule polishing, Dr. Sonu?
Under surface of the anterior capsule, yes. If you want, I can demonstrate. Mera irbu tha na visco mein irrigation de. I'll just take a quick word, and then we will talk about polisher tha na yaar. Viscoelastic में लगाया था ना आपने? Viscoelastic में लगाया था ना आपने मेरा? Polisher था ना बेटा? नहीं यार, लल्लू आदमी है. कहाँ लगा दिया तुमने? So I think I am lost with my polisher, viscoelastic view. So can we have the lens, please? So I must compliment the facilities at Dr. Suresh Pandey's place. I think amazing. The staff is very trained, a fully equipped OR, visco, and visco.
Thank you, Dr. Sonu.
And
Thank you for
amazing,
your-
all equipments. I think full marks to him for organizing this wonderful live surgical event.
Thank you so much
I've
for
been
your kind
traveling
words.
worldwide, and I feel he has an amazing world-class facility at his center. We all should give him a big loud of applause for holding and organizing so smooth. And I think Dr. Harshul Tak at the same time deserves full marks for IUL, please. IUL for organizing such a smooth affair here. And thank you, Harshul, for making us feel comfortable at home with all this. I think you all know, might be familiar with this, the Hoya platform. This is how the preloaded injector system. So you have this XY18T, T stands for toric, and this is on the T4 platform. Now, yes, by chance, we have a plus 29.5. So I'll just want to show you how 29.5 on this platform goes so smooth. So this is 13 with 6, and I have a 2.25 cylinder viscoelastic. So this is the step 1 before doing anything, bit of HPMC. So the step 1, am I clear on the view? So this is the step 1 where you push in the viscoelastic, you remove this, and then you push. This is the step 2. बेटा आपने इसको पुश कर रखा था क्या? आयुल दूसरा है, चिपका हुआ है, ये चिपका हुआ है पीछे.
I think Dr. Sonu has maximum number of Hoya lens implantation, all kind toric and other Hoya lenses in the Rajasthan state, and he will share with us the most important advantage of this technology by Hoya.
So I think flush करो, saline डालो cornea पे. Saline. So what I want to demonstrate here is see from the incision. एक मिनट सामने से हटेंगे प्रतीक. Yes, thank you. Such a well organized OT. Full marks to Dr. Suresh Pandey. I have my the video going playing in front of me. So just watch carefully. I'm just twisting. Very controlled delivery system that you have. Saline डालना बेटा. Saline. Just watch. Since की देना left hand में. And you can, gradually nudge it inside the bag. See, I have been very gentle, very slow. And you have an in the bag implantation of the IOL.
Very beautiful demonstration.
So I think that's the beauty with these Hoya lenses. You have an in the bag lens implantation. And just a quick word. I'll just withdraw this lens from the bag and demonstrate the frosted. See very carefully. See, this is how the what you mean actually with the frosted design. You can see the haptic, which is it visible there?
Yeah, very.
Dr. Pandey, is it visible?
Yeah, it's visible.
Yeah, it is.
Can you see the haptics? These are sand blasted or these are frosted. I think
Yes.
now
Yes.
these are the square edge. These are the frosted haptics, and this is what gives you the extra amount of stability which is required, and that what contributes to maybe less than a diopter of the toric rotation that these lenses exhibit. So a quick word for before pushing the lens in the bag, you can at times keep the lens, one of the haptic on the AC, and then slowly get close to your desired axis, because with my experience with the Technis platform and the Hoya platform, they are so sticky now that it is difficult to rotate them. And that is what gives them the excellent rotational stability with these lenses. So I'm trying to gradually nudge the lens close to the axis. 176 is the desired axis what they've given me. And this is what I have achieved here. A quick tip, a good viscoelastic wash. Visco should always be washed from the posterior surface. Never seal the wound too tight, because if you tend to over distend the anterior chamber, the lens is bound to rotate. And this specifically happens when you have a high myopic patient. In case of high myopia, the back gets distended and you have a surprise day one sitting for you. So a good viscoelastic wash is what I'm doing here. I go behind the lens here, wash the viscoelastic here, and so that the bag doesn't distend. And this posterior surface is what I want to stick onto the posterior capsule, so that the ozone treatment that they say would come into play and gives you an excellent rotational stability. A good viscoelastic wash here. And this is my own trick, which I learned from Professor Ronald Yeo and Chi Soon. So you just need to go and then tap the lens here. Twice you tap, and this lens goes and sits snugly into the bag. And I think all these three things together gives you an excellent rotational stability. So I think I'll just dial the lens to the desired position. You can switch on to the next surgery. I don't want to waste on time. Thank you so very much for giving me this opportunity.
Let us congratulate Dr. Sonu Goel for excellent demonstration of the Hoya toric lens implantation, and thank you so much for
Thank you,
sharing
sir.
very
Excellent
valuable
surgery,
tips,
Sonu.
for
Congratulations.
residents as well. And Dr. Sonu has very rich experience of using premium lenses in Rajasthan since last 15-20 years. And can you shift to another
Suresh, can you
microscope?
switch over to the next case, please?
Now the next case, Dr. Saurabh Luthra from Bilaspur will be showing the cataract surgery on Alcon Centurion machine with implantation of panoptics lens. Dr. Saurabh Luthra, can you share some detail about your case? Welcome to Kota, Dr. Saurabh.
Brief about the patient. He is a young 40-year-old male with a NS3, NS2 grade cataract. He's had a small history of trauma some 10-15 years back, but fairly no injury to the lens per se. And so we are planning to give him a trifocal, as he is also keen in, interested in having not to use the glasses. So,
So Dr. Saurabh will be demonstrating the use of panoptics lens in a young patient with unilateral cataract, and he is only 41 years old, and he wants vision without glasses with the trifocal platform.
Yes. So aiming for a almost a 5.5 rexis. Yeah, some fine focus. So in early young patients, we need to have a smaller rexis. These are a little fragile. They can go a little beyond. I always tend to stain my capsules, and I have a pre-filled visco needle. Somehow there is a little bubbles coming in here, which we can manage, of course. Yeah, much better. So this is a tip for the younger generation, because somehow old habits die hard. I still tend to practice this so that somehow I should have a nicely filled anterior chamber. So I have a smaller margin under my incision. So I'm trying to go a little beyond so that I have a fairly decent rexis. I hope I am centered and visible.
You are almost centered. Just little.
Almost. So sir, can you help me with the microscope here? Bas beta.
No, now you are decentered.
Now it's better.
Now you are centered.
Good.
Okay, fine.
In such cases, you prefer 5mm rexis, Dr. Saurabh,
So
or you
yes.
prefer little smaller one?
5 to 5.25, sir, nothing bigger than that, because you need to have a good center IOL. As Virender was also commenting that you cannot play Okay, I need to take care of this bubble. Yeah. Centration is the utmost part. Okay. भैया keratone दीजिए. Keratone. So I've made a partial entry through a 2.2. I will be completing my entry so that the visco loss is less. So I am a compulsive now 2.2 guy hydro bhaiya.
So very nice, beautiful rexes you had done, Dr.
It
Saurabh.
could have been better, sir, but thank you. So you need to really decompress well, and then be careful about your. You can see the wave now going in, tap, let it form well. It is harder in the center, but otherwise it is a fairly soft cataract being a young person. So we have hydronucleation and delineation both being done comfortably. Visco. सब एकदम ठीक है राहुल भाई. Okay. So now I would be, can we shift to grade 2? It's not a grade 3 setting. Give me a grade 2 setting on the FACO, please. I'll be using a Alcon Centurion with the active sentry here. Active sentry is basically active fluidics with another third sensor right in my handpiece, which really makes the difference. So you can really play around with the pressures, with the high myopes, with the hyperopes, wherein you want to, like in this particular patient. Bas beta. हाँ. Planned diopter is 16, so he's a little myopic. So my IOP here is, so right now for the sculpt, I've been using a 50 IOP, but we'll see is as I shift, I go down to my IOPs because it is fairly comfortable. So I am a compulsive stop and chop guy. You've seen direct chops, all the bosses operating.
And Dr. Saurabh, this is very good technique for the beginner surgeon, and I think it's very important point for the residents and young doctors who want to proceed their journey of emulsification.
Yeah. But somehow, sir, मैं इसी पे अटक गया हूँ. I'm not been good, going beyond it. So
it's better to be safe rather than be sorry. And I think Dr. Saurabh is doing wonderful demonstration of a case of
so we've had our
bilateral
first
traumatic
crack. Yeah, we've had a nice crack. So now you can see, I don't know if my overlay is there. Now the IOP is brought down to 40. Bottle height of say somewhere around 50, with the vacuum levels going till 400 plus. And you can see the stable chamber. There's hardly any. Aja bhai. So half is gone and go in. It's quite soft. I'll just, try to break it just like that. Saline on cornea, please. So, the epinuclear part, you really don't. नहीं भैया इसको ना इसको हाँ sorry नहीं सब ठीक है. So with the active you really need not shift to the epinuclear module. You can very well go ahead and do it with the cortex, but let us demonstrate what's right. As it is, we've been taught in the last piece you need to be slow. So we are done with FACO, and भैया इसको दीजिएगा, लेंस रेडी करेंगे, आइए शिफ्ट करेंगे. ये पकड़ बेटा, शिफ्ट टू आइए. नहीं कोएक्सियल वो रखा है टेबल पे. तो सब
Dr. Saurabh, you have done a lot of panoptic cases.
I have, sir.
How did you find this lens in your practice?
Sir,
in terms of patient satisfaction.
Yes.
And the vision at near, intermediate, and distance.
So fairly, sir, everybody is skeptical initially to push. I always tell my patients about the initial halo glare phenomena, of course, but so far I've been using them for young adults to almost say around 70s. Can I have my side quote? Yeah. So it's fairly excellent, especially when implanted in both the eyes. I have not given glasses to any patient, although we tell all the patients that you might need glasses, but it works fantastic in near and intermediate, of course, with good clarity in distance. I am again a compulsive coaxial guy, and has been taught by all the stalwarts, always do the under. भैया मेरे को थोड़ा सा वो देंगे क्या? नहीं नहीं, fine focus. Yeah.
Dr. Saurabh will be implanting a 16 diopter panoptic lens,
नीचे चला गया.
and this is a
Saurabh,
trifocal lens from Alcon.
ठीक.
Saurabh,
This
center.
lens is wonderful lens, and I have implanted in doctors, in surgeons, and they have excellent vision for near distance and intermediate. Few of the doctors where I implanted panoptic lens, surgeons, they are doing surgery without using glasses. So this is wonderful lens.
Give me a little visco.
Excellent
थोड़ा
vision.
visco देना भैया.
And this has minimal or almost no PCO rate.
Yes,
because
sir.
of the hydrophobic acrylic material from the of the acrysoft, and this is sticky surface, and
the best part is again the centration, sir. It has a extra 4.5 milliliter center, so that you have, it is pupil independent, very importantly. So works very well in the night vision as well.
yeah, that's very important point. This is a people independent lens, and this has excellent rotational stability. So you can use panoptic toric lens when there is a cataract is combined with the corneal astigmatism. And Dr. Saurabh, which is your preferred viscoelastic? Chondroitin sulfate based viscoelastic do you use in your practice?
Yes, sir, very much. नहीं वो आपके हाथ से ही लिया. Sir, there's no financial interest, but I of course use a lot of viscoat here in all my hard cataracts. I have a little subincisional cortex. Let me just push the lens so that I can lift it up and then take care of it. My incision is a little bent forward.
So the beautiful part about the chondroitin sulfate based OVD is that it provides an excellent coatability to the endothelium, and this is very important in such cases of premium lenses.
सब ठीक है राहुल, हम लेंस डालेंगे, ठीक है? लाइए सर, मेरे को दे दीजिए. हाँ जी. So it's a 16 diopter lens, and with intermediate add of 2.17 and a near add of 3.25. So practically, जैसे Virender sir was also saying, you need to ask the patient what is his working distance for intermediate. It is better to नहीं बेटा वो cartridge. So you should ask the patient what is his work distance. As like for the computer users, the bankers, it's a boon. भैया इसको ओपन करेंगे. मैं लोड करूं, आप कर रहे हैं? So let me just load the lens. It is better to load these lenses under the microscope.
Any particular tip you want to share while loading these lenses for agents?
Sir, yeah. So let us follow the classical way. Put a drop of viscoat or HPMC. Put one drop on the lens. Bring it to the safe zone. थोड़ा नीचे करना भैया इधर. हाँ अब ठीक. So bring it here so that it doesn't fall off here and there. Once you are sure that you've got the hang of it, ठीक है. मैंने डाल दिया. Put the first tip, dip it, and take this trailing haptic, guide it through the instrument given, which has that specific guiding level. So as I said, I am a compulsive stop and chop guy. I've also only shifted to 2.4 thanks to active sentry, because the fluid loss is always managed there. Visco. Yeah. थोड़ा सा प्रेशर लगेगा बेटा, हम लेंस पुश करेंगे, ठीक है? एक सेकंड ले रहा हूँ हाँ बस वो जो है ना वाई वाला वही देंगे, ये वाला जो मेरे हाथ में था पतला सा। हाँ बेटा बस बेटा बस ले बेटा। So as you can see, it nicely unfolds, gives you a time to tuck it, especially when you're using a toric. ये थोड़ा सा सेलाइन डालिए तो बस, थैंक यू। बस अब पैरा So I'm trying to put the lens a little behind the capsule so that I can take that.
डिस्प्ले नहीं आ रहा है हर्षुल?
लेंस डाल दिया राहुल, बस 2 से 3 मिनट फिर अपन चलेंगे बाहर। अरे यार नहीं, गिव मी हाइड्रो। हाँ
सौरव, डिस्प्ले नहीं आ रहा है सौरव।
Okay, so we are out with that cortex. So you can see with the 2 point, there is hardly any wound leakage, and the AC is formed because of that extra sensor which takes care of the fluid loss. And the centered IOL.
So Dr. Saurabh has done beautiful demonstration of unilateral traumatic cataract in a young patient.
Yes, sir.
And he
Thank you.
successfully implanted the panoptics lens from Alcon.
Sir. All right. And
Sir, you want to?
Perfect, perfect. Okay, so thank you. I'll just hydrate the wounds. Wound hydration, please. बेटा बस हो गया।
So congratulations, Dr. Saurabh, for wonderful demonstration of.
Sir, thank you so much for world class, for
cataract surgery with panoptics.
fantastic
lens from Alcon.
facilities. All your staff, thank you so much.
And thank you so much for coming from Bilaspur.
Sir, it is my pleasure for having. Thanks to you. Thanks to
the Rajasthan Ophthalmological Society conference.
It is my
And
pleasure,
now we
sir.
welcome Professor Pankaj Sharma, sir, to Operation Theatre. And next case will be done by Dr. Pratik Gupta from Bhilwara, and he will be showing the cataract
भैया ये
surgery
ना
with implantation
इधर से
of
भी लीक कर रहा है, इधर से भी। एक 2 cc में
comfort
थोड़ा
lens.
सा सेलाइन दे दो।
और एकदम ढीली छोड़ दीजिए। Should I start?
Start. Dr. Pratik Gupta will be starting the case now.
इसको 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 भाजी बहुत अच्छा कर रहे हैं आप, बस ऐसे ही आराम से ढीली रखनी है, आप सामने देखते रहना, आपको बहुत बढ़िया, शाबाश। सामने देखिए, कोई दर्द नहीं होगा, आपको पता भी नहीं चलेगा, है ना?
So Dr. Pratik, this is a grade 3 cataract or?
Yes, sir. This is grade 3 nuclear cataract with a grade 3 PSC also. And
okay,
I don't use MVR. I use this side port, which is very good in my hand.
Okay, so you use MVR blade for side port incision.
Yes.
And then you use intracameral injection for anesthesia or?
Generally, sir, these days I don't use anything. I just do it in paracaine.
Okay.
Or sometimes if patient is not good, then I am able to do it in block also.
And for capsular access, you prefer the cystotome?
For capsular access, sir, I use a double instrument technique.
Okay. Very nice. Excellent. बधाई हो राहुल जी, बधाई।
Table.
Dr. Gupta,
टेबल पैडल है क्या?
पांडे जी,
टेबल का पैडल इसको देना बस। इसको I use this Muscati capsular access forceps. This is Muscati capsular access forceps.
So what is the advantage of Muscati capsular access forceps, Dr. Prateek?
Sir, it gives me a good control of rhexis.
Okay.
And with this rhexis forceps, जब बाबूजी आंख मत हिलाइए,
आंख मत हिलाइए, लाइट में देखिए।
वेरी गुड।
लाइट में देखिए।
घबराइए नहीं बाबूजी, है ना, आराम से सामने लाइट में देखते रहिए। कोई दर्द नहीं होगा, आपको पता भी नहीं चलेगा। हिलाइए नहीं, आप सामने देखिए। इसको देना।
Dr. Suresh Pandey, can you hear us? Dr. Suresh Pandey, can you hear me?
कोई बात नहीं बाबूजी, आराम से, है ना, आप अच्छा कर रहे हो। Very good. Hydro. I use this 27 gauge cannula to do the dissection. There is a grade 3 PSC in this case, so hydro would not that be easy.
Dr. Pandey, can you hear me?
Dialer.
Is there anybody in the OT?
We are using laureate machine. We will do the stop and chop technique. IA1, Echo 1. This is the first crack I have made.
So Dr. Pratik, which technique do you prefer in such cases?
Sir, I prefer stop and chop technique.
Okay.
Because I feel more comfortable with it.
Stop and chop technique.
And generally I make at least 6 to 8 pieces in each case, and then I go forward. And this is a comparatively hard case.
Yes, sir.
So with this technique, we have to use the minimum energy.
And which viscoelastic is your preferred viscoelastic?
Sir, I use all the viscoelastics, but due to a good volume in our surgery setup, so we use 2% methyl cellulose mainly. Tyler.
Hello. Can anybody hear me?
I rotate my sleeve and change from the stopper to the dialer in between.
Okay, okay. So once you break the nucleus into pieces, then you just change this second instrument.
Yes, sir. I changed.
Dr. Pandey.
Okay.
It make more easier for me. Is it centered there?
Is
थोड़ा इसका head है sir.
now this is center. Dr. Pandey.
Now we will eat all the pieces one by one.
Dr. Gupta, can you tell us something about the lens which you are going to plant in this case?
Sure, sir. Sure, sir. Today we are putting EdTech Comfort IOL, which is an EDOF IOL.
Okay. This is on a hydrophobic platform, I think.
Sir, this is a hybrid type of IOL.
Okay.
And which have both the properties of hydrophobic and hydrophilic.
Okay.
I have implanted maybe 2000 or more than 2000 IOLs.
Okay, good.
The result which I get generally is 6-9 for the distance, and patient has to wear 1.5 diopter for the near. So
okay. So with this IOL, patient is able to do his computer work or
I'm coming to the point, sir.
Yeah.
With this lens, I have seen that the results in a younger patient are very good. They can even able to read. Some patient of mine. ये tube हटाना सामने से. Younger patients are even able to read without spectacles when I implanted them bilateral. And with older patients, they have to take a glass of 1.5 for the near work. Rest, most of the patients are very happy. Nowadays, in my practice, I use almost every patient with less of the astigmatism. I use this lens because this is one of the Indian lens which is comparatively cheaper. और जो पहले एक बहुत रेगुलरली एक समस्या आती थी कि पेशेंट आता था बोलता था कि सर दूर का तो दिखता है पर पास का अब आ ही नहीं रहा सर बिल्कुल भी, तो आंख और खराब हो गई. अभी पिछले 2 साल से सर दैट प्रॉब्लम हैज बीन गॉन.
So the results of this lens is quite good.
IA2 please.
EdTech.
Yes sir, the results are fantastic sir. That's why I am putting these IOLs regularly. And most
so is it available in toric platform also, or
yes sir, it is available in toric platform also. And it is very surgeon friendly also, as the IOL implantation is very easy. The injector quality is very good. Although it's an Indian lens, but I feel that injector quality is much better than any other lens. And my criteria these days is like If patient is ready to pay and he just want to get rid of glasses, then I go for the trifocal. If he has some kind of toricity in his eyes, then I go for toric. Otherwise, for a routine patient, I just go for this EDOF, which is economic and more patient friendly.
Okay. So what is the incision size for this IOL?
I routinely do a 2.4 incision, but
Okay.
it can easily be implanted with 2.2 also. I will just let you show.
Okay, fine.
So, continue. This was a PSC, so there is a lot of plaque there.
Yeah.
Patient is an old patient. He is around 65-year male. So it might take a few seconds.
But this is quite peripheral. You can leave it also. This will not cause any problem in the vision.
सर सुरेश सर से पूछ लेता हूँ, बाद में नाराज नहीं हूँ.
सुरेश सर बाद में पीआई कर दे या कैप्सुलोटॉमी कर देंगे.
If Suresh sir is ready, I can leave it, sir, like that.
Because sometimes it's very difficult to remove these kind of plaques.
Okay, sir. If you say so, I will leave it. So I implant the IOLs in hydro only. So no need for a visco. This is the IOL. So the memory is not that much because it's a hybrid IOL. So it went in easily and open up. Bottle height थोड़ी बढ़ा दी. Bottle height is बढ़ ही नहीं सकती. So you can see the IOL now, I think. Yes, this is a beautiful IOL. See how easily I can tuck it in. No need for any visco implantation.
Dr. Pratik, I think you have done maximum number of implantation of this lens in Rajasthan. Am I correct?
Sir, only the distributors can tell that, sir.
So what is your experience about visual outcome?
Sir, visual outcome, as I told earlier in the talk also, the visual outcome is very good, sir. Patient generally comes after the surgery with 6/9 vision and for near he has to use 1.5 diopter of for the reading purposes. But generally patient does not complain of near vision loss. Patient comes up and say, I can see very well. And sometimes I would require and after 28 days, like patient himself come and say कि sir बाकी तो सब ठीक है, अगर आप चाहो तो थोड़ा मोड़ा चश्मा दे दो सर. So for that price, I think it's an ideal IOL, in fact, for our scenario where patient is very price conscious also.
Okay, yeah, absolutely. You are very correct, Dr. Pratik.
So I think my surgery is over. Thank you very much.
Congratulations, Dr. Pratik, for wonderful demonstration of the EdTech Comfort lens implantation. And Dr. Pratik is the youngest surgeon in today's live surgery session. And let us congratulate him once again for his courage and for his dedication for performing live surgery today.
Thank you
now
so
we
much,
have
sir.
Professor Pankaj Gupta, sir, who is Professor.
Excellent surgery, Pratik. Dr. Pratik, excellent.
Thank you so much, sir. And I must thank
Excellent.
you, ROS, and must thank
Let us
you,
welcome
sir.
Dr. Pankaj Sharma, sir.
You will be a very budding ophthalmologist of this Rajasthan Ophthalmology Society.
That's very, very true. Dr. Pankaj Sharma, sir, will be showing the cataract surgery with implantation of synergy toric lens.
सामने देखते रहो.
And this patient is 66-year-old male with corneal cylinder of 1.9 9 diopter, and Dr. Pankaj Sharma sir will be showing his technique of cataract surgery and synergy toric lens implantation.
बाबू जी बहुत अच्छा हो गया आपका ऑपरेशन, कोई तकलीफ तो नहीं हुई आपको? बहुत
Dr.
बढ़िया।
Pankaj Sharma, this is a grade 3 cataract.
Yeah, this about almost grade 3.
हाँ बंद रखो बंद रखो।
And
The
you
central
prefer to use, dispersive viscoelastic in almost every case.
Yes, the magic solution is chondroitin sulfate.
Chondroitin sulfate has
Yes, it is
negative
light में देखें,
charges,
light
and it binds with the positive charges of corneal endothelium, and that's why it gives excellent, it provides excellent coatability to the corneal endothelium, and therefore it helps to achieve clear cornea on day one.
See, it has got triple negative charge. Two charges on the chondroitin part, that is a sulfated part, and one on the sodium hyaluronate part. So triple, yeah, it helps, it binds the corneal endothelium and it protects the corneal endothelium. It has both space maintaining and endothelial coating properties, both.
And that's why it's very correctly said as surgeon's third hand.
Yes.
Because it helps surgeon to achieve perfect visual outcome with minimal corneal endothelial cell loss, and therefore it helps to achieve the clear cornea on day one.
Hydro.
ग्लव्स चालू कर ले, कोई बात नहीं।
लाइट में देखें सर, लाइट में, बस लाइट में देखें, बस। फेंको।
Dr. Pankaj, which is your preferred technique
For?
Which is your preferred technique for phacoemulsification?
The direct chop is my technique, and clear rotation after the hydro procedure, because the fluid inside the eye, it automatically causes fluid dissection. So over rotation of the chopper, over rotation of the
using the Alcon Centurion phaco machine, and he's going to demonstrate the quick chop technique or the vertical chop technique. In this case,
no, I need sharp chopper, sharp tip chopper. So for the direct chop or the vertical chop, you need a sharp chopper.
The advantage of the vertical chop that you need minimal
light में
energy,
देखें, yes.
and this is relatively faster also.
So the power is transferred from your phaco to the chopper.
Yes.
तीनों पेन ले ली,
कुछ नहीं में देखें।
Any particular tip you would like to share with the young ophthalmologist about this technique?
Actually, we should not start straight away go to the quick chop method. Best way to learn phaco is do a stop and chop first.
Okay.
Once you get the hang of the chop, the dynamics, and only then you should start this quick chop technique.
Okay, that's very important message for young doctors.
And a small segment of the pie should be removed first. This gives us a handle to work for the nucleus, for rotation, and it also creates a space through which fluid goes behind. So I don't like to, do too much of hydro procedures.
Okay. What is the reason why you avoid doing too much excessive hydro dissection?
Excessive rotation of the nucleus actually causes hampering of your chopping techniques.
Yes.
So it rotates too much. The nucleus
है ना?
Need some amount of stability in the nucleus for it to create the chop.
So any comment about the
करने वाला कौन है?
machine you are using?
करेगा कौन?
This Centurion has got the dynamic fluids, which is you can control the IOP. So controlling the IOP is more important than bottle height itself.
Yes, yes.
Completing normal.
So you can have a very stable chamber even at a lower IOP. And I usually use the torsional phaco with just a burst of longitudinal only for the
सर ऊंचा करो साहब.
when it gets occluded. So it is known as what is called the IP, intelligent phaco.
Yes, yes.
हाँ करो आप करो नहीं नहीं एक मिनट yeah that's fine wait see this is the central core of the nucleus, which is the hardest part.
यार माइक्रोस्कोप के इसका समझ नहीं आया ये पैडल कैसे काम करता है.
So the central core of the nucleus was almost grade 3. विस्कोट देना
कर लूंगा.
एक मिनट इसको सेंटर कर एक मिनट लो. So when you are working in a new setup, it's a bit different. Normally, I put viscoat from the side port with the phaco handpiece inside, the needle inside. Only problem with that is what is known as the infusion blockage syndrome. If you put too much of visco from the side port, it's the infusion ports also, then a sudden surge appears when you start the fix. So one way to avoid is to put the visco from the main port. There's just one problem with viscoat is that few fragments of the nucleus, they just lie there under the cornea and they don't come to the port because it's such a thick solution. See the small fragments, they are stuck to the cornea.
Very good. बस लाइट में आपको ऐसे
we are almost
है ना. 5 मिनट लगेगी, 5 मिनट में अभी आपको फ्री कर देंगे. वाह, नीचे देखो आपसे. वेरी गुड, बहुत बढ़िया.
नो हाँ ये वाले इसको चेंज नहीं स्ट्रेट टिप दे दो, कोई सा भी दे दो. हाँ
Dr. Pankaj, I want to ask you the reason behind your preference for the coaxial irrigation aspiration system.
Just one reason, I feel more comfortable with that. I don't like making too many ports. One of the main port, the side ports are about 1.2 if you do a bimanual, and making 3 such ports. Then I dialer. Just give me a dialer.
And you also developed a technique of sealing the clear corneal incision.
Oh yes, I just forgot about it. I should have done that initially. See, it is what is known as the stromal pocket. एक dialer दो. Yeah.
देखो लाइट में है ना.
Anti-stromal pocket
थोड़ा सा और लाइट में देखो.
Causes compression of the wound.
बहुत बढ़िया, बहुत
The wound. The Mickey Mouse hydration or the usual hydration which was developed by Howard Fine sometimes causes fish mouthing of the incision, and the incision sometimes opens up if you do too much of hydration. So to prevent that, you can make a small pocket in the anterior stroma and hydrate that stroma. And
that's very important technique to prevent any wound leaking and fish mouthing.
सामने देखो साहब है ना. फ्लूइड डाल सकते.
इसको ये एक मिनट इसका हेड नीचे करना थोड़ा सा. इसका पेशेंट को थोड़ा चिन लोअर करना. बस ठीक है. हाँ बस ठीक.
what is your tip Paul, for removal of the subincisional cortex when you are using?
I think one important thing is to always see the edge of the CCC. If you can visualize the edge of the CCC, the viscote या कुछ भी.
ठीक है, लाओ लाओ 2.8 लाओ.
If you can visualize the edge of the CCC, you can be quite daring, and you can go and do that. And the other thing is using a curved tip IA.
Okay, okay.
थोड़ा saline डालना.
ढीली छोड़ो आपको, बहुत बढ़िया.
IA is very good
ऐसे
for
ही रखोगे तो बस 2
removal of
मिनट
the
लगेंगे, है ना?
subincisional cortex.
See, now there is a very small nuclear fragment
बहुत बढ़िया,
which we can remove afterwards also. We'll put the lens first.
It's better to always remove afterwards so that you have inject capsular bag.
Yeah. So we are putting a synergy toric IOL, which toric 2, which has got frosted haptics. It gives from 33 centimeters up to infinity, extended depth of field. And it's the true achromatic design. So we'll first load the lens.
So,
हाँ, शाबाश,
what do
बहुत
you
बढ़िया. हिलाओ
like the
नहीं,
most
सामने देखते
about
रहो.
this Technis
Light, बहुत
platform
अच्छा देख रहे हो.
and about synergy lens and particularly synergy toric lens?
The material itself is excellent, and the design and the optics part is too good. Actually, I've used the eye hands also, and even that gives a good intermediate vision. But if you want good close sight vision, 33 centimeters, then you have to go to these either a trifocal or a EDOF.
So that's what they appropriately told. Light begins at 33 centimeters.
Yes. Dialer देना. Dialer. ये रहा ये मेरे पास.
नहीं
हाँ, ठीक है.
So which injector do you prefer to inject, a screw based or the push based?
No, I don't like the screw base, so we have got the screw base, and anyway, we'll use this only.
Yeah, this is like very old this injector, emerald injector.
Yeah.
When they launched the sensor lens, and now
Visco.
लेंस देना.
any particular surgical pearl you would like to say about toric lens?
So, see, these are the toric marks. You should just leave it short of the actual axis, and then remove all the. एक बार मेरे को फेंको handpiece. So that yeah. So one disadvantage of viscoat is that sometimes the small pieces get stuck to the back of the cornea, and they just don't move.
Yes.
So and then they appear at the wrong time. फेंको पे करो. So now that is that. Now we will do the IA. So always should remove the viscoelastic from behind the IOL first, so that the chamber doesn't become shallow. If you go behind the IOL with the dialer देना.
grade 1 कर
It's
दिया
very
क्या?
important to remove the viscoelastic thoroughly behind the IOL
grade 1 कर
in order to ensure the long-term rotational stability of the toric lens.
So I always prefer to use simple hyaluronic acid, sodium hyaluronate based viscoelastic for putting the lens.
Okay.
So because the chondroitin sulfate will not come out so easily.
Yes.
So we have to do a thorough wash in case of chondroitin sulfate. So I can actually see the chondroitin sulfate stuck on the back of the cornea.
So now this lens has automatically almost come on the intended axis. We'll just wait because it just rotates clockwise only. It's one more important thing. This is the Toric 2 design, which has got frosted haptics. It's said that it is quite stable. It improves the rotational stability of the lens. So now it has gradually come on the axis. Now we'll just hydrate the wound, and that would be the end of the surgery. No, no pylo, hydro.
Bottle ko height.
So you might feel that actually one of the marks need to be aligned because there's always some parallax.
Yes.
Always it will be there. So if the patient moves his eyes at one time, it feels aligned. The other time, it feels not aligned. So you can just align one of the marks. It will usually is all right if the marks are absolutely centrally placed. So we can see this mark is now in alignment, and this is also almost in alignment. This is at 168 degrees or 170 degrees. And now, and the eye is, and you should not overhydrate the wound, and you should not over compress the anterior chamber because that can cause rotation. You can always just check the IOP with your finger. It is a nice soft eye and the wound is stable. So that is the end of surgery. Bas. Sure.
So congratulations, Dr. Pankaj Sharma.
Thank
For
you.
wonderful demonstration of cataract surgery with the implantation of Synergy toric lens.
एक और है? अच्छा, मेरे को नहीं पता था. चलो चलो चलो, वैसे भी चेंज तो करना ही. ठीक है, ठीक है. अरे नहीं, वो क्या है, वो आयुल कौन सा है? अच्छा अच्छा अच्छा, ठीक.
अरे
ठीक
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 पूछ ले तो अगला लिया.
ठीक ठीक
सर से पूछ ले अगला लिया, ये हो गया खत्म.
ठीक है.
हाँ.
उनको एक बार बात कर लें इनको. बाबू जी बहुत बढ़िया हुआ आपका है. आपने वेट तो बहुत किया, लेकिन सबसे अच्छा आप ही का ऑपरेशन हुआ है. ठीक है जी. हाँ, नहीं नहीं साहब,
एकदम डिलीट
जयपुर से आया हूँ मैं. अब बहुत
आपका वाह साहब.
हाँ.
हाँ साहब, कोई तकलीफ तो नहीं हुई आपको? बहुत बढ़िया हो गया ऑपरेशन आपका. लो. अरे इधर ही लेटा दे यार.
आपको भी दर्द हो रहा है क्या?
मेरे ख्याल से वहाँ तो खाली हो गया हॉल तो।
ये
हाँ
होया
हॉल
वाला
तो
कोई
खाली
नहीं
हो
बाहर?
गया शायद।
होया वाला कोई बाहर
ये
नहीं
हटा
है?
दिया ना, मेरी
होया
आवाज तो
वाला
नहीं जा
बाहर
रही
नहीं
वहाँ?
कोई? बस बस ज्यादा हो गई।
नहीं मतलब
फिर ये बाल आ रहे हैं। नहीं नहीं मेरे को एक,
बस
चलो
छोड़
ठीक
दे
है।
यहीं पे। ठीक है।
हम्म,
अरे
हम्म।
नहीं नहीं डाई नहीं चाहिए।
ये ग्लो बहुत अच्छा है इसका, वेरी नाइस। ये वही माइक्रोस्कोप है जो वहाँ लगा है, मोनीलेक में लगा है जयपुर। इससे ऊपर है, वाह है, वेरी नाइस। उनके महंग के कौन सा लगा हुआ है? ये वाला है या इससे हायर? अच्छा अच्छा ठीक है। हाँ ओके।
अरे लेंस ओपन कर दे भाई।
ये आप गवर्नमेंट टेंडर में नहीं लिखते आप, करते वो? अभी टेंडर होने वाला है जो, नॉट द एसएमएस, स्टेट गवर्नमेंट के जो मेडिकल कॉलेजेस खुल रहे हैं ना, बाड़मेर, पाली, इनके लिए करीब 8 या 10 माइक्रोस्कोप्स का टेंडर होने वाला है। हाँ देख लेना। हाँ अच्छा।
सर
उसमें जाइस ही आता है
योर
हमेशा,
राइट सर।
और हमने उसको तो कर दिया क्योंकि वो असेंबल्ड इन चाइना हो गए वो जाइस वाले, वो
You're
तो
live
आउट
on-
हो गए।
Can you hear me? I'm
Yes,
Dr.
sir.
Pratik Gupta. I'm live.
चलो।
Is there anybody to
हाँ दे दो
listen
आगे
or
दे
to
दो।
see?
थोड़ा सा आगे कर दो आप, थोड़ा सा,
Tyler,
बस ठीक है फाइन।
let it be live. If
थोड़े से
there are
टाइट कर
people
दो।
in the hall, they can easily see that. This is a grade 1 cataract with grade 1 or 2 PSC.
स्टार्ट कर देते हैं। हाँ ले लो ले लो, इस लाइन है ना। क्या हो गया, खत्म हो गई क्या? ओहो, इसको क्रॉस कर दो। हाँ। कुछ बस ठीक है। हाँ वो दो मेरे को ऑक्यूलाइन, उसके बाद विस्कोलास्टिक, और उसके बाद केराटोम 2.4,
Tyler.
But बस हो गया। एक मिनट वो देना मेरे को, एक मार्कर देना एक बार, इसमें जो 9 और 12 o'clock है वो बिल्कुल डिम हो गए हैं, उनको पहले मार्क कर देता हूँ।
प्लंजर वाला बस तो दे दे फिर।
नहीं नहीं नहीं, सिर्फ पेन दे दो, मैं पेन दे दो।
अभी दर्द होगा क्या आपको? अब नहीं होगा।
थोड़ा इसको स्वैप करना है, यहाँ पे पानी बहुत है। बस ठीक है। बस ठीक है। चलो बाकी बाद में मार्क करेंगे।
ओके को फिर
अब मेरे को रेक्सिस वो फोर्सेप, कैप्सुलर रेक्सिस फोर्सेप
आइए दे दे। तो ठीक नहीं है क्या? हैं? ठीक नहीं है क्या? लॉक अपने लगाया हुआ है, ये पहले ये आगे बढ़ेगा। हाँ बस नहीं 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 नहीं, इसमें से तो हाइड्रो डलेगा, वो भी इसको डल जाएगा बस।
वो देना
हाँ,
मेरे को,
इसको लोड कर दे भाई।
विस्कोट देना। और है क्या विस्कोट या विस्को? विस्को इलास्टिक।
एक का डिफरेंट आया।
लाइट में देखें।
गए वो गए।
बस हाइड्रो देना, हाइड्रो हाइड्रो।
नहीं पीछे प्लंजर है ना। नहीं नहीं ठीक है। अच्छा उससे नहीं हो रहा।
लाइट में देखें, इनके थोड़ा पैराकिन डलवाओ, इनको तो बहुत फील हो रहा है।
इसमें डाल दे।
हाँ बस।
ये भी कर।
ओह अच्छा जब भी चलो।
ये लास्ट है बेटा की और भी है?
हो गया डाल दे।
लास्ट नहीं
शार्प, कोई बात नहीं। वो ब्लंट दे दो, ब्लंट दे दो, ब्लंट दे दो, ब्लंट दे दो।
दर्द हो रहा है भाई? अब नहीं होगा चिंता। उठेगा तो आप तो करते हो ना।
कर। नहीं 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 यार, नहीं सही नहीं, इसको दे। Okay. इसका इंजेक्ट वो टिप बहुत छोटा है। इसका टिप छोटा है, इसका टिप छोटा है। वो चैम्बर शैलो हो रहा है।
I will. आइए।
दर्द हुआ आपको? हो जाएगा ऑपरेशन, तो लेन डाल।
इसको करो यार। लो आई विल मेरे को मार्कर दो। ये वैसे 180 है, ठीक है 180 तो दिख ही रहे हैं, उसको तो मार्क करने की जरूरत ही नहीं है। लो,
People are not there.
ये रोटेशन वाला है या
Hall.
चलो कोई नहीं। ये वैसे ही है क्या
Is
जैसे
there
होया का
anybody
होता
in
है?
the hall watching?
होया तो खूब डाले, इसको घुमाओ।
अच्छा अच्छा।
ये तो सीधा जा रहा है,
Because we
आगे
have
वाला
completed this
फोल्ड नहीं
surgery.
हुआ,
This was a Hoya
आगे वाला
IOL
स्ट्रेट जा रहा है,
which
कोई
has
बात नहीं।
both
नहीं नहीं ठीक है, बाद में देखेंगे।
screw and push mechanism, and it's a wonderful lens, and surgery has also gone wonderfully.
लो डाल दो।
बाबू जी कोई तकलीफ तो नहीं हुई आपको? बहुत बढ़िया हो गया आपका ऑपरेशन। आराम से बस
बिस्कुट देना,
आराम से जाओ, कभी जीवन में तकलीफ नहीं आएगी। हाँ
थोड़ा कॉर्निया वेट करना।
अच्छा अच्छा, हाइड्रो देना,
सलाइन बस।
समझ गया ऋषि ना। हाँ हाँ
ये पकड़ना। चलो आइए बस। हाँ डायलर ही है ना ये तो। हाँ बस ठीक।
मैं गार्ड बुलाता हूँ, संतोष है ना, सामान को उठाने के लिए। बाबू जी बहुत अच्छा हो गया ऑपरेशन। वाह आराम से जाएंगे। इसको अरे ये बाबा ले लो। यार फोटो भेजेगा, फोटो भेजेगा, भिजवाओ ना। अरे फोटो भेजोगे क्या? आपने से तब भी बोला था मैंने। हैं? अब वो तो हमको इधर बिठा दिया, जो इधर ही 2-3 जो भी केस हुए इधर ही हो गए। हाँ
लो हाइड्रो। लाइट में देखें बस। डायलर देना, एक डायलर देना। ये लो ये लो ये। हो गया ना सारे? वेलकम। माता जी आंख खोलो। अरे वाह बहुत ही बढ़िया ऑपरेशन हो आपका, A1। ये जो लेंस लगाया ना आपके, ये बाहर से आया है विदेश से, और सबसे बढ़िया लेंस है। और गोविंद जी ने कराया आपका ऑपरेशन, बहुत ही बढ़िया हुआ है। मैं जयपुर
So Namaskar, Khamma Ghadi. Good evening, ladies and gentlemen. On behalf of the local organizing committee, I welcome you all to Roscon 2022, the 44th annual conference of Rajasthan Ophthalmological Society. I welcome all the guests to this conference, and I especially welcome our Chief Guest, Sir Dr. Amulya Sahu from Mumbai, and our guest of honor, Dr. Partha Biswas from Kolkata. And we are very soon expecting our special guest, Dr. Vijay Sardana from our very own Kota. I would like to invite all the dignitaries onto the dais for the inaugural ceremony today. And in this, please have a seat, all of you, so that we can begin the function and the inaugural ceremony. Please take your seats. I request all of you to take your seats. And first of all, I would like to invite Dr. K.K. Kanjolia, sir, who's the President, Rajasthan Ophthalmological Society, and also the organizing chairman, local organizing committee. And I would like to request Dr. Sandeep Vijay, sir, the Secretary ROS, to please accompany him onto the stage. Please give them all a big hand. Next, I would like to invite our President-elect, Dr. Khilnani, sir, and I would request Dr. Kamlesh Kedawat, sir, our Chief Organizing Secretary of the Local Organizing Committee, to please accompany him onto the stage. And I would now like to invite Dr. Amulya Sahu, sir, from Mumbai, our chief guest for this conference, and I would request Dr. Kedawat, sir, and Dr. Ashok Meena, sir, the Organizing Secretary, to please accompany him onto the stage. Dr. Kamlesh Kedawat, sir, please take your seat on the dais so that we can have all of you on the dais. Dr. Ashok Meena, sir, may we also have you on the dais, our organizing secretary for the conference of the local organizing committee. I now invite Dr. Partha Biswas from Kolkata, who's the guest of honor, and I would like to request Dr. Harshul Tak is not here. Okay, can we have Dr. Sanjay Gupta accompany him onto the stage, please? हाँ sir. May I now call upon all the dignitaries to kindly proceed for the lamp lighting ceremony. Please get. And also on stage, I would like to invite Dr. Pratul Tyagi, the treasurer for the Rajasthan Ophthalmological Society. Dr. Pratul Tyagi, sir. May I now invite upon all the dignitaries to kindly proceed for the lamp lighting ceremony. Please get the lamp lighting things on stage.
Shubham Kurutvam Kalyanam Arogyam Dhanasampada. 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 Shatrubuddhi Vinashaya Deepajyotir Namostute. Deepajyotir Namostute. Shubham Kurutvam Kalyanam
Thank you all the dignitaries. और अब अपने अतिथियों का फूलों से, खुशबू से और राजस्थानी साफे से स्वागत करने के लिए अपने सभी अतिथियों के स्वागत हम करना चाहेंगे इस कॉन्फ्रेंस में. And first of all, I would like to request Dr. K.K. Kanjolia, sir, the President as well as the Organizing Chairman of the Local Organizing Committee, to kindly welcome and give a floral welcome to Dr. Amulya Sahu, sir, the chief guest for this conference. Sir, thank you, sir. I now request Dr. Kamlesh Kedawat, sir, the Chief Organizing Secretary of the Local Organizing Committee, to kindly welcome Dr. Partha Viswas with the floral bouquet as well as the Rajasthani Safa. Next, I call upon Dr. Ashok Meena, sir, the Organizing Secretary of the LOC, to kindly welcome Dr. K.K. Kanjolia, sir, the President of the ROS as well as the Organizing Chairman for the conference. And may I also request Dr. Harshul Tak, the Chairman Scientific Committee, to please take his place on the dais. I now call upon Dr. Sanjay Gupta, the Organizing Secretary of the LOC, to kindly welcome Dr. Kamlesh Khilnani, the President-elect and the incoming President of the Rajasthan Ophthalmological Society. Please give them all a big hand. And I would request Dr. Ashok Meena again to kindly welcome Dr. Sandeep Vijay, the Secretary of ROS. Dr. Sandeep Vijay, sir. I also request Dr. Suresh Pandey to please take his place on the dais. And I request Dr. Sanjay Gupta again to kindly welcome Dr. Pratul Tyagi, the Treasurer of the Rajasthan Ophthalmological Society. And finally, I request Dr. Suresh Pandey, again the Organizing Secretary of the Local Organizing Committee, to kindly welcome Dr. Harshul Tak, Chairman Scientific Committee. आपकी तालियों की आवाज थोड़ी धीमी चल रही है. And now I call upon Dr. Sandeep Vijay, sir, the Secretary ROS, to conduct the rest of the proceedings, the official function of the inaugural ceremony. Thank you.
Thank you, Vidushi. Good evening to everyone. On behalf of Rajasthan Ophthalmological Society, I welcome you all on this occasion of 44th Annual Conference of the Rajasthan Ophthalmological Society. This is my privilege to invite Dr. K.K. Kanjolia, sir, who is ROS President as well as Organizing Chairman, to deliver his address to us and to introduce the incoming President, Dr. K.K. Khilnani, sir. Dr. Kanjolia, sir.
Good evening, everybody. I, my own behalf, and on behalf of the local organizing committee, and as President Rajasthan Ophthalmological Society, I welcome you all to this 44th Annual Conference of Rajasthan Ophthalmological Society, that is Roscon 2022, organized by Kota Division of Ophthalmological Society. आप लोगों का सादर अभिवंदन, सादर अभिवादन, स्वागत और पधारने का बहुत बहुत धन्यवाद. I especially welcome Dr. Amuli Sahu as our chief guest, Dr. Partha Viswas as our guest of honor. The organizing team has left no stone unturned to make this biggest scientific event a grand success. Dr. Kamlesh Kedawat, our chief organizing secretary, Dr. Suresh Pandey, Dr. Ashok Meena, Dr. Sanjay Gupta as organizing secretaries, Dr. Salind Billa, Dr. Rajan Chandil as joint organizing secretaries, Dr. Vishal Isnai as treasurer, and last but not the least, Dr. Jayashree Chandel as vice chairman have put up all their efforts to provide you the best academic feast. During my tenure, we had a midterm conference at Pushkar, organized by Ajmer Ophthalmological Society, and we had 2 PG teaching programs, one at Jaipur and one at Ajmer Medical College. In all the whole of the year, our ROS team, Dr. Sandeep Vijay, Secretary ROS, Dr. Harsul Tak, the Chairman Scientific Committee, who has given a very big show, which you must be witnessing right now. Dr. Prajul Tagi is our treasurer, who has put up a very good financial, and he has added the amount to the, and I am getting the cooperation from Dr. Kamlesh Khilnani, who is coming as a next president-elect. This conference will provide the cutting-edge technology in the field of ophthalmology. A galaxy of speakers will be sharing their experiences during this academic Manjana. This year, we have more than 300 delegates from all over Rajasthan and outside Rajasthan who will be sharing their expertise and experiences with each other. We will be witnessing some of the finest surgeries which we have witnessed today from best of the surgeons of the country in lay surgery, which is related from the Suvi Eye Hospital, Kota. I would like to welcome Dr. Santosh Hanawar from Hyderabad, Dr. Ajay Arora from New Delhi, Dr. Seetal Mahuvakar from Ahmedabad, Dr. Saurabh Luthra from Bilaspur, Dr. Nupur Goyal from Delhi, and Dr. Gunjan Bharadwaj from New Delhi. In this event, more than 50 companies are participating as traders. The LOC team has made all sincere efforts to make your stay very comfortable and enjoyable. In addition to rich academic feast, we have also arranged local sightseeing program, cultural activities, along with delicious and sumptuous meals, which you must have enjoyed in the morning also, and you will be enjoying in this evening also. A variety of activities for female spouse and kids has also been arranged by the local organizing team. I am thankful to Kota Division of Ophthalmological Society and all the members of local organizing committee who have been working day and night to make this conference a memorable one for each one of us. And I am thankful to the team of the ROS also. Once again, I welcome you all to this Roscon 2022. I am to introduce Dr. Kamlesh Kilnani. Photo. Here is Dr. Kamlesh Kilnani, who will be taking over today as the new president of the Roscon Ophthalmic Society. He has retired as a professor in head department of ophthalmology from SMS Medical College, Jaipur. He passed his MBBS and MD from SMS Medical College, Jaipur. And in 1989, he joined as assistant professor at SMS Medical College, Jaipur, and promoted as professor in 2009. During his tenure at SMS Medical College, he helped to establish Vitro Retinal Services, which is today one of the best in the government sector in North India. He has more than 40 scientific papers published in international and national journals. He has served as Treasurer ROS, Secretary JOS, and Jaipur Ophthalmic Society, and President of Jaipur Ophthalmic Society at various time periods. His wife, Dr. Meena Kilnani, is a consultant pediatrician, and they are having the 3 children. Presently, he is working as senior consultant at Many Lake Hospital, Jaipur. Now, I invite Dr. Kilnani to please come.
Now, this is the time of change over the seats and change over the taken over the responsibility from the outgoing president to the incoming president. ROS has seen an upgrade trend in the tenure of Dr. K.K. Kanjolia, and we look forward that Dr. Kamlesh Kilnani will raise the height of our society to a newer height. Thank you, sir. Please change your seats. Now, this is the time to present the secretary's report, what we have done in last year and during our all tenure of 3 years. Start. So this executive took over in September 2019. And this is our last year of our tenure. And from 17th of October, new executive will take over charge from us. As soon as we took over the charge in September 2019, immediately after 2-3 months, we encountered the most drastic pandemic of COVID-19. बहुत सारी हम लोगों ने तैयारियां की थी कि हम ये करेंगे, लेकिन सिर मुंडाते ही ओले पड़ गए हमारे ऊपर. हम लोग कुछ भी नहीं कर पाए, और फिर भी हम लोगों ने कोशिश की. उस वाला बहुत डिफिकल्ट टाइम था, उसको फेस किया हम लोगों ने. सब लोग घरों में कैद हो गए थे. सैनिटाइजर्स की बहुत कमी थी, मास्क की बहुत कमी थी, बहुत सारी प्रॉब्लम्स आ रही थी हमारे मेंबर्स को भी एंड टू द सोसाइटी आल्सो. सो when we were at home, we continued our relief work. We created a fund of with the permission of the executive body, we created a fund of 10 lakh rupees for the COVID relief fund, and from that fund we distributed our such COVID essential items like sanitizer, mask, everything to our needy our members through the our affiliated district societies. So that was of great help at that time. मुझे अभी भी याद है कि उस समय सब कुछ बंद था. मतलब कुरियर वाला घर पे सामान देने नहीं आता था. दिल्ली से हम लोग मास्क मंगाते थे, सैनिटाइजर मंगाते थे, बहुत सारी चीजें मंगाते थे, और मुझे खुद जाके अपनी गाड़ी में उनके ऑफिस से लेकर आनी पड़ती थी. देन एक सेंट्रल प्लेस में ले जाके मैं बैठता था, और वहां पे मैं इनवाइट करता था अपने मेंबर्स को कि आके मुझसे ले जाएं. So that we saw a very difficult time. but with the help of everyone, we could overcome that bad time. We lost many of our members in that era. That is the very bad experience. They are near and dear also. So, we hope that we should not face such time in our rest of the time. We started online scientific activities during that time. We conducted various online webinars, scientific webinars, as well as for the interest of the our members, financial matters also. In our tenure, I did a very tedious work of website updation. Our website was practically not working properly, so I made the website dynamic. Members can view their profile and can upload their details of their own. New members can join online. Everything was made online, online payment, online joining. And in COVID times, all guidelines issued by the Government of India, ICMR, ROS, AIOS, and other agencies were uploaded in real time. Academic videos, CMEs, awareness PPTs were uploaded. Members directory can be viewed now, up to date. Minutes of GBM from 2003 onwards were uploaded. That was a very tedious work. And constitution can be viewed online, and online nomination, withdrawal, all election process, everything what can be done online, I try to make it online only, to make the everything transparent. ड्यूरिंग दैट कोविड टाइम घर में बैठा हुआ था, खाली था, टाइम नहीं होता था, फिर मैंने मेंबरशिप लिस्ट देखनी चालू की, तो मुझे लगा इसमें बहुत सारी डिस्क्रिपेंसीज हैं. एक ही मेंबरशिप नंबर कुछ मेंबर्स को दो तीन मेंबर्स को अलॉटेड था, तो वो सारा बैठ के मैंने उन 2-3 महीनों में उनको पूरा स्क्रूटनाइज किया. आई ट्राई टू स्ट्रीमलाइन दैट मेंबरशिप and new membership certificates, new membership new membership numbers were allotted to members. New membership certificates were sent to all ROS members at that time, and smart cards, RFID cards, which AIOS is printing now and sending to the members. I have sent last year also to all our members. Those who have sent their photos, those who did not send their photo, their cards are still pending. And with the inspiration of Dr. R.K. Sharma, our past president, we distributed 18 indirect ophthalmoscope to PG teaching institution for benefit of our residents only. Financials of the society, Dr. Pratul Tyagi ने बहुत हार्ड वर्क किया इसकी financials को strong करने के लिए. When we took over 3 years back, we had a FDR of rupees 1,78 lakhs only, and with a bank balance of 34,34,000. Now with the efficient financial management of Dr. Pratul Tyagi, now the FDR, we have FDR worth of 2,83 lakhs, almost 1 crore increment, and with a bank balance of 33,10,000 at present. And all FDRs are now at one place. 3 years. Now all FDRs, when we took over, all FDRs were in, some were in Kota branch, some were in Adarsh Nagar branch, some were in other branches. So I welcome Dr. Vijay Sardana. He is principal and controller of Medical College, Kota. I request Dr. Kedawat sir to welcome Dr. Sardana by floral welcome, and Dr. Ashok Meena also. Thanks, Dr. Sardana, for sparing time for us. So, continuation of the financials of the society. So now all FDRs are at one place, one branch for the smooth working. Our Dynamics Chairman Scientific Committee did a wonderful job. He will present his what he has done for the society in last 3 years and is still doing. And he organized many online webinars in COVID era and excellent scientific program in Roscon 2021 and Roscon 2021 now. ROS Journal, Dr. Suresh Kumar Pandey from Kota did excellent work in releasing ROS Journal 2021 and now the latest version of 2022 with the excellent design, excellent material, excellent printing quality. This is at par with any of the good reputed journal of the Indian ophthalmology. Thank you, Dr. Pandey. We have, as a tradition, we celebrate national functions in a group. So on the banner of ROS, we celebrated Independence Day function, Republic Day function, and in the Eye Bank Society of Rajasthan Kota chapter, we did the felicitation of eye donor families on 28th August of 2022 now. Dr. Kanjolia and his team has felicitated almost more than 98 donors, families of eye donors. This is some glimpses of our organization. I would like to thank each and every member of our executive committee, especially Dr. K.K. Kanjolia, Dr. R.K. Sharma, immediate past president, Dr. Kamlesh Khilnani, Dr. Sanjeev Desai, all my Harshul, Suresh, Pratul, all my executive members who have believed blindly on me. जो मैंने कहा, जैसे जैसे मैंने कहा, उन्होंने कहा यस बॉस करो, हम सब आपके साथ हैं. सो आई एम तहे दिल से उन सभी का शुक्रिया. उम्मीद करता हूँ आगे भी उनका साथ इसी तरह का विश्वास मेरे को मिलता रहेगा. थैंक यू वेरी मच एंड welcome to the new executive who will take over to the on 17th of October and will, I expect that they will raise the ROS flag high. Thank you very much. Now I request Professor Kamlesh Khilnani sir, new president, for his address.
Respected Dr. Amulya Sahu, founding chairman of SMIT, chief guest of this evening, Dr. Partha Biswas, chairman scientific committee, AIOS, guest of honor, Dr. Vijay Sardana, principal Kota Medical College, guest of honor, Dr. K.K. Kanjolia, President, Rajasthan Ophthalmological Society, Dr. Sandeep Vijay, Secretary ROS, Local Organizing Committee, Dr. Kamlesh Kedawat, Dr. Suresh Pandey, Dr. Sanjay Gupta, and Dr. Ashok Meena. Invited guests, faculty, ladies and gentlemen. A warm good evening to all of you. At the outset, I would like to thank all of you for the confidence bestowed on me to making me the president of ROS. I assure you that I will work to best of my abilities to uphold the great tradition set by my presidents. All past presidents have worked hard to bring the ROS to this platform. My special thanks to Dr. K.K. Kanjolia Sahab, who has always been a gentle, has always guided us and led this ROS in a very mature and dignified way. I will also like to thank Sandeep Vijay I have seen him closely working for last 3 years. His meticulous working, as he has told, has streamlined the ROS. He has made the cards, he has distributed the membership forms, and he has in-depth knowledge how the system works, how the conference are upheld, are run, and how the ROS should be managed. I think he should be given a special thanks for each and every one. In this sequence, Dr. Harshul is always dynamic, always dedicated, and so is the Pratul Tyagi. What pleases me, these all youngsters, there are many who are sitting in front of me, many may not be here. They are all energetic, they are all focused, and they are all result oriented. And what pleases me is, apart from their dedication, as this has been the tradition of the Rajasthan ophthalmology, they all work in a very honest way. You take the example of AIOS, this AIOS, the previous AIOS, we are the one who has saved crores of rupees on these conferences. Dr. Virender is here. I must congratulate him for that gesture. I shall be my primary duty to look after the interest of each and every member of ROS. I shall take every word, help of everyone, and I should be entirely guided by the constitution of the ROS. That should be my Bible, then that should be my Gita, whatever you say. Now, our society is nearly 5 decades old. Time is changing very fast. When I was joining ophthalmology as a postgraduate in early 1980, our country was economy was about $200 billion. Today we are $3.5 trillion and inching towards the $5 trillion in, say, coming 3 to 4 years. Things are changing very fast. At that time, there were 80 medical government college, largely in government sector. They were the tertiary centers, they were the referral centers. Now today, the private sector has come in a large way, doing excellent work in each and every field, in providing healthcare, in the medical education, and even in the lot of innovations. We thought that we are moving towards a liberalized way, and then the things started changing slowly. With the government schemes, with TPA, we are again finding that we are guided by external factors. The ROS must unite, must raise our voice, remains united, that our voices may be heard in the various forums in formulating the government policy, the issues regarding TPAs, the issues regarding fixation of rate for the diagnostic procedure, and the issue regarding the fixation of the surgical procedure. Now, we have got immense talent in ROS. Some of them are able to show their talent here at ROS. And it's an open platform. Anybody can come, can join, and show his or her work. But what I find that there are many excellent surgeons working at a smaller places, are doing a solo practice with their limited resources, but doing very fine work. I don't find them here inside the auditorium, inside the hall, showing their work, showing their surgical excellence. I will request all of the members, and I will try my level best to bring this hidden talent in the forefront so they can also be recognized, so they can also be contribute. One thing which has been close to my heart is always been the teaching, the postgraduate teaching. When I was with SMS Medical College, that is the one area which I was always focused. Today, as I said, that things are changing. Today we have about 100 postgraduates doing MD courses or DNB courses. Now, challenge before us is immense. Either we prepare a half-cooked, half-baked professionals, these MD doctors, or we produce who are well trained in surgical procedure, in diagnostic, and those who can stand on their feet. There are various studies has been done, and they show that results are rather dismal. Only 20% of those who are complete their 3 years course can perform the standard ophthalmic surgery. Can we do anything about it? Can ROS has the power to do anything about it? There are some excellent centers giving excellent exposure to the student, but there are some other places where surgical exposure is not given. We are basically a surgical branch. So I will request all of those concerned to please utilize these 3 years of their residency, cultivate the art of learning, cultivate the scientific temper, so that reflects in their future endeavor. We find them inside the hall, right at when the scientific session begins, rather enjoying somewhere outside. Now, there are so many things, as a president, I can say, our responsibility to the society, our responsibility to the underprivileged, our brothers and sisters. We can focus on many of the emerging health problems, the diabetic retinopathy, the early detection of glaucoma. Lately, I have been seeing as a teacher, rather an epidemic of keratoconus. ROP remains a major challenge to us, and so many other things. We can hold workshop, we can do distribute the teaching material, and whatever we can do, we must do. But I will end with thanks to my wife, Dr. Meena Killani. She's a pediatrician and a source of strength to me. And our children, Shweta, she's a professor of English at a Delhi University. Her husband, Puranjay Singh, our second daughter, Sumegha, and my son, Rohan, who are both IIT graduates and now both are doing in their professional career. With this, I thanks all of them. I thanks Dr. Kanjolia, and my special thanks to LOC for organizing such a beautiful conference. We Rajasthan people are always known for the hospitality we extend to our guests, but this is absolutely fantastic. Thank you very much. Jai Hind.
Thank you, Dr. Khilani, for your encouraging words and your agenda for your tenure. ROS has the tradition of felicitating our members, senior members who have done so many things for the society upliftment, for the people benefit. So we confer Lifetime Achievement Award for their recognition of their work. This time, committee of 3 past president recommended name of Dr. Mahesh Punjabi. Good thing is that Dr. Mahesh Punjabi belongs to Kota also. Dr. Mahesh Punjabi. I'll read a brief biodata of Dr. Mahesh Punjabi. Dr. Mahesh Punjabi is the Director and Chief Eye Surgeon of Kota Eye Hospital and Research Foundation, Kota. He has done his MBBS and MS from the SMS Medical College, Jaipur. And he did his 4 years work in Sai Hospital and Research Center, Jaipur. After that, he went to Libya and India. He established in 1987 Kota Eye Hospital and Research Foundation. Traveled all over the world, and he is pioneer in phacoemulsification and microsurgery. He demonstrated live surgery by phaco technique in phacoemulsification workshop. In 2003, Dr. Punjabi invited in Nairobi for teaching of phacoemulsification to the local eye surgeons. He has been involved in teaching work of diploma in ophthalmic technique courses since 1989. He presented various papers in AIOS conferences, IRSI conference, and various state level conferences. He has been involved in eye donation and corneal transplant work started in Kota city only. He has been the chairman of Eye Project, Rotary Club Kota. He was ex-president of Rajasthan Ophthalmological Society. He was ex-secretary of Rajasthan Ophthalmological Society. He was ex-president of Kota Division Ophthalmological Society. And he was co-chairman in Avoidable Blindness Rotary International District 3050. He had various, he has membership of various national and international organizations. And he has fellowship of Federation of Ophthalmic Research and Education Center and Contact Lens Foundation. He has received district award for performing maximum number of cataract operation in Kota district 1995 by Government of Rajasthan. He received Karm Yogi 1995 award from Karm Yogi Seva Samiti for performing best community award in Kota. He awarded gold medal by India Intraocular Implant Society, Pune in 2000. So this is the best, the committee recommended his name to Lifetime Achievement Award to be conferred to Dr. Mahesh Punjabi. I request Dr. Mahesh Punjabi to be on the dais to be felicitated. Dr. Mahesh Punjabi. Dr. Pratul Tyagi, please. I request Dr. Kamlesh Khilnani and Dr. Kanjolia sir to welcome Dr. Mahesh Punjabi. Now I will read out the Lifetime Achievement Award citation. Rajasthan Ophthalmological Society. Lifetime Achievement Award is awarded to Dr. Mahesh Punjabi for his pioneering work in bringing eye care to the doorstep of the poor. His organization skills in conducting ROS conferences, eye camps, etc. as a provider of state-of-the-art services in the field of ophthalmology for the people of Rajasthan, especially of Kota, and in various roles in the Rajasthan Ophthalmological Society. This certificate is conferred to Dr. Mahesh Punjabi at 44th annual meeting of Rajasthan Ophthalmological Society, signed by Dr. K.K. Kanjolia, Dr. Sandeep Vijay. I request our President, Sir, Dr. Kanjolia, Sir, Dr. Amulya Sahu, to please. I request Dr. Mahesh Punjabi, sir, to address us few words. Dr. Mahesh Punjabi.
Once again, good evening. Dignitaries on the dais, respected senior members, friends of my age, and all the young generation ophthalmologists. It's a proud moment for me and for my family. I am thankful to our society for nominating my name for the Lifetime Achievement Awards. It has always been an honor to be a part of the ROS Society, especially thanks to my teachers, colleagues, and juniors for their constant support. Thanks to my patients, those who have confided in me for their eye care. I am thankful to my better part, Dr. Sandhya, for standing with me shoulder to shoulder throughout the years. आप मेरे से पूछेंगे लाइफ टाइम अचीवमेंट अवार्ड ऑप्थोलॉजी में करियर बनाने के बाद हुआ या पहले से ही चल रहा है? इफ यू आस्क मी, इट स्टार्ट्स फ्रॉम योर चाइल्डहुड, योर स्कूलिंग, योर कॉलेज, योर कंपेनियंस एंड योर सोसाइटी. तो वो जो पाथ आगे तक जा रहा है, वट एवर योर डेस्टिनी, इट स्टार्ट्स फ्रॉम योर अर्ली लाइफ. And it is the He who gave you the path कि इस रास्ते पर आपको जाना है, उस पर पहुंचना है. आप कोई भी काम करते हैं तो पहले जो मन में इच्छा जागृत होती है वो भी तब होती है जब वो कोई ऊपर वाला आपको बता रहा है. So, as I told, the Lifetime Achievement Award stands for Ophthalmic Fraternity and Community Service. But even it begins in your schooling year also. And for the Ophthalmic Society, it is your work, academic work, teaching work, and leadership role. Now, this is the history, how we have started our all functioning. So you can see our, this is the old building, then the camp work and all the surgical work. These are the achievement of our hospital, or you can say for my work, and everything is there. These are the milestones. So how we progress. Whatever telling me today, I am telling you, especially for the new generation, how they should proceed in the life. Because it's not a job of one day. आपको बहुत धीरे धीरे एक्सपर्टाइज करनी है और ऑनेस्टली एंड एथिकली and you have to keep the integrity itself. This is what we stand today. Now, what is the take-home message? You are a representative for the medical profession, ensuring your professional behavior matches and the expectations the public hold of you. Start as you mean to go on, developing an honest attitude to your work and demonstrating integrity as a medical student will translate the good medical practice as a qualified doctor. Even though there may be an easier option, but it is always best to offer an apology, explain the situation and the work with your colleagues in the managing complex situation involving errors. One more thing I want to tell, that never criticize for your in front of your patients about any of your colleagues. That's very important. Then we should have a brotherly environment in our practice. Now you can see what my son has said to me, because he has operated on my both eyes. So whatever the take-home message is, whatever you are doing, or rather whatever your profession, say our profession in ophthalmology as a doctor, but you have to keep all your life integrity, honesty and ethics of your profession. And I am once again very much thankful to the society for confirming this award. I am thankful to all the dignitaries who are present here and all the audience. Thank you very much.
Thank you, Dr. Punjabi. I would request each and everyone to give a standing ovation to Dr. Mahesh Punjabi for his achievement. Now I invite.
बेटर हाफ को समर्पित करने जा रहा हूं. Because without her support, कुछ नहीं हो सकता था.
Now I invite Dr. Harshul Tak, our Chairman Scientific Committee, for the further proceeding of the program.
Thank you very much, Dr. Sandeep, and all the respected dignitaries on the dais, respected seniors and all our ROS members. On behalf of Scientific Committee of Roscon Ophthalmic Society, once again, I thank all of you for contributing actively to all the scientific activities of Rajasthan Ophthalmic Society for past 3 years. So my tenure is also going to finish in 2 days. And I'm very thankful to our president, our secretary and entire executive committee for giving all their blessings for all the programs which we crafted for our members. So this year we did a lot of webinars. Apart from the physical meetings, like we had very nice midterm meeting in Pushkar, which was attended by more than 150 members of ROS. And we had 2 PG teaching program, which are backbone of ROS. And we do for upgradation of the PG teaching in Rajasthan. First program we had in Jaipur, that was the IGO program, Publish and Flourish, to make all the youngsters aware that how they can publish and flourish in their life, which was attended by more than 80 PGs of Rajasthan. And second PG teaching program we had recently in Ajmer Medical College, organized by Dr. Rakesh Porwal, and we had more than 100 PGs from Rajasthan attending that program, and that program was focused on cornea and refractive surgery. We had a very nice faculty from LU Prasad Eye Institute for that program. And in this conference, we have our national faculty, which are very renowned in their field. And if I talk of the submissions, we have more than 50 e-posters. We have more than 40 non-competitive ROS papers, free papers, and more than 30 residents and different papers in various categories and videos. And today morning, we witnessed amazing live surgery transmission from Suvi Eye Hospital, very nicely organized by Dr. Pandey and the entire Kota Divisional Ophthalmic Society. Thank you very much. And this live surgery was streamed live on YouTube, also on Facebook and various platforms. So after this, we'll be giving away some of the scientific awards of the last year. So the first award is Best Paper in the resident category. I'll request you to please get all the gold medals here. All gold medals, yeah. So I'll request our chief guest, Dr. Amulya Sahu, Dr. Partha Viswas, who is Chairman, Scientific Committee of AIOS, and Dr. Vijay Sardana to please come forward and give away the awards. And also our President, Dr. Kamlesh Khilani, sir, new President. Idhar laiye. So first is the best paper in resident category that goes to Dr. Priyanka Saini. The second was Dr. Surya Narayan Gold Medal Award for Best Video in Competitive category, and that went to Dr. Rajesh Goel of SMS Medical College. I'll request Dr. Ankur Midda to please collect medal on his behalf. So Dr. Rajesh was also part of the winner team in the Rajasthan Ophthalmic Premier League. So Jodhpur Jaguars were the winners. So I'll request him to collect that medal also for Dr. Rajesh Goel. And the next is Best E-Poster, which was awarded to Dr. Rolika Bansal. And the next was Dr. Shurveer Singh Gargi Devi Gold Medal Award for Best Paper in Competitive Young Ophthalmologist category less than 40 years. And that was awarded to Dr. Karishma Goel. I'll request Dr. R.B. Goel, her father-in-law, to please collect on her behalf. I'll request Dr. Partha Viswas to give away this medal. So we have Rajasthan Ophthalmic Premier League. So the winners of last year were Jodhpur Jaguars. So two of the faculty were Dr. Rajendra Prasad and Dr. Janin Patel. So I'll request Dr. Saurabh Luthra to collect on behalf, or Dr. Ajay Arora to collect on behalf of Dr. Rajendra Prasad, because he's from Delhi. Yes. कोई नहीं. And one medal is of Dr. Janin Patel. I'll request Dr. Sheetal, who is here, friend of Dr. Janin, to collect on her behalf. So our guest faculty is backbone of our scientific program, and we are thankful to all the guest faculty who have come all the way to attend this 44th annual conference. And it's our tradition to welcome and felicitate all our guest faculty with a memento and a turban. So I'll request the dignitaries to please felicitate Dr. Ajay Arora, who is a renowned veterinary surgeon from Delhi. We all know him. Right now, he is joint treasurer of AIOS. And I'll request the dignitaries to please felicitate Dr. Ajay Arora. This plaque. Memento, please. Yeah. I'll invite Dr. Sheetal Mahukar Mehta from Ahmedabad. She's a prolific cataract, corneal, and refractive surgeon from Ahmedabad. Dr. Sheetal. I'll invite Dr. Saurabh Luthra, who has come all the way from Bilaspur. We witnessed a wonderful live surgery from Dr. Saurabh Luthra. I'll request dignitaries to please felicitate. Okay. Then we have Dr. Nupur Goyal, who is from New Delhi, who has passed out from our own SMS Medical College, and a wonderful surgeon. She's accompanied by her daughter, Varunika. Welcome. Good exercise, yeah. Then we have Dr. Gunjan Buddhiraja, who is also from Delhi. I'll request all the dignitaries to please felicitate Dr. Gunjan. And I'll request Dr. Khilani sir and Dr. Vijay Sardana sir to please give a memento to Dr. Amulya Sahu sir. Thank you so much, sir. Thank you. Over to you, Dr. Sandeep.
I request all the dignitaries to unveil the ROS Journal 2022, as well as Directory of the Rajasthan Ophthalmological Society 2022 version. In continuation of providing indirect ophthalmological scopes to the different medical colleges, I request Dr. R.B. Goel to come to the dais to receive indirect ophthalmoscope for residents. He is professor and head of American Medical College, Udaipur. Now I request Dr. Vidushi to continue the program. Thank you very much.
Thank you, Dr. Sandeep. And continuing further, it is now my privilege to invite Dr. Vijay Sardana, our most dynamic principal and controller of Kota Medical College, also one of the leading lights of the city, an excellent orator as well as singer, to please inspire us with his words. Dr. Vijay Sardana, sir.
Chief guest of today's inaugural evening, Dr. Amulya, guest of honor, President, past and President-elect of Rajasthan Ophthalmic Society, secretaries, organizing chairman and organizing secretary of this 44th Rajasthan Ophthalmic Society Conference. I'm delighted to be here, and I hope that all of you must be enjoying this conference after 2 years of COVID, where physical conferences were virtually not happening. I have always seen ophthalmology as one of the very fascinating branch, right from my undergraduate days. Why fascinating? Because sometimes the choice of whether a particular branch is fascinating or not depends on your teachers. And that is one of the main reasons for many of you to choose a particular branch as your career. Though I did not choose ophthalmology, but I was fortunate to be taught by one of the teachers. I think all of you know him, Dr. M.R. Jain. He was at Jodhpur that time from Udaipur for a short period for maybe 2-3 years. And we were in final MBBS that time. And whatever he taught, we never consulted any book for that. And we used to read only that and only that. There are very few teachers who qualify for such a great thing. Those days, ophthalmology department was a small department with 3 faculty members. One, Dr. Mehrotra figures as first in your directory. I was just looking at it. He was also our teacher. And routine things were being done there. As the years have passed, ophthalmology has taken a very great shape. And there are very few branches which have grown out of proportion to time. I think ophthalmology is one of them. There's a lot of technology involved in ophthalmology, and that is, I think, one reason why it has grown out of proportion with the time. Those days, everybody used to do general ophthalmology. All consultants used to do cataract surgery also, glaucoma also, anterior chamber, posterior chamber. Nowadays, people have confined themselves, many of you, to a specialized field. Somebody is doing cataract surgery, somebody is doing glaucoma, anterior chamber, posterior chamber, and whatever. Those days, I remember, those days also people used to be focused and hooked to a one particular thing. In 1984, when I was in second MBBS, Dr. M.R. Jain organized a symposium. I still remember, symposium on extra and intraocular tumors. And he invited guest faculty. I was editor of the Wall magazine. I happened to be there and I interviewed one person. I still have his card and still remember his name. He was doctor of one disease only. Even those days, almost 38 years ago, 1984. His name was Akhiro Kaneko. I don't know if you have heard his name or not. If you look at literature, you will definitely find his name. And he was a specialist of retinoblastoma. Retinoblastoma, I used to see only retinoblastoma cases. And such a rare disease, 1 in 20,000, I think in those days, I don't know what is the incidence now. So I was fortunate to interview him and ask him that what drives him to be disease of one single doctor. He answered that it is my passion, it is my interest. I want to do justice with all those patients who were referred from all over the world to me, patients of retinoblastoma. Gradually, you people are, specifying to the particular field. That's a good thing. There's nothing wrong in it. It happens in all the branches. It is happening in ophthalmology also. You have seen period of COVID where I think ophthalmology was one of the worst affected branch. You had to postpone the routine surgeries, do only the emergency surgeries. But over last 20, 30 years, we have seen a lot of development in ophthalmology. From initially cataract surgery used to be, I think, just lifting the curtain and looking at a glow of light after seeing many dark days. But as the years have passed, people have become more demanding. You people have become more precision result oriented. Now, with biometric, you are measuring length of the eye and precisely doing the pre-op assessment and giving proper lens to the patients. Patients have become more demanding about their vision. There are different type of lens. Gone are the days when they used to wear the thick lenses, presbyopia lenses, toric lenses. Then LASIK, laser, femtosecond LASIK assisted cataract surgery, femtosecond assisted LASIK flaps, your drug delivery systems, compound drug deliveries, NSA, topical, and lot many things have come. Fat suppression MRI, highly resolution MRI to look for orbital pathology, and lot many things have come. So with the help of technology, See, there are many branches, like I am a neurologist. We say that whatever technology comes is ultimately your clinical acumen or clinical skill which matters, which wins ultimately. But I think yours is the branch where technology really helps. It aids in making your clinical opinion and knowledge about the patient and increases your wisdom about the management of a particular patient. It is heartening to see all of you gathering here for conference, for updating the knowledge. And I congratulate Dr. Punjabi, who is a very senior ophthalmological surgeon of the city and the state. I also compliment other ophthalmologists of the city who are not only doing good ophthalmological practice, but also contributing in many other ways to the society. Ophthalmology is one branch where you have the chance of doing community service also, social ophthalmology or community ophthalmology, whatever you say. So, and the incidence of disease, this is one branch where incidence of disease is, enormous. Every living human being is a potential ophthalmological patient. Just like every living female is a potential gynecological or a obstetrical patient, you have a lot of patients. Still, the reach of a common man to consult a qualified ophthalmologist is limited to cities and smaller cities. I think the scenario will change. I hope the knowledge delivery system and the tools have also changed. They are changing with the social media, with the YouTube, with the Facebook live streaming, which we have done today. I think the gap, the divide, which is actually not there, divide between the bigger cities and the smaller cities specialists will reduce, which should be. Any developed country you see, the reputation of a specialist does not depend on how larger the city is, how good the institution is, how good the individual is. I think with the knowledge delivery system fast changing, this divide or this gap will reduce, and all ophthalmologists, wherever they are, will be able to serve the society, will be able to educate their students, their patients in much better way. I thank you for inviting me to be part of this inaugural function. Thank you very much.
Thank you so much, sir, for those words. Next, I would like to invite Dr. Partha Biswas, our guest of honor from Kolkata. With his innovative teaching methods, court-martial, and so many other things, he has traveled all over India, entertained as well as taught so many of us. Dr. Partha Biswas, sir.
Thank you very much, one, for giving me such a huge honor. I'm really humbled. I'm really humbled, and I'm extremely obliged to ROS for this humbling moment in my life. The oration itself, I spoke from my heart when I really thought that what Rajasthan has had to offer to the whole Indian subcontinent. And it is the valor, the courage, and the bravery of this land that I thought I spoke of. When I come to Rajasthan, when I come to Jaipur, Udaipur, or Kota, there are friends everywhere. But the most important thing that struck me, when Jaipur took up the conference at a crisis at AIOS, I was chairman ARC at that time, and the leadership that was there with the ROS team led by Dr. Virendra Agarwal, Sandeep, and the whole team was something that I think AIOS shall ever remember. When I come to Kota, I do think that there are two things that Kota is always proud of. Kota has been a seat of learning for medical education and aspirants of medical education. Kota is that place where kids say, "Mujhe Kota jana hai, mujhe doctor banna hai." So this is the place. But again, if I step back and say that what Kota holds for me, I remember as a postgraduate and after that, whenever I would read an article or a case series or a published paper which had intraocular lenses as its topic, there were two names that would always glare. One name, David Apple, and the other, someone called Suresh Pandey. And when later in life, I realized that this Suresh Pandey was that Suresh Pandey, I really feel so proud. And I'm so proud to have operated in his surgical unit today with all the wonderful facilities, the fantastic team of kids who were seen running everywhere. Yashwant, the guy who assisted me, all attention, and I had Court Marshal Suresh Pandey, and he took it out on me today. He made my Rexes run out today. But I did pull it back. When we think of Rajasthan, we think of ophthalmology, we think of people of ROS becoming leaders of ophthalmology, not nationally, but internationally as well. And people win Rhett Buckler Award, Vishal Agarwal. People get a bow like this from Bob Osher in his challenging case series, Sonu Goel, Harshul Tak. So these are the people who we are proud of nationally and internationally. And I wish to take these names as just examples. I'm sure there are so many. But this is where we need our youngsters who are sitting in the back. We need them now to come in the front. We need them to take up challenges. We need them to go beyond what we have done in our lifetimes. We need them to publish papers, to do research projects, to take Indian ophthalmology beyond Indian ophthalmology to the international forum. This is what we desire. This is what we want. And that is the reason at AIOS, in the ARC or in the scientific committee, we have strived to make it possible for more and more submissions, more and more competition, more and more awards, and to inspire everyone, because this is important that you should not be sitting here in Kota or Udaipur or Jaisalmer. You should be presenting at Chicago, in Paris, in Milan, in Tokyo, all over the world. And we are proud of you. Thank you very much for this great opportunity. I wish you a great, great conference. And it's been an absolute pleasure for me to be here today. Thank you so much.
Thank you, sir, for your words and all that affection for Rajasthan and its people. And now it's my honor and privilege to invite our most respected chief guest, Dr. Amulya Sahu, sir, from Mumbai, to share his wisdom on so many facets of life. He's been sharing it since yesterday, and I'm sure it will be enlightening for all of us.
President, sir, and all the dignitaries on the dais. I don't know why Harshul took out his pagdi. And this pagdi, when I was an undergraduate student, I was representing India in Ceylon as a rover scout. I had the pagdi on my head. So I was going through Tamil Nadu. I came to know our president, Radhakrishnan, is there in his house in Mylapore. So I went to meet him. So I said, let me take this opportunity. And he was gracious enough to give me audience. And he saw my pagdi and said that now you have understood the importance of pagdi. India is now rising. So this word I'm telling you, your pagdi makes me feel so nice. I don't want to take it up. So because this gives you a sense of valor and elation. And its significance is there, you know. In Rajasthan, it was a talwar they were hitting. The pagdi used to save their head, you know. And whenever I see a Rajasthani old man coming to my clinic, I feel so good looking, so much masculinity is there. So it really pleases. And I think the younger generation must go back to their roots and seek this thing which all of us are proud of. You know, the children, we have grown up with the valor of Rajasthan, how they have fought. Rana Pratap is our inspiration. Thousands of years of fighting invaders. It's not a joke. They could have just enjoyed life. They wanted to sacrifice their pleasure to save our heritage. And this is what Rajasthan symbolizes. I think younger generation is now giving up their old habits. Little bit they must go to their root and stick to their roots. It is really full of valor and so much. We sing their song, when they sing their song, when we feel sensation in our body. So here, and few things I will say that science, we have done a lot here, but little bit of few people, few incidences. Virendra Sahuja, I know for a long time, Agarwal, and he was telling that he is one of the most successful ophthalmologists, all of you know. But what I liked about his feeling about his family, he has so much of respect for his wife. He said, because of her, I am here. So that speaks a lot, you know, and she is so spiritually inclined. And Virendra do not have inclination toward this, but he appreciates her. This is what in the family, everybody need not agree with everything. But if they learn how to appreciate others' plus point, it's a wonderful family. I saw Suresh Pandey. He was such a nice person, and I saw he has achieved so much. He have been trying to call me so many times, and where are you there? Come here. These are small gestures. I went to his hospital, and really, I was asking, what is the secret of your success? What I saw is sincerity, hard work, humble, and so many things are factored there. See, all the as Partha said, all of his staffs are really having a quota of emotions. You will find that in America and other things, they are all correct people. They are references on through the head. But in India, we have a feeling quotient that makes us distinguish in the world. Anywhere I learned you New York, you have to pay $1 for a trolley. Now here we don't think we are a rich people within. We are not having economy of 30 trillions, but we have a richness of more than 30 trillions. So that's how our country is rich, because we are rich within. And it's a matter of time we will express our richness outside, because once upon a time we had the 25% of GDP of the world belongs to India. That is why everybody searches for India. They were the Columbus and everybody came searching for India because it was a golden goose. And then the independents came, they loot it. So then the British came with Chalbaji, they wanted to manipulated our divisions and conquered. But they could not suppress us because we are going to be there always. This is the only living civilization in the world. You can have a written history for 14,000 years when Ramayana happened, to 7,500 years before when Mahabharata happened. We have written histories. They wanted to tell it is mythology. No, it is not mythology, it is history. So we can be a lot too proud about. Now they see how India is rising. India is rising not because of the Modi. India is rising because a family is holding together and the family is trying to aspire and teach the children to excel. That is why the country is rising. It is not the Modi. Modi brings a leadership which people believe that he is honest, he is sincere, he is hardworking. That is why everybody is rallying around him. So that day, and now the West is trying, the Marxists are trying, then the left, all them are trying to break the family, bring sort of a Western concept to us, give sort of division, and the way they are trying to break the family, we must be very conscious about. Because now that you see there is a word I'm here that my friend is my son is my friend. This is what kind of nonsense is it? How can a father be a friend to son? It is a friendly father, that's all. The son has to look up to the father. The father must enhance the respect of the institution. He should always be fair, nice, where the son takes pride in looking up to him. The day father becomes friend, then we have started going down. Father is not a friend. Father is an institution which provides the hood. The day the hood is gone, the son is exposed to the harshness, and you can see their behavior. Just take 10 examples of where the parents are failing, how the children behave, and when the parents are holding together, how they excel. So that is the example all of us has to hold together as a family, because it is not a marriage. It is a madhyam marg of self-realization. This is a grastha ashram. We have forgotten the connotation. We have said it is a contract. Now this contract is coming from the West. That is, 10 years, 10 wives. And if one wife you are not satisfied, how can you be happy with another wife? The happiness is within. You give an excuse that my wife is, I am happy because of my wife. No. If you are a happy man, you find a reason. If you are an unhappy man, you find a reason. So that's why, and with one thing I want to say, that start the day with yoga. Yoga karmasu kosalam. If you are 10 times efficient, you will be 100 times more efficient if you start the day with Brahma Muhurt and yoga. Yoga karmasu kosalam. ये बात 1000 साल पहले बोला गया था. It is relevant now. To understand this yoga, only I will tell one example. Please try to see it scientifically. It is not religious. We don't have a religious heritage. We are Veda means to know. To know. It's vid dhatu. It comes from vid dhatu to janna, manna nahi hai. So we are searching all the time. And we are searching for what? Higher meaning to life. Now you say that we must move into from, I have written a book called Journey to Know Thing, poetry book. So this is we are not one, we are four. This is a biological car. It is running by electric current. If I cut this one nerve, it will not function. This is a biological computer. Whatever you feed, you get back. This is a biological air conditioner. If you get tuned it lovingly, then you are driving a school. These are camera. In the morning when you get up, you say, I saw a good dream. Who saw that dream? That is the real you. In Gita says, Yanisha Sarvabhutani Tatra Jagrati Swami. जब सब सोए हुए रहते हैं, जो स्वयं को जान लिया, जगा हुआ रहता है. तो उसको जानने के लिए योगा चाहिए. Patanjali gave 8 steps. Yam, Niyam, Asan, Pranayam, Pratyahar, Dharana, Dhyan, Samadhi. There are other paths also. But try to do yoga. Try to do with understanding. And I'm 100% sure Rajasthan is the valor place and people are excelling everywhere. Marwadis have gone there and they have become billionaires. Now they are giving up that principle. For them, the pagdi was so important. They can give everything to save their pagdi. Now they are doing all sort of therapy. That's why they are going down. If the moment they go back to their roots, they will be again rich. So with this, I say I am going back with lot of respect for these people. And thank you very much for giving me this honor. Thank you.
Thank you so much, sir, for sharing your wisdom, not just about ophthalmology, but about life, yoga, family, and so many other things. And finally, in the true tradition of Atithi Devo Bhav, हम अपने अतिथियों का मोमेंटो भेंट कर और शॉल उड़ाकर सागर सम्मान करना चाहेंगे. And first of all, I would like to invite Dr. Jayashree Singh ma'am and Dr. Vishal Snehi to please present a memento to our chief guest, Dr. Amulya Sahu sir. Dr. Jayashree, Dr. Vishal Snehi, please do the honors. And I would also like to request the dignitaries on the dais. Okay, sorry about the little confusion. We have a symbol of Rajasthani valor, the stump, the Vijay stump, which is situated in Chittorgarh. And this we would like to present to our out of Rajasthan dignitaries. So just a little bit of change of the mementos that we would like to present, because Dr. Vijay Sardana is our very own. So this stump is for our out of Rajasthan dignitaries. Dr. Amulya Sahu, sir, please come forward. Next, I would like to call upon Dr. Shailendra Birla and our Dr. Kamlesh Kedawat, who's on the dais, to present a shawl and memento to Dr. Partha Biswas, sir. And finally, I would like to invite Dr. Chandel and Dr. Sanjay Gupta to present a shawl and memento to our very own Dr. Vijay Sardana, sir. And before we finish, I would now like to invite Dr. Kamlesh Kedawat, sir, our Chief Organizing Secretary, who has been the Captain Cool in all these months leading up to the conference, to present his vote of thanks, the most important part of the day, I suppose.
Most important part is MOC. शिक्षा नगरी कोटा शहर में राजस्थान नेत्र सोसाइटी द्वारा आयोजित 44वें महाअधिवेशन के अवसर पर मंच पर विराजमान आज के मुख्य अतिथि डॉक्टर अमूल्य साहू, अध्यक्षता कर रहे डॉक्टर पार्थ विश्वास, विशिष्ट अतिथि डॉक्टर विजय सरदाना, प्रिंसिपल एंड कंट्रोलर गवर्नमेंट मेडिकल कॉलेज कोटा, आरओएस प्रेसिडेंट डॉक्टर के कंजुले सर, आरओएस सेक्रेटरी डॉक्टर संदीप विजय सर, चेयरमैन साइंटिफिक कमेटी डॉक्टर हर्षुल टाक, ट्रेजरर डॉक्टर प्रतुल त्यागी और एलओसी के मेरे अपने साथी डॉक्टर सुरेश पांडे, डॉक्टर अशोक मीणा एवं डॉक्टर संजय गुप्ता एवं सबसे विशेष आप सभी का वंदन, नमन, अभिनंदन। इस अवसर पर आप सभी की उपस्थिति से मैं हर्षित हूं, आनंदित हूं। कोविड वैश्विक महामारी के बाद इतना भव्य कार्यक्रम कोटा की धरती पर आयोजित होने जा रहा है, जिसमें आप सभी ने अपना अमूल्य समय निकालकर अपनी उपस्थिति दर्ज कराते हुए अपना सहयोग एवं मार्गदर्शन दिया। इसके लिए मैं आप सभी का धन्यवाद प्रार्थी हूं। राजस्थान नेत्र सोसाइटी के पदाधिकारी एवं एलओसी कमेटी के मेरे सभी साथियों एवं कोटा डिवीजन ऑप्थेल्मोलॉजिकल सोसाइटी के सभी सदस्यों का हर पल मुझे पूर्ण सहयोग मिला, जिससे मैं इस चीफ ऑर्गेनाइजिंग सेक्रेटरी ROS 44 की जिम्मेदारी को निभा सका। वो एक चौपाई रामायण की 100 सप्त प्रताप रघुराई, नाथ न कछु मोरी प्रभुताई। हम सभी जानते हैं नेत्र हमारे जीवन में कितने महत्वपूर्ण भूमिका निभाते हैं। सर्वेंद्रियाम नैनम प्रधानम, यानी सभी इंद्रियों में आंखें मुख्य है। आज इस कार्यक्रम के अवसर पर राजस्थान के कोने कोने से यहाँ पधारे सभी ख्यात नाम नेत्र विशेषज्ञ एवं आमंत्रित विषय विशेषज्ञों, जो कि इस कार्यक्रम को सफल बनाने के लिए मुश्किल एवं लंबी यात्रा करके यहाँ आए हैं, मैं उन सभी का तहे दिल से धन्यवाद ज्ञापित करता हूं। हमारे अपने डॉक्टर विजय सरदाना सर का आभारी हूं, जिन्होंने अपने अति व्यस्त शेड्यूल में से हमारे यहाँ आने की कृपा की। मैं इस अवसर पर उपस्थित मीडिया बंधुओं को भी धन्यवाद देता हूं। प्रिंट मीडिया ने इस कार्यक्रम के बारे में समाचार को उचित स्थान देकर आमजन को नेत्रों की बीमारियों एवं उपचार की अत्याधुनिक तकनीक के बारे में अवगत कराया। मेरे परिवारजन, मेरी धर्मपत्नी डॉक्टर अरुणा खंडेलवाल का भी आभारी हूं। उनके सहयोग से मेरे लिए काम करना संभव हो सका। मेरा पुत्र डॉक्टर अनुज और डॉटर डॉक्टर अनुशिका, उनका भी मेरे को सहयोग रहा। अंत में इस कार्यक्रम को सफल बनाने के लिए जो विभिन्न एजेंसीज लगी हुई थी, फार्मा इंडस्ट्रीज, आईओल मैन्युफैक्चरिंग, ऑप्टिकल वाले, इवेंट वाले, कल्चरल प्रोग्राम वाले एंड एवरीवन, सभी को मैं धन्यवाद ज्ञापित करता हूं। लास्ट बट नॉट लिस्ट, एमओसी डॉक्टर विदुषी पांडे, जिन्होंने जयपुर से आके स्पेशली इस प्रोग्राम के लिए, थैंक यू वेरी मच। थैंक यू ऑल।
So once again, thanks to everyone. And now may we please all stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा। विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा। तव शुभ नामे जागे, तव शुभ आशीष मांगे। गाहे तव जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे, जय 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 हे।
So now you're all invited for the dinner. And sir, मैं कोटा की हूँ, जयपुर तो temporary है. So all of you are invited for dinner. Thank you very much, and thank you to all the dignitaries on the dais for their presence.